Otolaryngologists of India, Andhra Pradesh State Conference being held at Geetham Medical College on 8th, 9th and 10th October 2021. On behalf of the organizing committee, I warmly welcome all the stalwarts in the field of ENT and budding ENT surgeons to this esteemed South Zone AOI-APCON 2021. This is a dynamic step in this COVID situation to bring all the ENT fraternity to one place and achieve great purpose through extensive lectures and discussions on various topics of otorhinolaryngology. This is indeed an achievement to conduct a hybrid conference with 180 delegates in person and another 400 delegates following us on online platform. Appropriate arrangements have been made following all COVID protocols for this physical gathering. We, the organizing team, are trying our best to provide a fine experience to our physical and virtual delegates for these 3 days. We have highly anticipated lectures and live surgical demonstrations from eminent and humble masterminds of ENT, which we promise will be nothing less of a feast for the mind. Being organized in this city of destiny, Visakhapatnam, has added to the beauty of this special program. Adding magnificence to this occasion is its venue at this palatial auditorium within the premises of Geetham Institute of Medical Sciences and Research, fondly called as GIMSR. As we have delegates from all over the country, it is a great opportunity for you all to explore the beauty of this city. We are happy to inform the confirmed participation of the surgical equipment dealers in stalls, Kalelkar Surgicals, Santosh Surgicals, Vansari Medicals, Advanced Medisystem, Serval Surgicals, Optofine, Jyoti Burs. The links for the online platform are available and the Wi-Fi details of this hall. The name of the Wi-Fi is Geetham 5GHZ and the password is G capital GITAM $123. It is with great pleasure that I once again welcome you all to the South Zone AOI-APCON 2021 and hope you'll all have a great time. On this note, I would like to introduce Dr. N. Venkatram Reddy Garu, a well-known ENT surgeon from Hyderabad who acquired PG degree from the prestigious Osmania Medical College and worked as a faculty at the 250-bedded Government ENT Hospital, Osmania Medical College, Koti, Hyderabad for 2 decades. Dr. N. Venkatram Reddy Garu is a practicing ENT surgeon for the past 29 years in Hyderabad, had the teaching experience of more than 20 years at Osmania Medical College, Government ENT Hospital, Koti, Hyderabad. He presented more than 35 scientific papers at both state and national levels and won 3 gold medals for the best paper presentation. He published 14 papers both in national and international index journals. Dr. N. Venkatram Reddy Garu was the editorial secretary of IJONS from 2005 to 2012. He delivered many guest orations, moderated many panel discussions, and was the guest speaker for many ENT conferences at national and South Zone level. He served as treasurer and secretary of Association of Otolaryngologists of AP ENT Surgeons Association and governing body member of AOI Hyderabad branch. He is the president of AOI Hyderabad branch for the year 2017-18. His main area of interest is in endoscopic sinus surgery and anterior skull base surgery and endoscopic ear surgery. He has large series of endoscopic excision of JNA, inverted papillomas, and pediatric DCR and CSF rhinorrhea repair, etc. He is the organizing secretary for the 14th Asia, Oceania, ORL and HNS Congress and 71st AOICON 2019 at Hyderabad. We are indeed very happy to have such a mastermind to start today's grand session with the imaging of the PNS and the anterior skull base. Thank you. Sir, over to you, Dr. N. Venkatram Reddy Garu.
Thank you for the introduction. So nice introduction. Am I audible now? Hello? Very clear? Hello? Can I go ahead now? Yeah. At the outset, I would like to thank the organizing committee of South Zone and the Vizag branch of ENT Surgeons Association for organizing this South Zone conference in the midst of COVID. And they're doing a great job. I appreciate and a great tribute to the organizing committee for taking this particular step of the online presentations as well as the physical presentations, which is a unique in its type. So thanks for giving me the opportunity of giving me an opportunity as an opening batsman of South Zone in the like a T20 match. I think I have a lot of slides because this is a place where it's a day-to-day. It's very useful in a day-to-day practice for every ENT surgeon. So I just go like a little faster so that I can pick it up because it's a very common topic which every ENT surgeon is acquainted with. Uh, the imaging at the age old is a three types of X-rays which are deleted or outdated nowadays and have a little role. And you have a CT scan which is a gold standard, and MRI is assuming a lot of importance of late in imaging the anterior skull base and then paranasal sinuses. And this is a great disadvantage. We are no more doing any X-rays. The CT-PNS is a gold standard investigation because the single reason that the bone, the soft tissue, and the air are displayed simultaneously. That is why this is a very gold standard for imaging the sinuses. And then it is a choice investigation just because it not only gives a roadmap for our endoscopic sinus surgery, but also it pinpoints the site of obstruction, it gives the extent of pathology and disease, and it gives the rough approach whether I can approach endoscopically or there is a need for external approach. Where else you diagnose a case of dentigeresis? A dentigeresis straight away will be diagnosed in the CT scan. There is no investigation. Diagnostic endoscopy doesn't reveal anything. And also the fibrous dysplasia and osteoma. This is an investigation of choice. Whenever you are suspecting, you straight away the diagnosis. And no other modality can provide a diagnosis. And a CT scan is a gold standard for this. Then the CT scan is usually done for a better visualization and understanding. A multi-planar CT with a 3D reconstruction is the choice. So the axial, coronal, and the sagittal cuts are necessary to define the accurate pathology. And uh, defining the pathology with the latest DICOM viewer is a choice. The DICOM viewer gives the 3D assessment of the disease as well as the anatomy and pathology of the anterior skull base and sinuses. See, this is the image guided system wherein a tracker is used. You can see the tracker is in the optic now, and you can just correlate the same pathology, same anatomy over the axial, the coronal, and parasagittal cuts. This is there over the optic now, the tracker. And similarly, this is in the opticocarotid groove. Here, you can see the exact pinpoint where you are. So this is very useful, the image guided system with a 3D reconstruction of the CT scan, and the tracker system is the most important for a revision case or in case of distorted anatomy, especially in revision cases as well as any tumor pathology. The same thing here, the tracker is placed over the anterior wall of the sphenoid sinus, just over just below the ostium. You can see the pinpoint. So we can correlate with the DICOM software and the tracker system with the image guided surgery. Now, the skull base, defining skull base long ago by Kiros into three types. I think one should get familiarized with the type 1, type 2, and type 3, depending upon the depth of olfactory fossa and height of lamina lateralis. And this is of utmost importance because a type 3, which is a very low skull base, you can see in this CT scan, the low skull base with a polyposis on the left side. So this is more vulnerable for injury to the anterior skull base, especially the lamina cribrosa or the lamina lateralis. Now this is the frontal anatomy. You can see frontal sinus has got a varied anatomy like a gutter-like pneumatization, the forlateral pneumatization, and again deep into the frontal lobe pneumatization. There's so many variations. This looks like a third frontal sinus. We'll come to know. And this is, you can see here, this is the posterior ethmoids, which are larger cells. And what is this? This is the frontal sinus. The frontal sinus pneumatization is extending beyond or up to the level of the posterior ethmoid sinus. So this is a far beyond and far behind pneumatization of the frontal sinus up to the level of the posterior ethmoids. And this is you can see this is the cell with the intersinus septal cell. Some people refer to this as the third frontal sinus. And this intersinus septal cell will open either of the frontal sinuses or both the frontal sinuses. Now, you can see this is a midline frontal cell. This is a midline frontal cell, very large frontal cell, and you are supposed to dissect from anterior to posterior, not the posterior to anterior. Because if you dissect from posterior to anterior, like agar-Neji cell, and you are likely to enter the cranium. Now, all the cells in the frontal recess are the frontal cells, and depending upon its location, if it is a single cell, it is type 1 frontal cell, which is described by the Kuhn, and this single cell which lies below the floor of the frontal sinus. You can see this is the floor of the frontal sinus, and type 2 is the multiple cells which again lies below the level of floor of the frontal sinus. And type 3 is which extends into 1/3 of the frontal sinus, height of the frontal sinus, its lower part is a type 3 cell, and type 4 is the isolated cell within the frontal sinus, which extends beyond half of the frontal sinus. So the type 4 cell is a very difficult to cell that can be tackled or removed. Now, I think this is agar cell. Now you can see this anatomy. This is a large agar-Neji cell which is there, and here it is the large frontal bular cell. The bulla which extends into the frontal recess, the frontal bular cell, and the agar-Neji cell is to be dissected from posterior to anterior, whereas this frontal bular cell, you have to go from anterior to posterior to respect the skull base. Otherwise, if you dissect the similar way as agar, then you are likely to enter the orbit. This is an esolacrimal duct. These are all familiar: anterior artery, concha, and this is paradoxical and concha bullosa. I think this everybody is familiar. I just and this is most important radiologically is the hypoplastic maxillary sinus. When do you say there is a hypoplastic maxillary sinus radiologically? You draw a line from medial orbital wall vertically like this. If the medial wall of the sinus is lateral to the line drawn from the medial orbital wall, then it is called the hypoplastic maxillary sinus. Whenever there is hypoplastic maxillary sinus, you have to be very careful in doing unsplenectomy and doing middle medullary antrostomy, because you are likely to enter the orbit very easily. And whenever there is a hypoplastic maxillary sinus, as you can see in this CT picture, the maxillary sinus assumes the oval shape, and there is an absence of pneumatization below the level of nasal floor. This is a characteristic feature of the radiological identification of the hypoplastic maxillary sinus. Now, this is the septation within the maxillary sinus. You can see here. Now, the halar cell is nothing but the inferior extension of the bulla. It is called infraorbital cell or halar cell, which constitute about 10% in the population. Bulla, of course, anatomy. This is a basal lamella. It's a basal lamella which can extend posteriorly and enter into the orbit or the medial wall of the maxillary sinus. Here it is going and entering into medial maxillary wall, and here it is attaching itself to the lamina. Now, coming to the Onodi cell, radiologically, the Onodi cell, originally the Onodi is an anatomist from Hungary. He described 34 types of Onodi cells microscopically. And the Stamberger is the person who actually described the Onodi cell during endoscopic dissection. He defined the Onodi cell as any cell which extends 1.5 centimeters beyond the anterior wall of the sphenoid sinus is the onodic cell. And it is as close as 0.5 millimeters to the optic nerve. And there is increased incidence of onodi cells in Asian population. Am I audible, please? Hello? Any moderator? Am I audible? Am I audible? Hello?
Yes, sir.
Is it? Am I able to? Are you able to hear me?
Yes, sir. Yes, sir. You're audible, sir.
Yeah. Okay. Okay. So depending upon the relationship with the annulus of Zinn and optic nerve, the onodi cells are divided radiologically as indirect onodi or a direct onodi. What do you mean by indirect onodi? Whenever there is a posterior ethmoidal cell ends anterior to the annulus of Zinn, it is indirect onodi. It's very safe. The direct onodi is one where the posterior ethmoid extends beyond the annulus of Zinn and with no visible optic nerve bulge is direct onodi negative. This is relatively safe. And then a indirect, and a direct onodi cell is one which has a optic nerve bulge into the ethmoid. The direct onodi positive is very dangerous endoscopically, and this can be easily identified in the CT scan. I'll just show you the next pictures. How to identify the onodi cell? I think everybody is familiar. Whenever you see a horizontal septation in the upper part of the sphenoid sinus, so this is the right sphenoid, left sphenoid is the onodi cell. This is a horizontal septation. Coronal cut. Now, these are the two onodi cells, and there is a visible optic nerve bulge. It's a direct onodi positive, both sides. These are the sphenoid sinuses. Is it clear now? Yeah. Again, this is the onodi, direct onodi positive. There's a two onodi cells, and this is the large sphenoid sinus. And you can see the optic nerve bulge in the upper part of onodi. It is popping into the roof, in the roof of the onodi cell, whereas here it is popping and just looking at the lateral wall of the onodi on the opposite side. Now the sphenoid sinus, I think everybody is aware of sphenoid sinus, and these are the three different types of sphenoid and incidents. I think you can know in any. The sphenoid is one of the most variable sinus. And optic nerve bulge. This is the intersphenoid septum getting attached to the carotid artery. Now, a word about cone beam CT. A cone beam CT is compact. Shape. Hello, there is a disturbance. Somebody is talking. Hello. A cone beam CT is a compact and safe and faster version of CT scan with the 3D images, and it has a very less radiation exposure, at least 1/100th of the regular CT scan, and it takes less than a minute to get the images. Now, the imaging of the paranasal sinuses with the MR is getting more and more prominent. And what are the usual guidelines and usual indications of MRI in imaging the sinuses? Number one is that whenever you face a diagnostic dilemma on the CT scan, you can go for MRI. Then a disease extending beyond the confines of sinuses, like it extends into orbit and skull base, you can go for MRI. All sinonasal tumors, yes, MRI is indicated. All immune suppressed hosts, so MRI has a better, and it scores over the CT scan. And post-op complications, when you have a FES post-operative complications like orbital complications, injury to the optic nerve, or a skull base injury, then you can go for MRI. These are the general guidelines and general indications of MRI apart from CT scan in the imaging of the paranasal sinuses. Now, let us move to a common situations in our ENT practice. So where we can do a MRI and where we can do a CT scan, or both can be done in our routine practice, which has a more advantages over each other, or sometimes both are complementary to each other. So we'll now proceed to some of the common situations where the CT and MR, what is the role? Now, the common, one of the common situations is the anthropoanal polyp. In anthropoanal polyp, the preferred method of imaging modality of sinuses is the CT scan. The CT scan shows a smooth enlargement, sometimes lobulations, with no bone destruction, and there is a wide os, wide maxillary sinus os. So this is a pathognomonic. The CT scan has a better is a better imaging modality for the diagnosis of anthropoanal polyp. If you take MR, the same thing, in a T1 weighted image, a low or intermediate signal, in T2 weighted image, a homogeneous signal. So these are all variable because of the water content within the anthropoanal polyp. So the MRI has a variable in the imaging, whereas CT scan has a consistent in the diagnosing anthropoanal polyp. Now, the inverted papilloma, these are the CT pictures. So a ballooning opacity lesion, you can see the ballooning opacity lesion with a hyperostosis is the pathognomonic in the CT scan. So this is a hyperostosis, and you can see the ballooning opacity just like a AC polyp. But if you have a hyperostosis, then certainly you can diagnose the CT scan. So what is the advantage of the MRI over the CT scan in diagnosing inverted papilloma? So in inverted papilloma, I think MRI scores over the CT scan. So it gives a very classical picture of CCP pattern. It's called convoluted cerebriform pattern. Convoluted cerebriform pattern, which clearly described as alternating bands of hypo and hyper waves. So these are the alternating bands of hypo and hyper waves throughout is a pathognomonic of the inverted papilloma in MRI. I think whenever you suspect inverted papilloma, I think MRI is definitely scores over the CT scan, and you can do apart from CT scan, which is a baseline investigation, and go for MRI. This will give a typical of CCP pattern, and any loss of this CCP pattern, that is alternating bands of hyper and hypo, any loss is there, then that could indicate a malignancy. So malignancy can be suspected in the MRI, depending upon the CCP pattern is lost at some places. The site of attachment can also be seen in the MRI, whereas in the CT scan, you cannot determine the site of attachment. You can see this is the site of attachment. So this is a maxillary sinus inverted papilloma. You can clearly see this is attachment. Probably this is another attachment. Now, the most common is allergic fungal rhinosinusitis. The CT scan clearly shows a bony expansion with heterogeneity. A bony expansion with a heterogeneity. You can see this calcium and magnesium salts gives the high intensity signal and low intensity signal in the polypoidal area. And this heterogeneity is a pathognomonic in the CT scan. The same if you done MRI, then there is a hypointense or signal void. So the magnesium, calcium salts, and manganese salts, they do not give any shadow. It's called signal void. Is a diagnostic of allergic fungal rhinosinusitis in the MR. Now, the mucocele, the best diagnostic modality for the mucocele is the CT scan. It gives a well circumscribed opacification with a bony expansion and thinning at the periphery with a calcification. So on contrast, if you give a contrast, you get a calcification and a well circumscribed opacification with a bony expansion, and the peripheral thinning is the pathognomonic of the CT diagnosis of a mucocele. And if you take MRI, the MRI also gives a valuable information, but depending upon the water content and protein content, the signal image is quite variable. And you have to correlate depending upon if the protein content is more, water content is more, then it gives altogether a different imaging modality in T1 and T2 weighted images. But the CT scan, by and large, is scores over the MRI for the diagnosis. Now, coming to CSF rhinorrhea, the imaging modalities of CSF rhinorrhea are the CT cystoscopy, HRCT, and gadolinium enhanced cystoscopy, and the fluorescein dye test. So, if you ask me what is your choice investigation, I think if there is actively leaking, the CT cystoscopy and MR cystoscopy is diagnostic of the CSF rhinorrhea and my choice investigation. The HRCT with a 0.5 millimeter cuts is useful whenever there is no active leak. It gives a bony defect. It gives a bony defects and approximate site of the CSF leak. The radionucleotide is very rarely done. The gadolinium enhanced cystoscopy has an advantage over other modalities because the gadolinium stays in the CSF fluid for close to 24 hours. And if there is the multiple leaks, or if the leak is not active at the time of doing, and probably in 24 hours, if there is a leak, then gadolinium has got advantageous effect over the CT cystonogram and MR cystonogram. Then fluorescein dye test, of course, it can be done. It has different advantages in case of multiple leaks, in case of testing after the CT scan repair, the CSF repair is done. Then you can test with the fluorescein dye test whether your sealing of the leak is perfect or not. You can test it, and you can do the multiple leaks. It has an advantage. Now, some pictures. You can see CT cystonogram. There is a dye here, and there is a dye. You can see cystoscopy. The defect at the left ethmoid sinus. Now, this is a 11-year-old boy with a congenital meningoencephalocele, and this is a plain HRCT. In the plain HRCT with a meningoencephalocele, there is a defect here about 1.5 millimeters, and this is a huge encephalocele. And this MR with a CSF leak, the T2 weighted image in MR gives a very high intensity signal. This is a very, very pathognomonic of the CSF leak in MR. And this is a non-invasive test and very easily done. The T2 weighted image will give high intensity signal. And MR in a CSF leak has a great advantage because it not only diagnoses CSF leak, but also it gives the idea of raised ICP. The raised ICP, intracranial pressure, the dilatation of optic nerve sheath, the slit-like ventricles, the buckling of the optic nerves, the empty sella, the hydrocephalus, then globe fattening and optic atrophy. All these things can be described and delineated in a MR. And MR has got a great advantage in not only detecting the intracranial pathology, the CSF leak, as well as intracranial pathology like raised ICP. And it also rules out some intracranial lesion like any cerebral tumors. Now, this is a child of 11 months, and it's a congenital encephalocele, and it should just is a plain MR, because you see this is a MR, plain MR gives a high intensity, CSF gives high intensity signal, and this child, I repaired the CSF leak along with the excision of meningocele about 10 years ago, and the child is going to school now. Now, this is a case of traumatic CSF leak. In traumatic CSF leak, the CT scores over MRI. Of course, MRI you can see to exclude any intracranial pathology like hematomas, and then a raised ICP or any organized hematomas, you can diagnose in the MRI. But CT scores over the MRI, because you can see the fractures here, the outer table and inner table of the frontal sinus fractures. So the fracture, whenever you suspect a fracture with a CSF leak, the CT scan has a scores over the MR. Coming to JNA, the choice investigation, my choice or anybody's choice investigation is the CT contrast. It gives not only gives the diagnosis but site and extent. The MR and MR angio for accurate assessment of the extension, both intracranial as well as intraorbital. The MR and MR angio, MRI is good for the staging of the GNA. Because in CT, what all you see it doesn't accurately assess the extensions. The MR gives accurate size and staging and extensions of the tumor. The DSA, the digital subtraction angiography, will give an idea of feeding vessels, and whenever you are contemplating embolization. The 3D CT angio, this is the latest advancement of 3D CT angio. It gives an idea of what are the feeding vessels. Not only that, and where the feeding vessels are coming from. Whether it's coming from laterally or posteriorly, so that you can accurately go through the modified Denkers or external approach or endoscopic approach and do ligation properly before dissecting the tumor from all around. So it gives approximate assessment and accurate assessment of the where the particular feeding vessel is entering. Is it posteriorly entering or laterally, and how many vessels are involved? Then this is a coronal CT. It's a CT scan for a JNA. You can see the widening of the spinoparietal foramen, a coronal CT scan plane. And axial CT scan contrast. You can see the dumbbell tumor here, dumbbell tumor with the widening of the spinoparietal foramen area. And this is a homogeneous enhancement with a contrast CT. It's a very typical appearance of JNA with a contrast. And you can see again a contrast with axial. You can see the Horman-Miller sign, the anterior bowing of posterior wall of the maxillary sinus. You can see the dumbbell tumor very clearly delineated, widening and extension into infratemporal fossa, pterygopalatine fossa, and infratemporal fossa. Now, JNA, the advantage of MR for a imaging JNA is it differentiates the tumor from soft tissues and retained secretion. What the tumor appears in CT scan could be a false impression. But if you take MRI, it gives an accurate assessment of size and extensions of the tumor, so that we can go for accurate tumor staging. Whenever there is intracranial extension, intraorbital involvement, or a cavernous sinus involvement, I think MR should be done for all cases of JNA. And when you are suspecting a medullary marrow involvement, and for the pterygoid as well as sphenoid, if the marrow involvement of the pterygoid and sphenoid are clearly delineated in the MR, but not in the CT scan. The CT scan does not show any marrow involvement, and the recurrence of most common cause of recurrence is non-assessment of pterygoid and the sphenoid bone, the marrow cavity, because at the end of the excision, you need to drill the pterygoid wedge, you need to drill the sphenoid bone, the anterior wall, inferior wall, so that the marrow involvement will be completely eliminated and you can reduce the recurrences. So MR scores over the CT scan at this area. Now, so you can see these black spots here, these are signal void. So a JNA is an axial MRI, a plane. Now this is a contrast. You can see the signal void areas. So the MR with a contrast will give what is the vascularity of the tumor and where the vessels are entering. Where are the vessels and where are they coming from? Whether spinopalatine, ascending pharyngeal, or other vessels, hospital artery, where is involvement you can delineate. And so JNA with embolization, you can see the tumor blush here. This is a tumor blush, and after embolization, you see there is no tumor blush. And this is the X-ray PNS. This is a tumor blush without embolization, and after embolization, again a X-ray PNS. You see the disappearance complete. Now, coming to the invasive fungal sinusitis. As everybody is aware, the invasive fungal sinusitis is divided into acute and chronic. Acute is a fulminant type, which is dangerous type, usually associated with the diabetes and immune compromised host. And chronic is usually diabetes, and mucorrhizopus and aspergillus are involved. Sometimes the chronic invasive can be a individual can be immunocompetent also. and it presents as a tumor-like presentation. Now you see acute invasive fungal sinusitis. The CT scan shows the destruction, bony destruction of ethmoid. You can see this acute invasive fungal sinusitis. The CT picture shows the destruction of the bone and spread intraorbitally, and you can see the proptosis as well here. Now, this is if you take MR, the MR will show involvement of the cavernous sinus, the extension of the Sylvan fissure here, and infratemporal fossa and cerebral infarctions. So the in acute invasive fungal sinusitis, the soft tissue involvement is better delineated in an MR, unlike the CT scan. This is a CT scan, and this is a MR. The MR shows the soft tissue involvement, mainly the muscles, fat, and intracranial structures. Now, this is a chronic invasive fungal sinusitis, wherein you can see the tumor-like lesion. This man is a diabetic, and you can see the tumor-like lesion in the maxillary sinus extension into orbit. So this is in the maxillary sinus and extension into orbit. This is a tumor-like lesion. So if you take a CT scan in chronic invasive, it shows hyper-attenuated soft tissue mass-like lesion with a bone destruction. Same gentleman here, this is a CT scan of the same patient. Now, if you take MRI, you see the signal void and low intensity and T1, T2. The T1, T2 for a chronic invasive sinusitis shows the T1, T2 shows a signal void, whereas the CT scan shows hyperattenuated soft-like lesion. These are the two pathognomonic features, radiological features of the chronic invasive fungal sinusitis. Now, another case of chronic invasive involving the frontal sinus. See, this is the CT scan. You can see the CT scan in a chronic invasive, it gives a hyper-attenuated signal. But if you take MRI, you see the signal void. Signal void. This is a diagnostic of chronic invasive fungal sinusitis. Now, the fibro-osseous lesions. So this is a fibrous dysplasia involving sphenoid, the pterygopalatine area, and the pterygoid. This is a pterygoid, entire pterygoid wedge, pterygopalatine area, and sphenoid completely. Fibrous dysplasia. The CT scan is diagnostic, and MRI has a little role in this. Now, the fibrous dysplasia of the ethmoid. See, this is the osteum also. There is a osteoma, there is a fibrous dysplasia with osteoid elements and fibrous elements. And the CT scan is a gold standard for these two lesions, right? Now, the osteoma is the diagnostic. The osteoma easily it is diagnosed with a CT scan. MRI has a little role. Now, thank you very much for your kind attention. Hello.
Thank you so much, sir, for such a wonderful lecture on imaging of paranasal sinuses and anterior skull base.
Yeah.
Now, I would like to introduce Dr. Pradeep Undavalli Garu with many laurels to his name, MS ENT, Fellow in Otology, Bangalore, Fellowship Diploma in Lateral Skull Base Surgery, Bangalore, trained in Neurotology and Cochlear Implantation, France. Dr. Pradeep Undavalli Garu is a consultant ENT surgeon, otolaryngologist in Visakhapatnam, and has an experience of 8 years. He owns Asian Super Specialty ENT Hospital at SZ-AP-AOICON, Visakhapatnam. Dr. Pradeep Undavalli Garu completed his MBBS and MS ENT from Andhra Medical College, Visakhapatnam in 2005 and 2010 respectively. Received basic otology training by Professor M.V. Apparao Garu and Professor H. Vijayendra Garu. Dr. Pradeep Undavalli Garu did his super specialty training under supervision of Professor Jacques Magnin in lateral skull base at University of Marseille, France in 2012. He is a member of Association of Otolaryngologists of India and also a life member of Indian Society of Otology, Indian Medical Association, National Equilibrium Society, European Association of Otolaryngologists and Head and Neck Surgeons, and a member of Pulitzer Society, Europe. Dr. Pradeep Undavalli Garu practices lateral skull base and retrosigmoid along with regular ENT practice. He owns an exclusive neuro-otology center at Visakhapatnam. Dr. Pradeep Undavalli Garu conducted 5 conferences, Neurotology Update, Phase 2016, Phase 2017, Balencicon 2018, and Verticon 2019. He secured second prize for Pulitzer Award at Gran Canaria 2018, had about 6 national and international publications. The paper, Acquired Vertical Pendular Nystagmus, Role of Peripheral Vestibular System, had been published in Otology Neurotology Journal. The recent paper, Updated Management of Trigeminal Neuralgia, was published as an invited article by University of Varna, Bulgaria. Dr. Pradeep Undavalli Garu had been invited as faculty and a speaker for many national and international conferences. He pioneered the art of neurotology and had written multiple papers in the field of vertigo. He has a state-of-art ENT hospital and also vertigo evaluation center in Visakhapatnam. It's my honor to introduce and welcome such a marvel for delivering his lecture on emergent ENT. Thank you.
Thank you, Doctor, for the warm welcome. Good morning, everyone. A warm welcome to you all for the first hybrid conference in the post-COVID scenario. Welcome to the AOICON and South Zone Conference. At the outset, let me thank the organizing team of AP-AOI and South Zone Con for giving me this opportunity. So my topic for the day is expanding ENT horizons. When Dr. Suryaprakash sir called me up and asked me to deliver a talk, there was a dilemma in my mind that whether to go for a talk on vertigo or on the retrosigmoid. I have delivered a talk in South Zone in Mysore on vertigo, and I also have performed a cadaver dissection for retrosigmoid in South Zone conference at Mysore. So I thought it would be a little bit more monotonous. So thought of telling something new, mostly for the budding colleagues to shape up their practice. So this lecture would be I would like to dedicate to all my teachers. There is no need to mention the name of any of them there. So just before starting the lecture, would like to have a small clip, because in this competitive world, there are so many number of ENT surgeons budding up every year. So you should show something else to excel in your clinical practice. I don't know, as per the old saying, shall we be the jack of all trades or master of one? As science is evolving day by day, So as the science is evolving day by day, and so are the situations. So I will conclude my perception on this saying at the end of the lecture, which will help in developing our clinical skills. So all the procedures, what I'm going to mention in this lecture are not new, but they are not vastly practiced by our colleagues and not much stressed during our teaching programs. So I would like to recapitulate all the procedures which I am practicing. So to practice these activities, you might need one or more consultation, one or more 2 rooms in your OPD apart from your consultation chamber. That's all. All these are OPD based procedures. Does not need much expensive equipment. Learning curve is also very small, and they are simple and safe procedures. So I'll be dealing this thing under 5 or 6 subheadings. One is neurotology. The second is the audiology and the hearing aids. The third is the skin prick test and immunotherapy for allergic rhinitis. Next is the voice clinic. And the last one is the facial aesthetics. So first, on an average, like 3 to 4% of the general population and 4 to 6% of ENT OPD will be having the vertigo as a presenting complaint. So 10 to 14% of ENT OPD constitutes of allergic rhinitis, or 10 to 14% is of hearing loss, might be conductive hearing loss or sensory neural hearing loss or a mixed hearing loss. Around 18 to 22% constitutes allergic rhinitis or allergic rhinitis related issues. So only 0.5 to 1% of the population might attend for East. So when there is a huge scope for performing in these fields, unfortunately, there is a scenario prevailing either in the state or in the country, making all the youngsters to focus on very few aspects like cochlear implantation or anterior skull base, where you will be having very limited number of cases. So first aspect is audiology. What are all the equipment we need? Just a pure tone audiometer, one tympanometer, and if at all, if you have, you can purchase an autoacoustic emission. Both tympanometer and autoacoustic emissions are automated tests. Just the results are within 1 minute. For pure tone audiometry, you need 10 minutes more, but you are paid for that. If you have a luxury, hire an audiologist. So my sincere advice to the budding colleagues, do not outsource your audiology department. Do not outsource. It's a luxury if you have an audiologist working with you, but do not outsource to any of the companies. Next is the hearing aids. It is one of the grossly neglected segments by the ENT surgeons. There is a myth that handling the hearing aids is extremely difficult, but that's a blunder. The newer generation hearing aids are very easy to use and very easy to program. And they are very, on the good side, they will be very good even for the revenue generation. So again, the suggestion is do not outsource, and most of you might be aware of the things that are being happened in the in the hearing aid industry. Just this is what is happening every time. You are losing good clientele because of these audiological centers which are situated outside. So you should be the boss of your thing. With great difficulty, we are able to treat the patient. So they don't know the aspect of the patient, just they simply fit with the hearing aid and send the patient, which is unsuitable for the patient, and you are losing that patient again. That patient will not turn up for you again once he got treated at the center. So this is what is being happening everywhere. So I urge the colleagues to have your own audiology and hearing aid dispensary center. So as you all know, there are three types of hearing aids like analog, digital, and rechargeable. Few terms or few terminologies that need to be get familiar with the hearing aids. One is the gain processing. That is the amount of gain that is delivered by the hearing aid. The latest hearing aids, the latest one in AOICON company is almost all delivering around 86 dB gain, which is almost all like even giving a sound perception in profound hearing loss. So this can be fitted for the patients, at least to gain some sound perception. So number of frequency and number of channels, number of frequency channels and bands. The more the number of channels, the more the clarity of the sound. But if it is the channels are more than 20, again the sound will become muddy. So 4 to 16 channels hearing aids are worthy. And directional microphones, every hearing aid will be having directional microphones, one on the anterior and one on the posterior. Of late, recently, the GN Resound has come up with one more marvelous microphone in the receiver itself. That's called Mari receiver, which is excellent for all sorts of hearing loss. And digital noise reduction is one feature, and digital feedback reduction is another feature we need to know, because all of the analog hearing aids or old hearing aid technology gives a leakage of sound from the external auditory canal, giving some high-pitched whistling sound. Even that feedback is cancelled by our digital hearing aids. So other things like multiple programs will be there. The digital hearing aids can be adjusted according to the situation. Telephone adaptation, Bluetooth compatibility, the frequency shifting. When you have a profound loss in the high frequencies, those sounds will be converted to low frequencies where the hearing is better, so that the sound is clear. Because all the consonants will be in the high frequency range. If there is a profound high frequency loss, these consonants will be shifted towards the lower frequency where the hearing is good, and so that the consonants are heard well by the patient. So these are the types of hearing aids what we have. Next department is the neurotology department. So for this, you need to have good knowledge on the vestibular system. Like the equipment or minimal equipment, one is a Frenzel glass, the Snellen's chart, thick foam, a couch, 128 Hz, tuning fork, and an ophthalmoscope. Of course, having VNG is always a luxury. These are the simplified Frenzel glasses with plus 20 diopters fitted on a frame. It costed me around 5,400 rupees. That's all. With this, you can evaluate the eye movement, which will guide you in your direction in the diagnosis. Now, the most common causes of vertigo we encounter in our practice are BPPV, the Meniere's disease, the vestibular neuritis, and vestibular migraine. So treating BPPV with maneuvers is more apt and more practical than with medication. So to do that, we need to diagnose what sort of nystagmus it is there. For that, you simply need a Frenzel glass. You don't need even a VNG also for that. Now, coming on to the next field, that is the allergic rhinitis. The skin prick test is the most common test for the diagnosis of allergy, and it's the most reliable one. So it is minimally invasive, and you can test almost all 210 substances, either food or environmental. Of course, few people are more in favorable of allergen-specific serum IgE, but the international community does not believe in serum-specific IgE levels. Of course, few laboratories are advertising and getting those blood tests done, but it's not apt. It's not right. So I urge the association members also just to educate the people on this aspect. So the positive reaction is seen as a, sorry, the mouse is not working. So it is seen as a wheel on the hand. So you could see the reaction for the allergen in some of the numbers there. Now, coming on to the immunotherapy. As you have diagnosed the allergy, now it's the time to cure the allergy rather than treat the allergy. What happens? The allergic patients will be doing the doctor shopping. One doctor will be prescribing the mometasone, the other one will be prescribing the fluticasone. One will be prescribing the levocetirizine, the other one desloratadine, or someone will be with the belastin. but we are just treating the disease or treating the symptoms, but not curing the disease. Now let's target towards the cure, that is the immunotherapy. Immunotherapy has been used for more than 100 years as desensitizing therapy for allergic disorders. Allergen avoidance and immunotherapy are the only treatments that can modify the course of allergic disease. So it is the only available curative tool as of. It can alter the course of food allergy. It is capable of changing a Th2 status to Th1 status. It is capable of impeding the onset of asthma in cases of allergic rhinitis. This is the most important thing. So you should initiate immunotherapy even in pediatric case before the asthma sets in. Immunotherapy can impede polysensitization. It is capable of providing medication sparing effect. So immunotherapy has a capacity to provide long-term protective benefit against the development of various other allergic conditions. Usually the therapy will last long for around 2.5 to 3 years. And now at our hospital, we have a good decent number of more than 130 people being treated with immunotherapy. And regarding the voice clinic, I am not much familiar with these techniques and we are not practicing yet these voice techniques now. So just I would like to move on to the another interesting thing, that is the facial aesthetics. So ever-changing perception of beauty from childhood to old age is changing with the revolution in the cosmeceutical sciences. Aesthetics is an individual perception since time immemorial. And standards of beauty have changed through centuries with increased awareness about aesthetics. As we all know, the face is the index of the mind. Even that holds good now. The wrinkles and the laxity are considered to be one of the factors of aging. Facial aesthetics can be dealt with surgical and non-surgical. As my topic is like restricted to non-surgical OPD based technique, I would like to deal on with the non-surgical facial aesthetics. So the youthfulness despite advancing age includes a smooth, charming skin without skin folds, volume loss, and skin laxity. So non-surgical facial aesthetics include, the first one is the face optimization, facial optimization, for which you can give the Botox injection, the fillers injections, and the facelift, non-surgical facelift, because we are restricting our talk to only to non-surgical procedures and OPD based procedures. And of course, facial skin tone and lasers. So coming on to pathological uses of Botox. So we have been using the Botox for chronic migrainous patients, hemifacial spasms, temporomandibular joint syndromes, trigeminal neuralgia, and occipital neuralgia. And of course, there are other minor ailments for which Botox can be used, in which palatal myoclonus and blepharospasm is one of the most common one again. So this lady is having left hemifacial spasm and she is not willing for a microvascular decompression of the facial nerve. So the next option for her is to undergo Botox injection in the area of the orbicularis oculi. So these are the injection points of orbicularis oculi, both on the palpebral part as well as on the orbital part. If the mouth deviation is also prominent, you need to give the injection on the orbicularis oris also, and also on the risorius. So sound knowledge of facial muscles is more important, and who else knows better than the better of face than an ENT surgeon? If you see in the national capital region like Delhi and everywhere, even maxillofacial surgeons, dentists are practicing this very much. So I urge all the budding colleagues to focus on this aspect also, which will be useful both for the patient as well as for you. So even though Botox and fillers are little bit expensive drug per se, but once you start using, the results are very good. So this person is having trigeminal neuralgia, and again, this guy is not ready for microvascular decompression. Even the pain is not responding with high doses of carbamazepine or gabapentin. So the next option is again Botox injection to block the masseter muscle, the inferior alveolar nerve, and the mental nerve. Next, this is the most common segment of patients which all of us will encounter. That is the migrainous patients, chronic migraine patients who are vexed up with usage of medication. Believe me, Botox is doing wonders. We have 38 case series, and out of 38, 4 are neurophysicians getting Botox by me. 4 people are neurophysicians. So these are the sites to be given the injection. One will be the procerus in the center, and the corrugator, the second one, and the frontalis muscles on the anterior aspect. So we'll be dealing with all these sites with the injections. Temporalis area, 3 injections, 3 shots. Occipital muscle, 3 shots. Semispinalis capitis, 3 shots, and trapezius muscle, 3 shots on each side. So for that, you need almost 150 units, but if you can have 200 units or 190 units per patient, it is very good, and the pain relief will be very good, and it lasts long for almost for 8 to 10 months. Drug-free interval of 8 to 10 months in chronic migrainous patient who cannot sustain even with medication. So even for TMJ syndrome, every day in the OPD, about 3 to 4 patients come with TMJ syndrome. Even for that, Botox is giving good results to block the temporalis muscle as well as the masseter muscle. Now coming on to the Botox in facial aesthetics, till now we have seen in the pathological conditions just for the facial aesthetics. So golden rule for the use of Botox is perceivable pleasure after the expenditure by the patient. So the clinician should decide whether to give either Botox alone or should be combined with some other fillers to eliminate or to reduce or to prevent further rhytids, or any other adjunctive treatments are required. So for dynamic wrinkles, you can give Botox. For static wrinkles, you can give fillers. So these are the indications of Botox in facial aesthetics. One is the wrinkles in the face, glabellar rhytid, the crow's feet, the masseteric hypertrophy, which often you see in females, giving them a masculine appearance, and hyperactive mentalis and nasolabial furrows. So these are the sites of injection of Botox for crow's feet, which you will be seeing in most of the older age group. Next session is the fillers. So these are the substances that increase the volume of the face where there is a volume depletion. So there are 3 types. One is the hyaluronic acid, which is a temporary one, which lasts for around 8 to 10 months or 6 to 8 months, depending upon the density of the hyaluronic acid what we are injecting. And collagen, that is a permanent one, but I don't have much experience on collagen. And polymethyl acrylate, which is also a permanent one. I am dealing with hyaluronic acid for the past 4 years. And if most of you have attended my FACE 2017 workshop also, even we have demonstrated live demonstration of Botox and fillers injection in that workshop. For Botox and fillers, the learning curve is little bit less, and we all ENT surgeons can learn it with ease. Probably a couple of months would be enough for us. So we need a strong knowledge of the anatomy of the muscles of the face, and we all are aware of that. So the indications for filler injections are the glabellar lines, the nasolabial folds, the marionette lines, lip augmentation, chin augmentation, depressed scar, cheek augmentation, and even sometimes earlobe augmentation, sometimes if required. So these are the sites of injection for the fillers. You can treat the sleep lines, you can treat the nasolabial folds, you can give the volume for the lip, you can give the shape for the lip. So this is the nasolabial fold injection. But unfortunately, what happens? These people who come for the aesthetic purpose don't let us to take the photograph. But few are very generous to let me to take photographs, but most of the people won't let us to take photographs and publish. So this lady asked for the obliteration of the nasolabial furrow, and after giving the filler injection, the nasolabial furrow is obliterated and giving her much younger look. And the second patient, she is from the navel. thing, and she got multiple treatments, of course, Botox, fillers, and also the facial skin rejuvenation technique. This is a chin augmentation, and I'm fortunate to have this picture here because she is my niece only, so she allowed me to keep her picture here after chin augmentation with filler hyaluronic acid. And also you can see the shape of the philtrum also being shaped after the filler injection, a prominent philtrum. And also you can define the lip volume and also define the lip by fillers. And last one in my lecture is the facelift, non-surgical facelift. It takes around 30 to 45 minutes for each facelift. We generally do it on Tuesdays and Fridays where we have less OPDs in the afternoon sessions. And detailed knowledge of the anatomy is needed. And there can be multiple types of facelifts, what you can do with this PDO needles, PDO threads. Again, you can do jawline lift, you can do nasolabial lift, you can do marionette line lift, double chin neck lift, or eyebrow lift. So you can see this lady, like she is having a dropping eyebrows, hollowing eyes, sagging cheeks, the very prominent nasolabial fold, and downturning of angle of mouth, combined with fillers and facelifts. So the skin has been rejuvenated and the patient looks at least 10 to 15 years much younger. So I told you that I will be concluding my perception on this. Let's be jack of all trades and master many trades, not one. So with that, I conclude the thing and I'll be very glad to answer any of the questions here. Thank you.
I would request Dr. Sivaramakrishna Garu to present a memento to Dr. Pradeep Undavalli Garu. Thank you, sir. I would now like to introduce Dr. Samir K. Bhargava Garu, who is currently a professor in HBT Medical College and Dr. R.N. Cooper Hospital, Mumbai, and consultant Hinduja Hospital, Khar. He is the national president of the Association of Otolaryngologists of India for the year 2020-2021. Dr. Samir Bhargava Garu has done his MS ENT from KEM Hospital, Mumbai, and DLO from Royal College of Surgeons, London. He has been invited faculty at more than 70 live surgical and cadaveric workshops all over the country since 1996 and has delivered several prestigious orations across the country, including the prestigious Dr. S.N. Cooper oration at the Maharashtra Ophthalmic Society in 2016 for exemplary work by a non-ophthalmologist in clinical ophthalmic field. Dr. Bhargava Garu is a co-author of a short textbook of ENT diseases and was awarded Vocational Excellence Award 2019 by Rotary Club of Bombay West. He was also featured in list of Mumbai top doctors 2019, 2020, and 2021 published in India Today. It is with great pleasure that I invite Dr. Samir K. Bhargava Garu to deliver the Bangalore ENT Research Foundation oration on cartilage ossiculoplasty. Over to you, Dr. Samir Bhargava Garu.
Good morning, friends. Thank you very much for those kind words of introduction. At the outset, I must congratulate the organizers of the South Zone Conference for this wonderful virtual conference. Of course, it's in a hybrid mode. In the last 1.5 years, we have missed this physical interaction that we could have with our colleagues. And I think it is long overdue that we finally have physical meets. So be it if it's in a hybrid form, but something that we are looking forward very much to the next in the next few weeks and months. I would also like to thank the organizers and Dr. PSN Murthy when he called me and asked me to give this oration. I thought that why not select a topic that is something that we are used to using in our day-to-day practice. And hence the topic for today that I have selected. I'm sharing my screen now. Please let me know if you all can see the picture. Can you see my screen and hear me? Organizers, can you see the screen and can you hear me?
Yes, sir. Yes, sir.
Okay. So my talk today is on cartilage ossiculoplasty. Is this the workhorse in ossicular reconstruction? We all have been doing middle ear surgery since many decades, and India with its huge population has a large number of patients, and we have used all the techniques that are enlisted in the books. And over the last many years, from my experience, I have come to conclude that the cartilage is an excellent material which one can use for all kinds of ossicular reconstruction. So learning to do a good and a lasting ossicular reconstruction is like learning to ride a bicycle. It may look difficult initially. It may take some time to learn the tricks of the trade. If we falter, we must adjust our tools. Maybe pull up our socks and then embark on the task. Sometimes this assembly may last for a very short time, but with practice and the right technique, one can emerge successful. So in the next 40 to 45 minutes, I will be talking about what I do, what I practice, and try to educate particularly our junior colleagues with my experience. So as I mentioned that middle ear surgery is something that is our bread and butter, and the previous speaker has explained how we can expand our horizons, but today we will stick to more of middle ear surgery. The aims of any kind of middle ear surgery, whether it be the tubotympanic safe variety or the atticoantral unsafe variety, is to create a safe ear. A safe ear, a dry ear, because most of our patients come to us with this problem of discharge, and that is probably the most distressing of the complaints that the patient comes with. But very importantly, once we have achieved these two things, we must try to give the patient a hearing ear, because that's what the ear was meant to do. So today, my focus when I'm talking about ossicular reconstruction is going to be particularly on the use of cartilage as a means to try and improve the hearing of the patient, and particularly talking about ossicular reconstruction in the aspect of tympanoplasty. So if we look at the goal of a successful tympanoplasty, it is to create a mobile tympanic membrane or a graft with an aerated mucosa-lined middle ear space and a sound conduction mechanism between this mobile membrane and the inner ear fluids. Whenever we are talking in terms of ossicular reconstruction and improvement in hearing in general, one must remember the acoustic mechanics. So the normal human middle ear couples the sound energy from the lower impedance of air in the ear canal through the tympanic membrane and the ossicles to the relatively higher impedance of fluid within the cochlea. We all know this. The middle ear mechanism, which is both the tympanic membrane and the ossicles, they act as this impedance matching transformer, which can maximize the energy transfer from the vibration of sound in the external auditory canal to the inner ear fluids. So when we look at the acoustic mechanics, there are 3 or 4 important things that one must always remember. The significance of this very wide area of the vibratory surface of the tympanic membrane, which is getting compressed towards this small vibratory surface of the stapes foot plate. This is enabled by the hydraulic lever effect. So the ratio between the surface area of the tympanic membrane and the area of the stapes foot plate allows for an increase in the sound pressure, which is proportionate to the ratio of the areas. And this average ratio gain that one gets is approximately 20.8 to 1. So it's very important that you should have a good vibrating tympanic membrane. The next important lever is the ossicular lever. And we all know that the anatomy of the ossicles is what affords this mechanical advantage, because the malleus and incus, they both work as a unit. So when the incus is necrosed, which is by far one of the most common ossicles to get affected early, we must remember that the manubrium of the malleus is 1.3 times longer than the long process of the incus, and thus we have this 1.3 to 1 sound energy increase, which is the ossicular leverage ratio. And the third and equally important aspect is the importance and significance of the malleus. Because the tympanic membrane has this catenary lever effect, and the anatomy of the tympanic membrane and the bony and fibrous tympanic annulus, this provides a mechanical advantage. So the sound energy is directed towards the center of the tympanic membrane so that the manubrium of the malleus receives the greatest amount of energy. And this amplifies the energy and provides a twofold gain as far as the sound pressure at the level of the malleus is concerned. So with this knowledge about the acoustics, one should then embark upon doing any kind of tympanoplasty, which of course includes the ossiculoplasty. We must try to tick all the boxes. Always not possible, but if you have covered these prerequisites, then the chances of getting a good outcome, a good result, not only for the short term, but also for the long term, is almost guaranteed. So we need a good ventilated middle ear. We must ensure before we embark on any kind of ossiculoplasty, as far as possible, the caveat being as far as possible, because in our country, we try to do almost everything at one stage. So the middle ear must be disease free. There obviously must not be any cholesteatoma, preferably no granulation, and a mucosa lined middle ear, because that will ensure that the adhesion formation does not take place. If one has an intact tympanic membrane, that's the ideal scenario, because if you have to fix something between two mobile structures, it's always very difficult. So if you have at least some landmarks fixed, then it makes things far more simpler, and preferably a dry ear. And believe me, in a large number of patients, one can achieve this dry ear before we go into any kind of surgery. But today, in the era of antimicrobial resistance and biofilms, that must be kept in mind very importantly to get a good surgical outcome. Now, whenever we are doing any kind of osteoplasty, from the point of the hearing, we must look at what could be the good prognostic factors. And Jack Cartouche in the year 1994 came up with this middle ear risk index, MARI index. And this is something that we must look at before we start doing any kind of reconstructive procedures. We must educate our patients as regards this whenever we are talking about the outcomes, where the importance is given to these 7 or 8 factors. So when this index came into being, it had 6 factors and a number of maximum of 12. Obviously, higher the number, the poorer the prognosis. But then as time went along, smoking and the focus on middle ear granulations went up a little, and a total of 16 points is attributed. So otorrhea, if it is there, the prognosis is poorer. A perforation, not a big problem. We know how to repair these very effectively. Cholesteatoma, of course, must be removed. If the ossicular status is been damaged, then reconstruction may not give you the 100% result that, or 99% result that you are looking at. But today, of course, in my talk, the focus is on ossicular reconstruction. Previous surgery, if any. So revision surgery obviously carries some degree of lower prognosis. And smoking, very important. We must tell our patients, the ones who've been smoking, that their outcome gets reduced by a significant factor, and hence smoking must be stopped completely. The other very important index which one looks at, which was described by Jack Dorhofer, is the OOPS index, which is very popular. This is the osteoplasty outcome parameter staging index. And again, this looks at the factors including your discharge or drainage. How is the mucosa? Is it normal? Is it fibrotic? Is there no mucosa? What is the status of the ossicles? Are they normal? Is the malleus present, which is extremely important, or absent? What are the surgical factors? What is the type of surgery that one is embarking upon? Whether a mastoidectomy is required, whether a canal wall up or canal wall down, because that reduces the middle ear space. It will affect your ossicular leverage ratio, etc., including the catenary lever ratio. Revision surgery always carries a little lower prognosis. So when we have all these factors in mind, then we can plan our reconstruction depending upon what is the finding in the middle ear. So any conductive deafness will require repair, of course, of the tympanic membrane, whether it be primary or a revision, which today I will not be focusing on, but more importantly, the ossicular reconstruction. But I must mention that since I'm talking more about cartilage as a form of reconstruction, today we can do a good tympanic membrane reconstruction also using the cartilage, preferably sliced cartilage, so that the thickness of the drum is maintained to a thin level. So when we talk of ossicular chain reconstruction and when we talk about cartilage, so is it the same for every kind of reconstruction? Definitely no. There is never a one size fit all in any kind of reconstruction. It has to be completely tailor-made according to the circumstances, and it should be modified according to what you find as you go along. So when you look at osteoplasty, the materials that have been popular so far include the autografts, which is the patient's own ossicles, whether you use the incus, reshape that, or the malleus head. Bone, which from the mastoid has been used, but more or less given up because of the incidence of resorption, and cartilage. So cartilage has been a very popular mode of reconstruction right since probably the 60s or even the 70s. Homographs used to be very popular, which is harvested incus or malleus, but with the incidence of transmissible diseases, this has now more or less, the popularity has gone down significantly. And today, when we have other materials available locally, we do not use homographs because it involves issues about about the disease transmission, of course, and of course, ethical issues, because you must tell your patient that you are using his or her own tissue. And the alloplasts, which have been very popular in the Western countries. In our country, because of the cost factor and rate of extrusion, the use is generally limited, except when I would probably use it when I'm doing a staged procedure. So titanium, which is extremely popular, the HDPS, hydroxyapatite, glass ionomer cements, Teflon. Gold was something that was extremely popular in the late 90s and the early 2000s. And because of the extrusion rate, we found that it has been virtually given up. So when you look at an ossicular chain reconstructive material, what are we looking at? What criteria are we looking at? One, that the material should be biocompatible and hence should not be causing any kind of adhesions in the middle ear. Use of the patient's own tissue will suffice this criteria completely. It should maintain the shape and should not undergo any kind of resorption. And when I'm talking about maintain its shape and resorption, we are not talking of short term, we are looking at a long term results, and that becomes very important. The correct rigidity for acoustic properties. So if the tissue is extremely soft, it may not be able to transmit as well as the other materials. It should be easy to use. It should be lightweight. So lightweight and rigid prosthesis, these minimize the sound impedance while maximizing the sound energy transfer. So we must remember that the weight of the material is also extremely important. And it should be acoustically reliable for the transfer of sound. The last but very, very important in the Indian scenario is the cost effectiveness, because most of our patients may come from a rural background or from lower socioeconomic. It becomes very important that we use something that can be very cost effective and reasonably inexpensive for our patients. So cartilage generally will tick most of the boxes. It is an autograft, biocompatible, absolutely no chance of rejection, easily available in abundant quantities in and around the ear. There is no transmission of disease like HIV or the Jacob-Creutzfeldt disease, which has been a major deterrent, although the numbers being very, very small, but still something which can be a potential disaster for the patient and can result in the surgeon getting sued for it if adequate precautions not taken. Very minimal time for shaping and placement, as I will be showing in the videos subsequently, and inexpensive, available at no extra cost to the patient. Some disadvantages that are present with cartilage are this apprehension about resorption, particularly if it has been used where with a very small piece which can get resorbed far more easily. Sometimes difficult to sculpt in certain specific scenarios, but that also let us see as we go along how we can bypass that issue, and the lack of rigidity. So this is one aspect which is always a hot debate, that this lacks rigidity and hence the sound improvement, the decibel gain may not be as good as with certain other materials. But here again, one can look at ways and means to bypass this problem. So whenever we talk about ossicular reconstruction or tympanoplasty for that matter, we always talk in terms of the Woolston, original Woolston classification. And this is, of course, the type 1, 2, 3, 4, and 5. And ossiculoplasty being the type 2 or the type 3, where there is a problem with the incus or with the stapes, and that's the reconstruction. But today, when we talk in terms of ossicular discontinuity and its repair, we generally look at the Austin-Cartouche classification of ossicular discontinuity, which was devised looking at the absence of or disease of the incus, and whatever is available of the other ossicles is how the classification came up. I was fortunate to visit Dr. Jack Cartouche in 1995, just after this classification had become very popular in the 1994. So if we look at the group, it is divided into 4 groups, the A, B, C, and D. By far the most common is where, of course, the lenticular or the long process of the incus is necrosed, and you have a very good malleus handle and a trapezius suprastructure. So this is the M plus, S plus. 60% or more of our patients would come in this group. The second group is the group B, where the malleus handle is present. So the malleus handle is probably the most resilient ossicle. And if that is gone, that it indicates an aggressive kind of a disease. Quite often in cholesteatoma, you may find that it may have got eroded. But trapezius suprastructure absent, so M plus, S minus, and 23% of the patients in a large series would have this kind of a ossicular status prevalence. The group C, where the malleus is absent, the handle, and the suprastructure is present. So a lot of times this is, of course, a canal wall down procedure post cholesteatoma surgery. So M minus, S plus, and about 8 to 10% of patients would come under that category. And the last, group D, where both the malleus handle as well as the trapezius suprastructure is absent, and you have only a mobile foot plate. So 8% of our patients. So when I talk about use of cartilage, the sources of cartilage can include the tragus and the concha, which is very easily available within the same local incision from the patient himself or herself. The nasal septum has been a popular cartilage used for ossiculoplasty. Of course, this would mean going into the nose and harvesting this from the patient. Prior consents may be required, additional procedure required. But if you can manage with the tragus, then why go for the septum? Although having said that, the lower end of the septum, which is the cartilaginous septum, which is close to the crest, is fairly rigid and tough. So the issues about rigidity is quite often tackled if you use that kind of material. Costal cartilage used to be very popular, again, very stiff material, but those were the days when one was using homographed cartilage, and it is more or less given up now. Harvesting of this cartilage is very relatively simple, and you can see the incision being taken just a few millimeters below the tragus, bulge of the tragus. Prior infiltration, even if you've done it under general anesthesia, helps ensure that the field is very good. I generally prefer to take cartilage with perichondrium on one side, and you can manage to do that with the minimal instrumentation. If you have taken it with perichondrium on both sides, then it is not very difficult to remove the perichondrium from one side. If required, you can hinge it at the edge in case you want to use this from the point of view of tympanic membrane repair. Fashioning the cartilage will depend upon the requirement. You can have a piece which can be used for the ossicles, and you can have a larger piece which can use for the reconstruction of the canal wall, attic defects. So sculpting is dependent upon, you can be a Michelangelo and take away whatever is required to finally get the final desired outcome. And this will be again tailor-made according to the situation. I must compare sculpting of the incus, which is far technically a more difficult procedure, requires much more expertise, of course requires the use of additional instruments, so the burrs, so that would to some extent increase the cost of the surgery, but you need to be very adept under the microscope to be making these very fine grooves for the stapes as well as for the handle of the malleus. So let us look at the real life scenarios. So the first is the group A, which by far is the commonest type of ossicular discontinuity issues that we are facing. So here we have the handle of the malleus is present, fully intact, a tubotympanic type of a disease, no cholesteatoma, but we have the incus, not only the lenticular process, which would be in contact with the head of the stapes, but even a part of the long process of the incus is necrosed. Stapes suprastructure is intact. So in this scenario, what we can do is use a piece of cartilage which can be interposed between the long process of the remnant part of the incus and the stapes head. Putting a part of this going under the handle of malleus so that we can get a better leverage ratio. Now, what I generally do is use a cartilage which is a little bigger than just a tiny piece, because we know that this lenticular process necrosis is a avascular necrosis. And in the times to come, if a little more necrosis takes place because of poor blood supply, then you should not land up with a situation where you've done a reconstruction which lasts only for a short period of time. So here we can have a situation where even if a little bit of the incus necrosis further, we have it well covered with our technique. So this is a patient where you have the posterior superior area adherent onto the long process of the incus, curating the overhang so that we can see the ossicular status, and you can see that the long process of the incus is partly necrosed, dissected off from the stapes very gently, and you find that the head of the stapes is intact. So in such a scenario, check for the ossicular mobility, see if there is no fixity of the malleus in the attic, and use a cartilage. As I mentioned, a little broader and a longer piece of cartilage which goes in. I generally prefer to put some gel foam in the middle here, which props up the cartilage against the undersurface of the malleus so that there is no drop in the cartilage anteriorly. The cartilage is adjusted. It does not take much time to do this. Check the assembly and then slightly slide the cartilage up so that if the lenticular process, long process happens to necrose further, you have taken care of it. The tympanic membrane grafting using the temporalis fascia can be done either before, or it can also be done after you have done this reconstruction, because you just need to slide in a little bit of fascia and that would end the procedure. The hearing results with these kind of ossicular reconstruction over long-term basis can be easily less than a 20 dB airborne gap in most of our patients. A second case where again there is a group A situation, lenticular process thinned out or partially necrosed, a very small piece of cartilage in these cases can also be used. Or a situation like this, where you have the long process partly necrosed, the facial nerve is clearly completely dehiscent in the horizontal segment, and you may not want to use a heavy material over there, or for fear of the ossicle falling off if you use that for reconstruction. And here also one can use the cartilage for reconstruction. The other advantage of leaving the incus in place is that it prevents any kind of posterior superior retraction that could take place if the incus has been removed, because the aeration pathways are such that if you do any kind of violation, there is a technical theoretical possibility that later on over a period of years, the posterior superior part of the drum may retract. So quite often one would want to maintain the incus in its normal position and easily do a reconstruction using a cartilage. So if you have a situation like this where there is a significantly dehiscent facial nerve, you would like to use soft material, which a cartilage will definitely fall into that criteria. Another patient here where the incus had to be dislocated from the stapes suprastructure, and in trying to put it back, we found that it is not going back into position. We try to move the malleus and we find that there is not enough good movement. So a piece of cartilage introduced between the lenticular process of the incus and on the head of the stapes would provide a very, very stable assembly. The thickness of the cartilage works to our advantage over here because this helps in getting adequate pressure when you move the incus. Preferably use a little bit of gel foam so as to support and prevent the fall of the ossicle that you have of the cartilage that you have transposed. Let us look at another scenario where you have a group A. Again, this incus is necrosed, the stapes suprastructure is present. You find that the malleus head has had to be removed because there was disease and epithelium in the attic. And this defect that has been created can be reconstructed using the cartilage. So you have this defect being closed, repaired with the help of a cartilage, tragal cartilage here, and the repair of the ossicular reconstruction using the tragal cartilage. I prefer using tragal cartilage in most of the cases because of the rigidity and the thickness that it can provide as compared to the conchal cartilage. So depending upon the need, the sculpting can be done. So you have the cartilage larger piece used to repair the defect in the attic area. Leaving a space under the free edge of this cartilage for ventilation of the mastoid. Now here I've used the curve of the cartilage to my advantage, and it goes below the handle of the malleus and sitting on the stapes head, very stable. Again, using gel foam. I use gel foam even when I'm doing a regular type 1 tympanoplasty, just one small piece under the handle of the malleus. So this will swell up and then approximate the, since I always do underlay tympanoplasty, it abuts against the graft and pushes it against the undersurface of the malleus and helps in keeping it stable over there. So use of the gel foam works almost like a sandwich. So where you have the main part, which is the delicious part which of the sandwich in between the two pieces of bread. So you can see how well this is stabilized over here. And when you move the assembly, it moves in unison. The other options, of course, can be the use of ossicles, which I will be not speaking about in detail today because the focus being on cartilage, but that is also something that one can use in scenarios like this to bridge the gap. But yes, the disadvantage as compared to the cartilage may be that it would take a little more precision in sculpting this, more time. You can see that in this where one needs to sculpt. And the placement that needs far more delicate controls so as to be able to get it in correct position. So what have been the hearing results? So if we look at this paper coming in the otology and neurotology, but way back in 2001, showed that the results with of ossicoplasty using cartilage have been superlative. 50% of patients undergoing partial ossicoplasty, which is using where the malleus handle is present and the stapes suprastructure present, only incus necrose, was almost 50% less than a 10 dB airborne gap, and more than 80% having a post-operative airborne gap of less than 20 decibels. So equally good results were found with other autographs, which include the head of the malleus or the interposition of the incus. But the advantage being that this procedure looked and as you've seen is far simpler with less time that it could take to do the procedure. Our own series coming out of the medical college, which I am attached to as professor, which we came out in 2017 in the International Journal of Otolaryngology, showed that an average airborne gap of 39 decibels in the pre-op was reduced to 18 decibels in the post-operative period, and this persisted over 6 months of follow-up. We now, of course, have longer follow-up, and the results continue to remain the same. Now let's move on to the group B, where you have the malleus handle, but the stapes is absent. So here I will show you a scenario where we have a cartilage placed in the hypotympanum to create some middle ear space, and this is where I'm using the incus and pushing the incus under the handle of malleus and going on to the foot plate. And you can see that this assembly requires some degree of expertise. But if for some reason the incus could be falling short, you can always use a piece of cartilage on top of this incus.
Ready? Okay. Start. Good evening, one and all. Today I'm presenting a case series in comparison between endoscopic versus microscopic plastic.
Please mute the other mics. Please.
First,
so if you have a scenario like this, you can see the foot plate of the stapes mobile, and this is an intact canal, and you find that the incus is short. You do not have enough material. So this is one scenario, or type B, where you need more rigidity and you a longer length. So in such a scenario, you can use a combination of the auto incus and then use a piece of cartilage on top of this incus to get that adequate height. There have been a lot of reports where two pieces of cartilage back to back have been used again to increase the height of the middle ear space, again to help in the middle ear transformer ratio effect. So once again, a little gel foam being placed. So you can see that on top of the incus, a piece of cartilage placed so that now it comes in contact with the tympanic membrane, and you can get a very good and stable assembly as regards this procedure. The other options, of course, can be the use of alloplast material, and which has this hook which can go under the handle of the malleus, but that is a description for another day. Let us now move on to the group C, the Austin cartridge group C situation, where you have the malleus absent, the stapes suprastructure present, and a canal wall down procedure. And that's where the tragal cartilage can be kept on the stapes head. So let us look at that scenario, and you have a cholesteatoma that is being dissected off from the stapes, and you can see the facial horizontal coming into view. The hypertrophied mucosa being dissected off. The head of the malleus is being removed so as to create a space for placement of the graft, and of course to check if there is no. So if the malleus was not involved, then you could have used that as well. So here you have this horizontal piece of cartilage which goes again under the malleus onto the head of the stapes. A small piece of cartilage used to reduce the mastoid cavity also in size. And once the fascia is put in place, a relook is always done to check if the new ossicles that have been put in are in good shape. We are able to achieve almost a 20 or a 25 decibel airborne gap, which in most of the patients is very good enough for giving a good hearing. Another case where once again you are harvesting the tracheal cartilage. I will skip that because we have already seen the harvesting. So the cartilage is, one piece of the cartilage is placed in the hypotympanum to create some middle ear space, little bit of gel foam placed so that it doesn't retract. In the immediate healing phase, you can see the head of the stapes very clearly over here. The temporalis fascia being placed under the handle of the malleus, and the piece of cartilage then being slid onto the head of the stapes. Looks stable. The fascia reposited back, once again lifted up to make sure that it is in stable position. A small piece of gel foam placed to stabilize the cartilage, once again under the cartilage so that it doesn't fall, and helps when the gel foam swells up, abuts the cartilage against the undersurface of the malleus. So now let us look at the last scenario, which is the Austin cartouche group D, where the malleus is absent, the incus is absent, and the stapes suprastructure is also absent. So this kind of a scenario most of the time will warrant a canal wall down procedure, but where you have a canal wall up and you have dissected, if you have drilled out a little part of the attic, you may want to reconstruct that using the cartilage and using the cartilage for ossicular reconstruction. So which can be in the form of a single columella from the footplate to the tympanic membrane, an umbrella kind of a columella, but this is not often a very stable assembly. And the more preferred, what I generally prefer, is the boomerang cartilage from the annulus to the footplate. So you have a situation where you have the cartilage from the footplate going to the annulus. A notch has already been created in the anterior annulus. You can sometimes use it at the posterior annulus as well, and so that this fits in a rather stable assembly. Also, a cartilage can be used if you are doing a alloplast material, use of titanium and keep it at the shoe at the level of the footplate so that there is no trauma to the footplate while you are adjusting. So let us look at how a group D reconstruction can be done. You can see that's the tensor tympani, that is the stapes footplate that is there. Some amount of mucosa has been denuded over here. You can see the promontory, which is not the best case scenario, the round window over here, and a piece of cartilage. Again, the tracheal cartilage far more rigid as compared to the conchal cartilage. And this comes from the footplate and goes anteriorly to the notch that has been created anteriorly. Now, whenever I am doing, so making sure that there is enough space underneath, so this is a boomerang. I sometimes shake the head of the patient gently if the patient is under general anesthesia, to check for the stability of the reconstruction, whether it be cartilage or ossicle if I'm using, and this gives you some kind of a little mental surety that what you have done is going to stay. And then finally, the temporalis fascia being placed. Another case where you have a canal wall down procedure, the horizontal part of the facial you can see over here, and a piece of cartilage. Now this is a columella effect, straight coming from the foot plate. You can see tenting over here, so we know that it is in place and adequate force will get transmitted. Another boomerang cartilage, once again, canal wall down procedure. This is a revision procedure, and the cartilage coming from the foot plate going on to the annulus posteriorly, making sure that there is enough room underneath. So in these scenarios, if you do not have perichondrium on the undersurface, the chances of adhesion become greatly minimized. The temporalis fascia is being adjusted, and then you can see the ossicle, the reconstruction material in place. One last use of cartilage is as an interposition over a torp. So we all know that extrusion rates are high, but if you keep a piece of cartilage on top of the prosthesis, then the extrusion rates can go down significantly. So another case in point where you have again a piece of cartilage being introduced on top of the stapes of the reconstructed material. In cases of atelectasis, also the same procedure can be done. Here you can see a single piece of cartilage, that's the foot plate, the horizontal facial, non-dehiscent. The height being very much, so this will be tailored, cut to size depending upon the requirement. It should be slightly above the height of the facial horizontal canal, so that when you place the temporalis fascia, it can provide enough tension. A piece of cartilage kept in the lower portion of the middle ear and the hypotympanum, and a temporalis graft being placed into position. Again, a small piece of gel foam kept there to stabilize the cartilage. This was again a revision procedure, and you can see the tenting effect over here, so that there is a good contact between the temporalis fascia and the foot plate. So if you look at literature and this very interesting article, which was on a series that they presented in the Journal of International Advanced Otology, where the cartilage ossiculoplasty from stapes to tympanic membrane, which was acronymed COST, C-O-S-T. So a cost-effective method of doing a reconstruction, where they found that the cartilage ossiculoplasty from stapes to tympanic membrane in a one-stage tympanoplasty for cholesteatoma is a safe, reliable, easy, and effective procedure with no additional cost. The hearing improvement being fairly good, one can achieve up to a 20 decibel in a large majority of our patients, up to a 25 decibels in a few of the patients, but that is fairly good for a patient who is able to hear normal conversation fairly effective. Definitely the hearing improvement when we are using prosthetic material may be slightly better, but the results are very good as far as cartilage is concerned. And this recent paper that came up in the Indian Journal in the August issue, where we have a comparative evaluation of hearing in cartilage, umbrella, boomerang, and torque in chronic otitis media cases with an absent stapes suprastructure, showed that the advantage being that there is reduced chance of prosthesis extrusion as compared to torque, and the hearing improvement, whether it is in mucosal disease, was very good as compared to the top, giving almost the same kind of results, and hence it is something that can be used very effectively. So to sum up, the advantages of autologous cartilage being that it is an autograft, biocompatible, absolutely no chance of rejection, availability is very easy, no transmission of disease. You've seen that minimal time is required for shaping and placement, and extremely cost effective. So with this, I would like to leave you with these few lines. Hopefully my talk would have been to educate a few of my junior colleagues. And this talk has been from my experience. It's always best to learn from someone else's experience so that you don't learn from your own mistakes. Thank you very much.
Hello, Samir.
Yes, Dr. Apparao.
How are you, man?
Very good, very good. Thank you.
Thank you very much for your nice oration. Bangalore ENT Research Foundation oration. Is our AOI National Body President, and his father also ENT surgeon. Is a renowned ENT surgeon in India. Thank you very much, man. You'll receive your
being at least
certificate
on the virtual platform. Yeah.
Yeah, you'll receive a certificate and medal in due time. Okay.
Okay. Thank you. Thank you.
Thank you very much. Thank you.
You'll have a great conference.
After this amazing lecture by Dr. Samir K. Bhargava Garu, we move on to Dr. K.P. Raman Pillai oration on cis, sulci, and mucosal bridges of the vocal folds, a difficult family, by Dr. Nupur Kapoor Nerurkar Madam. The chairpersons of this session are Dr. B. Sriramurthy Garu, President of South Zone, AP Chapter of AOI, and Dr. Y. Subbarayadu Garu, Secretary of AP Chapter of AOI. Dr. D.R.K. L.N. Raju will introduce Dr. Nupur Kapoor Nerurkar Madam to us.
Dr. Nupur Kapoor Nerurkar is an ENT surgeon who has graduated in 1994 from KEM Hospital with a first rank in Bombay University. Since 2004, she is practicing exclusively as a laryngologist and is currently heading the Bombay Hospital Voice and Swallowing Center. Dr. Nerurkar is also the DNB coordinator of the ENT department at Bombay Hospital and director of the Laryngology Fellowship Program and course director and annual phonosurgery workshops at Bombay Hospital since the past 14 years. She is a past president of the Association of Phonosurgeons of India and currently on the governing council of the association. Nupur Madam is the chief editor of the textbook of laryngology, which is the official textbook of the APSI, and has also authored an Atlas of Phonosurgery in 2017. Dr. Nerurkar is the only Indian to date to become a fellow of the American Bronchoesophageological Association as well as American Laryngology Association. She's an executive committee member of the International Association of Phonosurgeons and a member of the British Laryngology Association. Thank you, madam. Please continue.
Thank you so much for the kind invitation. And I'd like to thank Dr. PSN Murthy and Dr. Rao for inviting me today to take this Dr. Raman Pillai oration. I'm very honored to do so. So that there are no issues with internet connectivity, I have just pre-recorded my talk, and I would request the audiovisual to please go ahead and relay it. And I'm very much live with all of you. Thank you once again. I hope the audiovisual is ready to relay the talk.
Madam, it's ready. You can.
Thank you. I have a pre-recorded talk which the audiovisual has, so I hope there's no confusion and they're relaying that. Or are you expecting me to share my screen and take the talk just now? If someone could just coordinate with me, please. Or you don't want me? Okay, we're not going with the pre-recorded talk. All right, I'll share the screen. That's not a problem. I'll do that. Okay. Thank you once again for this invitation to take the Dr. KP Raman Pillai oration for the 16th AOI South Zone and 39th AOI Andhra Pradesh State Conference. I'm indeed delighted to do so. I'm Dr. Nupur Kapoor Nerurkar. I work in Bombay Hospital in Mumbai, as has been introduced already. And I'm going to take today's talk on cysts, sulci, and mucosal bridges, which can be considered to be a difficult family of the vocal folds. Why difficult? Because one, it is very often difficult to diagnose these lesions. And secondly, they can also be very challenging to treat. So therefore, we can consider it a difficult family because they're very often found in coexistence with one another. What are the objectives of today's talk or oration? It's basically to understand the etiopathogenesis of vocal fold cysts, to understand the histopathology of cysts a little bit in detail. We're also going to go through the various classifications which have been proposed for vocal fold sulci, the surgical options and the challenges in managing sulci of the vocal folds. And then we're going to talk about the various types of mucosal bridges. So coming to the etiopathogenesis of cysts, we basically do have two types of cysts, as you are aware. We have the retention cysts and we have the mucoepidermoid cysts. Now, the retention cysts are thought to develop because the duct of the seromucinous gland, which may be present in the vocal fold, gets blocked. And so a mucus retention cyst develops. However, a mucoepidermoid cyst develops because there may be a congenital cell rest present in the subepithelium from birth. Therefore, you have children sometimes who present with mucoepidermoid cysts typically. Or there is a theory that it may be a result of healing injured mucosa, which buries epithelium. So just like you have your cholesteatoma pearl formation, similarly, you can have a mucoepidermoid cyst. So this is the appearance of a right vocal fold mucus retention cyst. And what you can see, the margins aren't very clearly defined. The material within seems to be liquidy, serous in nature. So this is typically how a mucus retention cyst appears under the microscope. And here on the left-hand side of our screen, on the left vocal fold, we see very clearly the mucoepidermoid type of cyst, where the margins are more clearly defined. The material seems to be more thicker, yellowish, almost toothpastey in consistency. And then you can have very occasionally a variant of an epidermoid cyst where the cyst actually starts leaking into the laryngeal introitus. And then we refer to that cyst as an open cyst. As you can see over here, the cyst is sort of leaking into the laryngeal introitus. These are all images from our own hospital. So what we see over here on the left-hand side top corner right here is a classical mucoepidermoid cyst. And we see just below it what the histopathology looks like. So you can appreciate what I'm showing you as the wall. The wall is stratified squamous epithelium. So it's a thick wall. So really, it could be maybe technically easier to remove the epidermoid cyst because the wall is thick. But occasionally, these cysts could be deeper, and they could even be attached to the ligament. So can mucus retention cysts. The issue with mucus retention cysts, like you see on the right-hand side here, top on the right top corner, the wall is very thin, the cyst wall. The material is very liquidy. So, of course, during surgery, the chance of opening up or rupturing a mucus retention cyst is higher than that of a mucoepidermoid cyst. And right here at the bottom, you can appreciate the cyst wall, which is a respiratory and thin epithelium. So this is a comparison of the histopathologies and this of the gross appearance of the two types of cysts. But interestingly, there is a study and a research which has been published in 2000 by Schwero and Koren, which I find very fascinating, where they have further subclassified these vocal fold cysts, where the mucus retention cysts have been subclassified into a type A and a type B. Now, the type A is the cyst which is lined by respiratory epithelium, which does not have any cilia. But the type B is lined by respiratory epithelium, columnar epithelium with cilia. And then we have the type C and D, which are subdivisions of the mucoepidermoid cyst. The type C is lined by stratified squamous epithelium, but without any typical keratinization within. The type D, however, has the typical stratified squamous epithelium lining and keratinization and filled up with keratin debris. So of late, we have been classifying our cysts based on this Koren system of classification. And this is typically what a Koren type A cyst looks like. So you see the respiratory epithelium, no cilia, and the colloid content over here. And these two images, both of them are the Koren type B cysts. We can see over here beautifully the cilia of the columnar epithelium. Similarly, over here, we can see the cilia. So this is the Koren type B. And in fact, at least in our series, the Koren type B cyst is the commonest type of cyst that we have found in the last decade in our practice when we, sort of went through all our cysts. So here we have the least common in our series, which is the Koren type C cyst, where the lining is stratified squamous epithelium, but there's no keratinization within. Okay. And then finally, you have that very typical epidermoid cyst, which is stratified squamous epithelium lining. And then you have a lot of keratinization filled up with keratin debris within. Both of these are the Koren type D cysts. So in the mucoepidermoid group, the Koren type D are the commonest in our series, but overall, the type B cysts are the commonest because we see many more of mucus retention cysts as compared to epidermoid cysts. As far as the gender and age is concerned, according to Martin's series, basically, which was a study done in 2011 on 72 cysts, out of which 46 were cysts operated, the rest were diagnosed clinically. The majority of the cysts were found in the female gender, and 36% of cysts were found in children. However, in children, there was a reversal of the gender where about 69% were seen in males. Now, in our study, which was performed over a 10-year period and published in 2020, we found quite the reversal. We found 60% of our cysts were found in males and only 3.6 were in the pediatric age group. And then we have Schwero's study of 2000, which was on 41 cysts. Our study was on 218 operated cysts over a 10-year period. In Schwero's study, again, just like ours, they had more of a preponderance of males with 61%. So there's not a very clear verdict out there as far as the gender is concerned. I would like to share with you a little bit in detail our study, which has been published in the Laryngoscope in 2020, which is a 10-year study of the etiopathogenesis of cysts. And there's a second part to the study, which is a study of seromucinous glands in the vocal folds. So now, historically, we know that vocal fold cysts are possibly the commonest benign phonotraumatic lesion that requires surgery. Of course, the commonest benign phonotraumatic lesion is nodules, but that does not require surgery 95% of the times. Now, what we found in the last decade in our center was that we seem to be doing many more cysts than we were earlier. So we divided the last 10-year period into 2 5-year periods, a former and a latter 5-year period. And we compared the number of cysts we were operating as compared to the polyps. And we found a statistically significant increase in the number of cysts in the latter 5-year period. So that was interesting. So we wanted to try and understand why possibly there is an increase in cysts, what could be the various factors. So what we studied in the 2 5-year periods, as far as the type of cyst on histopathology was concerned, in both the 5-year periods, maximum of our cysts were mucus retention. So 92% in the former 5-year period, 93% in the latter 5-year period were mucus retention cysts. So there was no dramatic change there. And all through the 10 years, it seemed to be primarily mucus retention cysts that we were operating upon. Now, this is a little different from Martin's study, where they found that almost 60% of their cysts were actually mucoepidermoid cysts. Once again, Schwero's study was a little bit more like ours, where there was 63% of cysts which were mucus retention cysts. So once again, there is no real very clear verdict as to whether mucus retention cysts are more common or mucoepidermoid. It seems to vary geographically and with different studies. What about the location of the cyst? So when we talk about the location of a lesion on the vocal folds, when we talk specifically about the striking zone, because you can see on my slide, we've sort of divided it into whether it was on the striking zone or not on the striking zone. So the striking zone is the anterior 1/3 and the posterior 2/3 of the vocal fold. But if you consider only the membranous vocal fold, then it is the mid-membranous vocal fold. And we know that's the point of maximum contact during phonation. So typically, phonotraumatic lesions develop on the striking zone. So the significance is that if there is a lesion, like in our study over these 10-year periods, 91% of the polyps were in the striking zone, it's quite clear that polyps is a phonotraumatic lesion. What was interesting was that 84% of the cysts were also on the striking zone. So they seem to have a phonotraumatic etiology also. In Schwero's study of 2000, they found 90% of their cysts on the striking zone, once again suggesting a phonotraumatic etiology. This is actually what we mean by striking zone. So here we can see it on laryngoscopy. This is the mid-membranous. Or if you're counting the entire vocal fold, the anterior 1/3, posterior 2/3 of the entire vocal fold, including the cartilaginous part, this would be the striking zone under the microscope. Now, these were considered to be posterior cysts when they are behind the mid-membranous. And these were considered to be anterior cysts when they are in the anterior half of the mid-membranous vocal fold. One very interesting finding that we found was regarding laryngeal hydration and cysts. So what do we mean by laryngeal hydration? We, for the purpose of our study, considered an inadequate laryngeal hydration in a person who had less than 4 glasses of water in a day, or had more than 8 caffeinated beverages, which could be tea, coffee, colas, etc. And what we found was that 56% of patients who had developed cysts did fit into the category of a decreased or inadequate laryngeal hydration. And this was something which was over the entire 10-year period, not the 2 5-year periods. And compared to the polyps over the entire 10-year period, in polyps, there were only 17% of patients who fit into this inadequate laryngeal hydration. So this was statistically significant with an odds ratio of 6.24. Now I'd like to come to the second part of our study in this publication. So as I mentioned, the primary cysts which we seem to remove were seromucinous gland cysts, the mucus retention cysts. So mucus retention cysts, as we've discussed, develop due to a blockage of the duct. Now that can only happen if the seromucinous glands and their duct exist anatomically in the superficial lamina propria. So we did a histological study of the presence and the distribution pattern of seromucinous glands in 40 apparently normal, fresh, frozen cadaver true vocal folds. So we sort of excised the true vocal folds, marked the anterior superior part with permanent ink, and then 2 of our pathologists in Bombay Hospital independently reported on these cut sections. And what did we find? We found out of the 40, there was the presence of seromucinous glands only in 13 vocal folds, out of which 10 were found in the superficial lamina propria, 3 anteriorly, 7 posteriorly. And there were 3 seromucinous glands in the muscle, 1 along the ventricular surface and 1 present more posteriorly. So that was as far as the distribution of glands in our study was concerned. Now, this is what seromucinous glands within the superficial lamina propria look like. And this is how seromucinous glands appear within the muscle. Now, why is there so much concern regarding cysts? We know a patient who comes to us, let's say we've diagnosed a cyst, has typically come because he or she is symptomatic and there is hoarseness. So it's only the symptomatic cysts which really need surgery. Very often my patients in my practice ask me that, you've diagnosed us with a cyst and we have hoarseness because of it, and you are saying this is 100% not malignancy. So what would happen if we do nothing? So in order to answer these patients, I rely on this very interesting publication of Kirk and Sulika, which has been released in 2020 in the Laryngoscope, where they have discussed the natural history of the vocal fold cysts. And they have said that most of the vocal fold cysts, almost 70%, would remain static over time. 30% of the cysts may increase or decrease, with 15% maybe a little bit increasing, 15% little bit decreasing. And it would be very occasional that a cyst will spontaneously settle or rupture and develop into a focal pit. It can happen. Voice can get much worse then, but that's very occasional. So this is a good paper to refer to. And why is there so much concern with the surgery of removal of a benign cyst? There are 2 factors of concern. One is regarding the healing, of course. You want a good mucosal wave post-operatively. And as the cyst is present more deep and attached, let's say, to the ligament, the healing could be worse. The second concern is regarding recurrence. And during surgery, if one leaves a little bit of the cyst wall behind, there is a chance of recurrence. So that is another concern. We've published a paper in the International Journal of Phonosurgery and Laryngology, which is our association's journal, regarding a subepithelial vocal fold cyst, where we've called it a pearl on a string. Why a pearl on a string? During dissection, when you dissect the entire cyst out, almost always you will find anterior and posterior fibrotic bands, which are pretty thick. So when you dissect it, it almost gives the appearance of a pearl, which is the cyst, on a string, which are these anterior and posterior fibrotic bands. What is the clinical significance of this? The clinical significance is that one has to do a sharp dissection of these bands, either with scissor or with laser, because with a blunt dissection, the chance of opening up or rupturing the cyst is higher, then leaving the cyst wall behind becomes higher, and chance of recurrence, therefore, also gets higher. What are the basic surgical steps when we are removing a vocal fold cyst? Always palpate, because you want to know what is the lateral extent of that cyst, so that you may make your incision bang on the lateral extent of the cyst, which is your mini microflap incision. I personally don't like to infiltrate in cysts because I feel the boundaries get a little bit lost there. The surgery, of course, could be performed with cold steel instruments or laser. That does not matter. They are just tools. But what we do is a blunt dissection of the cyst from the overlying epithelium and the cyst from the underlying superficial lamina propria. And then we identify anterior-posterior fibrotic bands. As you can see very clearly, this is the posterior fibrotic band over here. This is the overlying epithelium of the right vocal fold, and the cyst is, of course, lying on the bed, the superficial lamina propria. So then we do that sharp dissection. We cut the posterior fibrotic band. Similarly, we'll cut the anterior fibrotic band, and then ideally perform a complete removal of the cyst wall with the cyst. Try to preserve the overlying epithelium if possible. And I would like to just share a small edited surgery of a mucoepidermoid cyst. In a young girl, she's got a right vocal fold mucoepidermoid cyst, which we are palpating over here. And when we palpate the left vocal fold, see the pit and see the mucosal bridge. So this young girl has got a cyst, she's got a focal pit, and she's got a mucosal bridge. So she's got the whole family which we are talking about. Now you see this red sort of line, which is making the incision on the right vocal fold just lateral to the cyst, and that is the CO2 laser in a scanning mode. And with the scanning mode, we get what we call an AccuBlade. So this is this produces very little heat dissipation and almost zero charring. Now, this is the microflap elevator, which is being used to separate the cyst. So we are going to separate the cyst from the underlying SLP, and we are going to separate the overlying epithelium from the cyst. You can see there are so many blood vessels on the epithelium. So these blood vessels very often tether the epithelium onto the cyst. So you have to be a little bit careful where it is getting tethered. There can be bleeding over there occasionally. And you can appreciate how thin is this overlying epithelium. Once we've separated both the overlying epithelium and the underlying SLP from the cyst, we then can identify that anterior fibrotic band, which is now being cut with the CO2 AccuBlade. So the cyst will now start retracting posteriorly. And that's the fibrotic band, which one can't just do a blunt dissection of. So once we start this excision, you can use, I typically like to use the laser for the complete surgery, but you don't need to, of course, you can use scissors. And here you see we're using a crocodile forceps to hold a little bit of the cyst wall and medially retract it so that we can separate the bed of the cyst from the SLP. If you hold the cyst too tightly, it'll rupture. So we need to be a little careful here and gently hold any fibrotic attachment which may be present on the cyst wall or the cyst wall a bit gently. And as we keep separating the cyst from its bed, and once again, I mentioned we can do this step with cold steel instruments also, we come to the posterior fibrotic band. And as we cut this posterior fibrotic band, we will get a complete release of the cyst from all its attachments. And then what you want to preserve is not the entire overlying epithelium, but just the infraglottic epithelium. And this white epithelium, this is the infraglottic epithelium, which will then get reposited back on the medial vibrating edge. So you see, this is a telescopic photo now, and this entire infraglottic epithelium is covering the medial vibrating edge, and there's no raw area whatsoever. So this is an ideal way of doing the surgery with the microflap technique, I have used a laser. We don't always need to use a laser. So the conclusion of the first part of my talk is that subepithelial cysts are seen to have toughest fibrotic bands at the 12 and 6 o'clock position, giving that appearance of a pearl on a string, and sharp dissection of these bands is advised. Laryngeal hydration, as our study showed, is to be encouraged. Voice therapy is important postoperatively, and maybe there is an anatomical predisposition for the formation of mucus retention cysts, again, as our study suggested. I'm going to now move on to the second part of the talk, which is sulcus of the vocal folds. And we know the vocal folds, if they're transected, they've got the epithelium, SLP, ligament, and muscle. So you can have a type 1 sulcus. What is a sulcus? It's a furrow or a depression along the length of the vocal fold or in just one place. A physiological sulcus is thought to not cause any problem with the mucosal wave of voice. But as the depression gets deeper, it can be referred to in various classifications as either sulcus virgature, type 2, stria minor, major, etc. So you see over here is this vocal folds, and you see on the right vocal fold the depression from the vocal process level going anteriorly. This is like a type 2 sulcus. And then you can have what is referred to as a sulcus vocalis or a type 3 sulcus or a sulcus pocket, which is this depression over here. Now, in all these classifications, there is no clear-cut definition as to the length of the sulcus and the depth of penetration. And I'll come to that in a bit. But what are the theory of sulcus formation? So Boucher has got the theory of sulcus formation saying that the sulcus could be a stage in the development of an epidermoid cyst. The long-standing dysphonia that sulcus patients typically give us is a clue in favor of the embryonic theory. And the hypothesis is that there may be an anomaly of the 4th and the 6th branchial arch. And this could also explain the fact why cysts, sulci, mucosal bridge are seen together, the difficult family, what I mentioned. We've been picking up more and more sulci, and probably these are the most superficial ones which were missed earlier and now getting picked up because we have better equipment, also because there's increased awareness about the presence of sulcus. Now, I'd like to discuss the various classifications of sulcus. Boucher was the first individual to basically describe sulcus in 1985, where he said there's a sulcus virgature and there's a sulcus vocalis. And then Nakayama and Pontes gave their classifications in the same year, 1994. And Ford, which is a classification a lot of us use, came out with his classification in 1996. And I've tried to show in this graph how these sulci would sort of fit in with each other's classification. All these classifications do not very clearly define the length or the depth of involvement of the sulcus, and very rightly so, because these are classifications which are typically used during laryngoscopy, stroboscopy, and it is next to impossible to decide the length and the depth of penetration of the sulcus by doing just a laryngostroboscopy. In fact, so many sulci will be missed and not even picked up, even on high definition video stroboscopy. So these classifications are basically based with the stroboscopy system. So we have come out with we have proposed a classification of sulcus following microlaryngoscopy, not following video stroboscopy, and where we have very clearly defined the length and depth. And we can do that in MLS, but we cannot do that in stroboscopy. We've also discussed a type of surgery, a new type of surgery using the laser, and I'd like to share this with you. And once again, this has been published in the IGLP. So what is the proposed classification? It's a simple classification, very simple really, but please remember it's following microlaryngoscopy, where you can have magnification, you can have palpation, you can perform infiltration, you can perform excision. So in this classification, there is A, B, C, D, E, F. What is A, B, and C? When the sulcus length is more than 50% of the length of the membranous vocal fold, it fits into A, B, and C. A is when the depth is into the SLP. B is when the depth is into the ligament. And C is when the depth is into the muscle. Similarly, D is when the length of the sulcus or depression is less than half the length of the membranous vocal fold. When it's entering into only the SLP, it is D. When it is going into the ligament, it's E. And when it's going into the muscle, it is F. So very simple classification after MLS. Sometimes within a sulcus, you find a polyp or you find an open cyst. So you can refer that to as keratin in brackets or polyp in brackets, or if there's a cyst, then C in brackets. And if there's a mucosal bridge, you can mention MB. So this is a diagrammatic representation of our classification of sulcus, A, B, C, and D, E, F. And I just to share what we mean by this. So if you see on the right-hand side of your screen over here, we see on the left vocal fold, there is a depression. The depression is less than 50% of the membranous vocal fold length. And the depth is only into the SLP, as we know in palpation, but there is a polyp within the sulcus. So this is a left D sulcus, P in bracket. Now on the left-hand side, you have a sulcus on the right vocal fold, but this is more than 50% the length of the vocal fold. So it would become, and it's into the SLP. So it's a type A sulcus, and there's a similar type A on the left vocal fold. The difference being that the right vocal fold has a polyp within the sulcus. We do find these lesions like polyps, cysts within the sulcus very often. It's almost like the body's compensation mechanism to close the phonatory gap. As I mentioned to you, very often sulci are missed on strobe. So how many sulci are missed on strobe? What did our study show us? That we picked up only 38% of sulci by doing high definition video stroboscopy. And there was 61% of sulci which we had completely missed. So how did we pick them up? We were actually operating for other lesions like cysts, hemorrhagic cysts, polyps, and under the microscope with palpation, with infiltration, we picked up so many more sulci, which were obviously more superficial sulci. So more like the type A and the type D sulcus. What is the big deal with the sulcus? What is the problem? The problem is two-pronged. And it's a big problem because one, the sulcus is like a scar. It doesn't allow for a good mucosal wave. So the patient has got a hoarseness. Also, because there are sulci, whether unilateral or bilateral, there is a glottic incompetence. So there's a phonatory gap. So there's a leak of air. And whenever there's a sulcus, there's also, like when there's a scar, there's a high pitch to the voice. So typically the patient will have a hoarse voice, breathy voice, high pitched voice, vocal fatigue. And this is usually from a young age group. So therefore, when we talk about surgical options, we need to tackle many things. It should be a two-pronged attack, but it could be in a staged fashion. There are so many surgical options. They could be at the epithelial level, where you're just doing a sulcusectomy that is excising the sulcus, all the way down to the slicing mucosa technique of Pontes and Bellau. Or you could do augmentation techniques where you're injecting to build up the SLP using hyaluronic acid or fat or fascia lata or even stem cells now. Or you could do a medialization when the phonatory gap is so large, more than 3 millimeters, you can do even a bilateral thyroplasty with Gore-Tex or with Silastic. And you can have a combination of these surgeries also. Why are there so many surgeries? Because sulcus is one of the most challenging conditions to treat surgically. It requires a lot of effort, a lot of therapy post-operatively, and the expectations should be realistic. But interestingly, what we found is when children have sulcus, they seem to respond much better to surgical outcomes. And fat injection is probably the one thing I like to do only in children. And I have not got good results in adults in my hands, but in children, yes, maybe because of better neuroplasticity, because of better healing in children. I don't know what the reason is, but fat injection seems to do well when you inject the fat into SLP and paraglottic space. But what about adults? Now, my go-to surgery nowadays for sulcus in adults is the LASR, which is a laser-assisted sulcus release surgery, which is a surgery described by me. And how did we think of this LASR? It was thought of based on two surgeries which already exist. One is the triradiate incisions, which very often are performed for subglottic stenosis, where you make the incision with a laser, triradiate. or Mercedes-Benz incisions, and you dilate, whether with a balloon or dilator. And the second surgery on which it was based is the slicing mucosa technique of Pontes and Bellau. In their surgery, they have described making an incision just medial to the sulcus, elevating the entire epithelium of the sulcus and making small cuts at 90 degrees to the lip of the sulcus to release it with cold steel instruments. So a combination of these two in my mind really resulted in the LASR. And what is this laser-assisted sulcus release or the laser surgery? Very simple surgery indeed, where we take the AccuBlade laser and make small cuts of 0.5 millimeter at 0.5 millimeter distance from another at both the medial and the lateral lip of the sulcus. And even if it is bilateral sulcus, you can do the surgery. So the idea is to release the sulcus so that you have a raw area, an epithelium, raw area, and epithelium. And then the new epithelium will hopefully grow in the same plane and not down as a depression. So I'm just going to show you a small edited surgery of this laser surgery in this patient who's got 2 type A sulcus on the right vocal fold and 2 type A sulcus on the left vocal fold. So there are a total of 4 type A sulcus. So we put the patty in the subglottis. This is a subepithelial infiltration, which was with 1 in 10,000 saline adrenaline. And now you see the AccuBlade laser making small cuts at 90 degrees to the lips of both the sulci on the left vocal fold. So the idea is you have a raw area and then epithelial area, raw area, epithelial area, and then it should hopefully heal in a single plane. So we started by doing these surgeries in superficial sulci. We've now tried them in deeper sulci and we've been getting very promising results. So we are doing our research with that. We do operate bilaterally also as long as the anterior commissure is respected, which is the anterior 3 millimeters. As long as we respect the anterior commissure, we've not had any issues with glottic webbing. So of course, these patients require enough time for epithelialization and then a good amount of therapy. So this is the same patient's pre-op phonatory gap, and you see post-operatively, there's hardly any phonatory gap. So the new epithelium has grown well, and our therapists give therapy for almost up to 3 months to optimize vocal outcomes. This is just a table to show how our classification would fit in with the other classifications, but there's a very big difference because ours is falling after microlaryngeal surgery and the others are not specifically after that. So what is the conclusion of my sulcus bit of the talk? That is the microlaryngeal examination and palpation of the vocal folds in our study revealed a sulcus in 61% of stroboscopically undiagnosed vocal folds. That's a very high number. And that vocal outcomes of surgery of sulcus are unpredictable. Our target is both phonatory gap and repair of SLP. Voice therapy is prolonged, and do the surgery which you're most comfortable with, but give a realistic outcome, vocal outcome result to the patient before surgery. And finally, to come to the last bit of my talk, which is regarding mucosal bridge. A mucosal bridge, many of us may not have even seen. What is a mucosal bridge? It's basically a thin band of mucosa which is attached anteriorly and posteriorly to the vocal fold, but it is not attached at the medial vibrating edge. So you can pass an instrument underneath it. So therefore, it is like a bridge. And occasionally, these epithelial bridges are slightly thicker, in which case then they've got a center or an axis of a connective tissue. So there are different theories of formation. Always, Boucher-Connor's theory is that maybe an epidermoid cyst ruptures superiorly, inferiorly, and so you have a mucosal bridge. Maybe it's genetic, maybe it's following vocal fold microtrauma, if there is that history. And this is a patient who's got a right thin mucosal bridge. So we took the patient up for surgery for the hemorrhagic cyst. And on palpation, we saw that we palpated the thin mucosal bridge. It's felt that maybe hoarseness besides the hemorrhagic cyst may also be in mucosal bridges because of two separate vibratory characteristics, one of the vocal fold, one of the bridge. That's a theory. You can excise the thin mucosal bridge, you can leave it behind. I don't think anyone knows what is the gold standard as yet. And, you know, I don't really think it matters, but of course you have to remove the offending lesion. But what happens when the mucosal bridge gets thicker? Now on this left vocal fold, you see there's a bilobed polyp and there's something in between, which on palpation, that something is a slightly thicker mucosal bridge. So we removed the bilobe polyp, but we did not remove this slightly thicker mucosal bridge because we don't want to decrease the volume of the vocal fold and land up with a glottic insufficiency. And then you can have bridges which are really thick. This is very uncommon. You see a bilobed polyp on the right vocal fold, and it's attached to a really thick mucosal bridge. We excise the bilobe polyp. We don't touch the thick mucosal bridges. Don't excise them because that will really result in a lot of glottic insufficiency. And I show you this is the patient post-operatively, the stroboscopy. Actually, we see the point of this is the point of cleavage, as you can see, between the thick mucosal bridge and the vocal fold. So imagine if we removed this thick mucosal bridge, how thin would the true vocal fold become? So please don't excise thick mucosal bridges. What can you do? You could just leave it untouched, or you can freshen the opposing surfaces and glue them or suture them. And then Chang has presented or published a PDL glottoplasty with mucosal bridge undermining paper. So you could try that. Excision for the thinner ones, I think, is okay if you want to. I would like to mention here that we have also discussed a third type of mucosal bridge, which is an incomplete mucosal bridge. And we've published this in the European archives. So what do we mean by this incomplete mucosal bridge? Sometimes during palpation, we found that there was a slit, but this was not a focal pit. Our instrument would enter and almost enter the laryngeal introitus and just fall short of entering. And this was what we termed as an incomplete mucosal bridge. So, of course, a picture says 1,000 words. So let me show you what I mean. Over here on the left vocal fold, there's a slit. Right vocal fold has a cyst. So when we put an instrument in, you see how it enters, and it's almost like a mucosal bridge. It's almost going to enter, but does not enter the laryngeal introitus. So this is what we termed as an incomplete mucosal bridge. And interestingly, all the time, the movement was always from lateral to medial. So an incomplete, this is a patient who's got a left open cyst and a slit on the right vocal fold. We put the instrument, there's an incomplete mucosal bridge. So we freshen the opposing edges and we suture it together. And whenever we do suturing in the vocal folds, healing takes a lot longer. And it's very unusual to see a mucosal bridge on stroboscopy. Almost always you'll miss it and pick it up on palpation. But in this case, and you'll see for yourself, a dramatic mucosal bridge, thick one of the left vocal fold, where the mucosal bridge is literally flopping around during stroboscopy. This patient had a biopsy done in South India. Actually, a biopsy was done. So I don't know whether it was post-biopsy or the patient had it already. And then when we performed an excision of the congested left vocal fold mucosa, we diagnosed it as sarcoidosis. Patient was started on steroids, is doing well, but it's very unusual to see a mucosal bridge like this on stroboscopy. And finally, so this is my third conclusion, that thin mucosal bridges may be excised or left alone. Thick ones, don't excise them to avoid the loss of bulk. But there is no gold standard out there yet, which has been set in the care of mucosal bridges. So someone needs to do that. Incomplete mucosal bridges, as described by us, are seen as a slit, and palpation is needed to diagnose them. And it's recommended that all patients undergoing microlaryngeal surgery be actively palpated for the presence of sulci and mucosal bridges. Why? Because it's vital for the accurate identification and documentation of all the lesions that exist in that particular patient, which are responsible for the patient's voice. You may be just removing a hemorrhagic cyst, but you need to document, okay, there is a sulcus, there is a mucosal bridge. You can guide the patient that maybe you won't have a perfect voice because that's the character of your voice because of these lesions. And in our series over this 2009 to 17 period, if we saw out of all the benign glottic lesions we operated on, that the bulk of what constituted the cyst sulci mucosal bridge was around 16%, which is pretty similar to Boucher's study of 15% in 1985. So with that, I thank my oration talk, and I'd like to thank all of you once again, and I'm going to stop my share. Thank you very much. If there are any questions, I know they're not permitted in the oration, so you can please email me on nupurkapoor@yahoo.com if you want.
Hello.
Hello.
Madam. Hello.
Yes.
Madam, thank you very much for your nice lecture. Because for a long time, after a long time, we are hearing such a good lectures on laryngology. Because I am a president of South India, South Zone president and AP state president. Thank you once again, because you are known for your laryngology. We have heard a lot of times for your lectures, and it's a very nice lectures. Because nowadays the tune of the ENT surgeons are towards the skull base, towards the endoscopic nose surgery, towards the otology. Now you are again enlightening us by your good lecture on the laryngology. Once again, thank you very much, madam, for your nice lecture, for your nice pictures, for your precise note. Thank you very much, madam.
Thank you.
I request Dr. Krishna Kishore sir to please come on to the dais. Give mementos to Dr. Sriramurthy garu and Subbarayadu garu.
But I was asked to call everybody, sir, irrespective of who is there.
Okay, no issue, no issue.
Yes, sir. A warm welcome to all the dignitaries and delegates to the 16th AOI South Zone and 39th AOI Andhra Pradesh State Conference being conducted at Geetham Institute of Medical Sciences and Research on 8, 9 and 10th October 2021. I am Dr. Kriti Apurva, a final year ENT postgraduate, here to host today's program. This is a dynamic step in this COVID situation to bring all the ENT fraternity to one place and achieve great purpose through extensive lectures and discussions on various topics of otorhinolaryngology. This is a hybrid conference with 180 delegates in person and another 400 delegates following us on online platforms. We have highly anticipated lectures and live surgical demonstrations from eminent personalities of ENT, which we promise will be nothing less of a feast for the mind. On this note, I would like to invite the dignitaries onto the dais. Firstly, I would like to call upon Dr. B. Sriram Murthy, President, South Zone and AP-AOI Chapter. Next, I would like to call upon Dr. C.V. Rao Garu, Pro Vice Chancellor, GIMSR, ex-Vice Chancellor, NTR University of Health Sciences, to please occupy his chair on the dais. I would like to invite Dr. Y. Subba Raidu, Secretary, AP-AOI, to please come on to the stage. Next, I would like to call upon Dr. T. Krishna Kishore, Organizing Chairman, South Zone AP-AOICON 2021, to please come and occupy his chair on the dais. I would like to invite Dr. S. Surya Prakash Rao, Organizing Secretary, South Zone AP-AOICON 2021, and President of Association of North Coastal Andhra ENT Surgeons. I humbly request Dr. SZ-AP-AOICON, Chief Convener, South Zone AP-AOICON 2021, past President of ISO and past President of South Zone, to please occupy his chair. It is my honor to invite Dr. K. Jeevan Pradeep, Superintendent of Government ENT Hospital, Andhra Medical College, President-elect Association of North Coastal Andhra ENT Surgeons, to please come onto the stage. I would like to invite Dr. A. Achyutrao, Observer APMC, to please occupy his chair on the dais. It is my pleasure to invite Dr. J. Srinath, President-elect AP-AOI, to please come onto the stage. Next, I would like to invite Dr. M. Sudhakar Rao, Treasurer, AP-AOI, to please come onto the stage. It is a pleasure to invite Dr. Leela Prasad, Treasurer, South Zone AP-AOICON 2021 and North Coastal Andhra ENT Surgeons, to occupy his chair on the dais. I humbly request Dr. B. Nageshwar Rao, Secretary, Association of North Coastal Andhra ENT Surgeons, to please come onto the stage and occupy his chair. I would like to invite Dr. Jyoti Swaroop, President-elect South Zone, to please come onto the stage. It is an honor to invite Dr. P.J. Sudhakar, Scientific Chairman, to please come onto the stage and occupy his chair. Next, I would like to call upon Bharadwaj Garu, Secretary, Geetham University, to please come onto the stage. Most wonders are wrought by prayers than the world ever dreams of. I request Dr. Madhuri, a final year postgraduate from the Department of ENT Andhra Medical College, to render the prayer song for us. I request all of you to please rise for the prayer.
महागणपतिं मनसा स्मरामि महागणपतिं मनसा स्मरामि महागणपतिं मनसा स्मरामि वसिष्ठवामदेवादिवन्दितमहागणपतिं महागणपतिं मनसा स्मरामि महागणपतिं मनसा स्मरामि वसिष्ठवामदेवादिवन्दितमहागणपतिम् महादेवसुतं गुरुगुहनुतं महादेवसुतं गुरुगुहनुतं मारकोटि प्रकाशं शान्तं मारकोटि प्रकाशं शान्तं महागणपतिं मनसा स्मरामि महागणपतिं मनसा स्मरामि वसिष्ठवामदेवानुवन्दित महागणपतिम्. Thank you.
When darkness comes, let us not condemn the dark, but light a lamp to illuminate. I welcome all the dignitaries on the dais to join for the lamp lighting ceremony. Now, I humbly request Dr. B. Sriramurthy, President, South Zone and AP-AOI, to please speak a few words on this occasion.
Hello. Respected chief guest of the occasion, my colleagues on the dais, and my friends, my lecturer, my senior teachers, my colleagues and students. It's a grand good morning and my greetings to all of us, all of you. Today, ENT is developing from Jenkins lights to robotic scopes. We used to have 40 years back when I was a student, we used to have a Jenkins light, Clark's and Jenkins light to do any surgery for an examination and all these things. Today, we came a stage for 3D exoscopes and robotic scopes. They are very, very new. But only one unfortunate thing is all the instrumentation in the ENT went to the hands of some 3 or 4 companies all over the world. That is very unfortunate, because to buy some simple instrument, it costs a lot of things over crores. The robotic scope nowadays costs about the 5 crores. How many people will afford it except teaching institutes? But anyhow, the ENT is growing up like any other thing in comparison with other branches of the medical sciences. In India, when I was a student, we used to go to Bombay to learn simple middle ear surgeries. Nowadays, thanks God to the Zoom and thanks God to the teachers, we are doing everything. In Andhra Pradesh, we are on par with any persons all over India, even all over the world, because I have seen so many universities in Europe, at least 40, 50 universities. I am telling this one, and everything is very, very, very good in comparison with any other standard universities all over the Europe. Once again, my best wishes to our ENT faculty, our AP chapter of South Zone. Thank you very much.
Thank you, sir. It is my honor to invite M. Sri Bharat Garu, President, Geetham University, to please come onto the stage and occupy his chair. Now, I would like to request Dr. Y. Subbarayadu, Secretary, AP-AOI, to please speak a few words on this occasion.
సభకు నమస్కారం. వేదికపై ఆసీనులైన పెద్దలందరికీ, అలానే వేదిక ముందున్న పెద్దలందరికీ కూడా నా హృదయపూర్వక నమస్కారాలు. అలాగే నా తోటి మిత్రులందరికీ కూడా హృదయపూర్వక శుభాకాంక్షలు. ఈరోజు అంటే ఈ పాండమిక్, ఈ కోవిడ్ మహమ్మారి ప్రపంచాన్ని చుడుతూ మనందరినీ కూడా అతలాకుతలం చేసిన సమయంలో ఈ విధంగా ఫిజికల్ కాన్ఫరెన్స్ని అరేంజ్ చేయడం అనేది సూర్యప్రకాష్ గారు చేసిన అతిపెద్ద ప్రయత్నం, సాహసం కూడా. ఈ సాహసం చక్కగా ఫలీకరించి వారి మిత్రులందరికీ మరియు వారిలో టీం అందరికీ కూడా హృదయపూర్వక ధన్యవాదాలు తెలియజేస్తూ ఉన్నాను. మన ప్రెసిడెంట్ గారు చెప్పినట్టుగానే మన నాసిక గళ, శ్రవణ నాసిక గళ విషయంలో ఉంటాం, అంటే ఈఎన్టీ సర్జన్స్ మనందరిలో కూడా ఎంతగా అడ్వాన్స్ అవుతుందన్న విషయాన్ని సార్ తెలియజేశారు. అలాగే దీనిలో ఉన్న అవకాశాల గురించి మన ప్రదీప్ మొదటి లెసన్లోనే చక్కగా వివరించారు. కాబట్టి దీనిలో ఉన్న అవకాశాలు అందరం కూడా చక్కగా అందిపుచ్చుకొని జాక్ ఆఫ్ ఆల్ మాస్టర్ ఆఫ్ నన్లా కాకుండా జాక్ ఆఫ్ ఆల్ మాస్టర్ ఆఫ్ వన్గా ఏదో ఒక విషయాన్ని చక్కగా పదే పదే ప్రాక్టీస్ చేస్తే మీరు చక్కటి ప్రతిభ కలగలిచి ఈ ఆపరేషన్ని వీరు బాగా చేయగలనే విషయం కూడా తెచ్చుకుంటే చాలా బాగుంటుందని నా కోరిక. అలాగే చాలా విషయాల్లో అంటే మనకి పాశ్చాత్య దేశాలతో పోలిస్తే మనకి ఉన్న తేడా ఏంటంటే, ముఖ్యమైన తేడా ఇక్కడ మన ఈఎన్టీ అనేది 3 సంవత్సరాల కోర్సు, కానీ వెస్ట్రన్ కంట్రీస్లో ఎక్కడికి వెళ్ళినా కూడా 6 ఇయర్స్ కోర్సు. అంటే బయట అంతా కూడా ఇది చాలా సూపర్ స్పెషాలిటీగా రికగ్నైజ్ అయిన కోర్సు. కాబట్టి ఇక్కడ మనకున్న అవకాశం 3 సంవత్సరాలు. ఈ 3 సంవత్సరాల కోర్సుతో మీరు ఆగిపోకుండా తదుపరి మీ పోస్ట్ గ్రాడ్యుయేషన్ తర్వాత అందరూ కూడా ఏదో ఒక విషయంలో దానికి సంబంధించిన ఫెలోషిప్ కానీ దానికని చేయగలిగితే చాలా అవకాశాలు అన్ని విపులంగా పుష్కలంగా ఉన్నాయి. వీటన్నిటిని ఉపయోగించుకొని మీరందరూ కూడా చక్కగా ఎదగాలని, మన ఈఎన్టీ ఫ్యాకల్టీకే ప్రత్యేకమైన గుర్తింపు తీసుకురావాలని కోరుకుంటూ నాకు ఈ అవకాశం ఇచ్చినందుకు కూడా టీం కనుక కూడా ధన్యవాదాలు తెలియజేస్తున్నాను. థ్యాంక్ యూ.
Thank you, sir. Next, I would like to call upon Dr. T. Krishna Kishore, Organizing Chairman, South Zone AP-AOICON 2021, to please address the gathering.
Chief guest of today's function, Sri M. Bharat Garu, guest of honor, Dr. C.V. Rao Garu, President, South Zone and AP, Dr. B. Sriramurthy garu, Dr. Y. Subbarayadu, the Secretary of OAP, Dr. S. Suri Prakash Rao, Organizing Secretary of this conference, and Dr. SZ-AP Rao, the Chief Convener for this conference, and all my friends, Dr. Pradeep, Leela Prasad, Nageswar Rao, Vijay Sudhakar, Jyoti Prasad, and all the delegates who are present here. It's like almost most of us are meeting here for after 2 years almost because of the havoc created by the pandemic. This conference actually was scheduled to be held last year, 2020 October, but it got postponed by 1 year. And even now, we are in such a state that we are able to organize this only as a hybrid conference. This first of its kind is happening like this, a hybrid conference in the history of South Zone and perhaps in other conferences around. And this actually is a new concept, and we must appreciate 2 persons behind this conference, Dr. Suri Prakash Rao, the organizing secretary, and Dr. SZ-AP Rao, the chief convener. They have really put a lot of efforts and with all their vision, wisdom, and all the expertise of their organizing skills. It's not easy to organize this kind of conference. It requires a lot of technical support and all, but we really thank them a lot for taking all the efforts and make it a grand success. And coming to this, our ENT faculty, we have seen the emergence of the epidemic, mucormycosis epidemic. And now the world has recognized the importance of an ENT surgeon. How effectively we could deal with the dreaded mucormycosis. We can say with proudly, I'm an ENT surgeon, because a multidisciplinary approach of mucormycosis, the leader has been the ENT surgeon. The neurosurgeon and the neurophysician above, the ophthalmologist here, the pulmonologist here, the ENT surgeon has been in the key position, commanding and doing the best, saving many lives of the mucormycosis patients. That's what greatness of our faculty. Right. I feel really very sorry for the postgraduates. The past 2 years, one batch recently passed out. Usually they get a lot of chances, the surgical chances, and to do the things. It happens only during the final year. The entire final year, they have spent only taking the swabs, nasal swabs. I really feel very sorry for them. Even the second year and first years, now they got promoted to the second years and final years. They have not actually seen what ENT work is like. They are never exposed to what the routine work, ENT work should be like. But I assure you, be hopeful. Luckily, is waning off. The pandemic is, the nature of the pandemic is like this. You are likely to get, as per the epidemiologists, they are predicting there is supposed to be definitely a third wave, but it's not going to be that severe due to various factors. And after that, probably 2022, we are going to have good time where all these postgraduates passing out, and they can have more number of workshops, conferences like this, and they can work in some institutions for fellowships and all. They can they definitely get all the exposure and expertise needed. And we are all here as seniors to support them, to guide them, and to train them. So with these few words, I once again thank the people of Dr. Suri Prakash Rao and Dr. SZ-AP Rao for organizing a wonderful conference here. And thank you. All the best. All of you.
Thank you, sir. Now I request Dr. P.J. Sudhakar, Head of the Department of ENT GIMSR, to introduce our chief guest, Sri Bharat Garu, President Geetham University, on this occasion.
Good morning, everyone. Can I hear a good morning from you? Thank you. I deem it a privilege and honor to introduce Sri Bharat Garu. Though he doesn't need any introduction to do the honor and the formality, but I was given the pleasant task of introducing him. He is a great personality, a man of integrity, and a good academician, and above all, is a great humanitarian. He also the president of the prestigious Geetham deemed to be university. The university was set up in 1980 in Visakhapatnam by great visionary, late Sri MBBS Murthy Garu. Currently, the university has 3 campuses, the Hyderabad, Visakhapatnam, and Bangalore, with 20 schools and a student body over 23,000. Regarding to the academics of Sri Bharat sir, he holds a undergraduate degree, bachelor's in industrial engineering from Purdue University, West Lafayette, Indiana, US. He belongs to class 2010. He also completed a joint degree of MBA and MA education in class of 2016 in a prestigious Stanford University, California, USA. Sir serves in various capacities in organizations in the states of Andhra Pradesh, Telangana, and beyond that. He also serves as a board of member in TAI Amravati, a chapter that engages the entrepreneurs from the entire state, especially Visakhapatnam. He also a board member in Basavatarakam, Indo-American Cancer Hospital, Hyderabad. He is the retreat chair and former chapter president of EVO Andhra Pradesh and an active member in Hyderabad Angels and Andhra Angels, a network of leading entrepreneurs. He is also investor and advisor for select group of the startup companies. After returning to India from Stanford in 2016, Sir established 3.5 megawatt solar power plant and led the company's foray into solar power generation. He is also diversifying into hydrogen and chemical waste treatment. He is deeply passionate about utilizing his knowledge and skills to develop the renewable energy, sustainable growth, and waste management treatment. His past experience include commissioning of a 460 megawatt gas-based power plant, quality control and operations in La Sofia, Chicago. His stints during his MBA, the innovation delivery team of Atlanta Mayor's Office, USA, and a marketing immersion in Sheraton Honshu, Taiwan. They are very much commendable. So he is the backbone to the Jimsar Institute and also especially to the Department of ENT. Just to tell us one example, during first wave, when I was in a state of confusion and also in a desperate state, what we are going to be given the PPE of its quality or not. So when I discussed with Bharat sir, he concluded it by saying, how much does the best PPE cost? So it answered every problem and give a solution to my confusion. So this is a single one example to say the how big is his heart. So can I have a clap offering for his? At this moment, I would like to acknowledge the presence of Dr. Sivarav sir and also my principal madam, Jyoti Padmaji garu. Now I invite Bharat sir to address the gathering. Just before that, I request Bharadwaj Secretary sir to come and occupy the dais.
Good morning, everyone. Sudhakar garu, how many people are participating virtually? Hybrid lo entamandi untaru? Okay. To dignitaries on and off the dais, doctors, apologies, I was slightly delayed. I was at a public program and that's why I'm dressed not appropriately for this event, but I didn't want to be late. So I came as quickly as I could. Can you all hear me okay? Okay. Krishna Kishore garu, mere kadandi. Meer antunnaru after the pandemic has come, there's recognition. I disagree with you. Recognition has been there from the beginning. In fact, as a child, the only doctor I used to frequent is a ENT doctor. So I don't know other doctors as much. So constantly I used to have some issue, tonsil or cold or something. So I think the importance that a child notices is not how serious the disease is, but how often it comes. And for me, the cold is something that was a very frequent visitor. So in that sense, the ENT doctor is very, very important to me. And the other thing that you mentioned, very, very important, is unfortunately the training or the lack of proper training for postgraduate students, not only in this discipline, but in any discipline over the last year and a half. Our good fortune is that our PG program didn't start by then. We're starting it now. We will be admitting PG students in the next in the next month or two. And hopefully when they come, we will be able to see a good caseload of a different variety of cases where both surgical and the medicine branches will be able to practice. And to Dr. Sudhakar, who introduced me, I feel embarrassed every time they read that out because that's a 3-year-old introduction before I became president of Geetham, and I'm not doing many of those things today. So I can't wear so many hats. Most of my life is dedicated to Geetham today and also a significant part to public life. So about the topic today, I think I'm happy to see all the doctors, young, medium age and old age doctors here, seniors who have vast experience. I think because this conference is happening here, I think a request that I would like to extend to dignitaries on the dais and doctors sitting in front of me is as we begin this PG program at Geetham, the intent is not just that we will train our students in understanding the knowledge in their particular domain and that they will practice skills, but also that we inculcate a growth mindset in these young doctors and that they will walk in the path of research. So this is something that I say at almost every medical event that I am a part of, because the pandemic has been a rude shock to us amongst others that there is so little that we can control in this world. And the only thing that we can do is be prepared for any eventuality that comes. And that can only happen when we are very agile and open as a culture. We are not that agile and open as a culture today. And that is a challenge. But if we need to change that, I think the seeds are going to be laid today in our young postgraduate students. So I request you all who are here, particularly with a bent of mind towards research, please spend time with us in whatever capacity, engage with our leaders and push us really hard in how we can create a positive and self-sustaining research ecosystem. And like Dr. Sudhakar said, our advantage as a university in Vizag here is we're a multidisciplinary environment. We have an engineering school, we have a science school, we have a management school, and doctors can collaborate with students from different disciplines to do research projects. I can give an example here. When I was at Stanford, there was a course over there called Design for Extreme Affordability. And that course is done by students from diverse domains. So from business, from engineering, from computer science, from medicine, from law. So one of the projects that one of my seniors did in that course ended up becoming a nonprofit company that started its operations in India. It's called Embrace. It was a portable baby incubator that they imagined and built the first prototype at Stanford. But they were able to, that was born out of lawyers understanding what is the legality around portable baby incubators, business students understanding what is the business model, doctors understanding the technicality of what are the specifications that are required for a baby to be safe, engineers to build that product, and computer science graduates to see how technology can be leveraged. So this is the world of possibility that we are heading into. So I think demonstrating excellence and depth within your own domain is welcome, and this is something that you all are very good at. But I think the future ahead of us is not one that is going to help us if we are limited only to our domain. So when I say research, it is not just within your domain, it is that interdisciplinary research that is very, very important. And when you say mucormycosis, is that black fungus? Is that what it is? Yeah. So I know one of our senior leader got something and we all were afraid that it was black fungus. And they cut some tissue from his throat and he ended up not being that. But there is so little we know. That's basically, I think, every time something like this comes. And while the ENT is dealing with one particular domain and I'm not a subject area expert, but I'm very curious about the kind of challenges that come up in neurology, because I think there's so little that we have done in understanding the challenges in neurology. My maternal grandfather got a brain stroke and he's partially paralyzed today. And any doctor that we've talked to, whatever they say, there's very little comfort that's given to me because after a lot of education, I think what they only know is how they can control the blood clot, but they don't know how the brain functionality and body functionality is going to come back. So I think it's just, especially for the younger doctors here, I think the world is our oyster and there is so much that we can do to discover and develop knowledge. And I think that's the path that we want to head out as an institution. We are not happy being a regular teaching or practice institution. We want to be the leader in the areas of knowledge discovery, knowledge development, and delivery of such knowledge in terms of research and patient care in the future. Thank you. Thank you for the organizers to selecting Geetam for this, and I wish you all the best in this conference and beyond. Thank you.
Thank you, Bharat Garu, for your nice words. And we are humbled by your immense respect towards doctors. Next, I would like to call upon Dr. C.V. Rao Garu, Pro Vice Chancellor, GIMSR, ex-Vice Chancellor, NTR University of Health Sciences, to please speak a few words on this occasion.
The President and Secretary of the Geetam, my colleagues on the dais, fellow delegates, students and guests. Good afternoon to all of you. I'm happy that the ENT department of GIMSR has come forward to host this conference of AP and South Zone. And we are also fortunate from this year, we are going to have the PG courses in the ENT also, along with other specialties. In a conference, usually we meet to empower ourselves on knowledge and skills. Probably these are the two objectives of any conference. So this conference is also no exception for that rule. But apart from that, more important things we are neglecting today. That is developing a good attitude and a good character. These two are also very essential for success in life. When you develop these two qualities, you will imbibe unknowingly the most important one, that is what is called the trust. Unless you develop a trust, it is very difficult to work in any type of environment. Today, the medical profession is facing the problem from the public because of lack of that 5-word, that trust. That is the word which is lacking. So probably it is wise on part of the organizers to have some non-medical subjects also like this to build up a personality. That is also very important for success in life. Not only the education and skill, but how to communicate. We all know that communication is a skill. One of the soft skills is also a communication. When you go for communication, doctors or a medical profession as a whole are very poor communicators. We want to say something, but doesn't know how to say. That is our problem. So probably we need some type of basic training along with medical training on communication. It resolves so many issues. The first issue is we all feel that communication is only talking. It's not talking. Talking is only a minor part of communication. It is the listening which gives a lot of communication. By listening, you will be able to absorb so many things without much effort. But we all are accustomed to hear, not to listen. The hearing is a passive process, but listening is an active process. When you want to listen, you have to concentrate really on the subject on which somebody wants to present to you. But we don't have that much of patience to listen to that. We only hear and forget about it. So that leads to so many problems which we may not be able to resolve in quick succession. So imbibe the habit of listening to resolve many issues which we face day in and day out, both at home and at work. That's very, very important. You approach for work on a daily basis, not on a quick succession. So every day you will face some problem, you approach that problem and try to resolve it with your knowledge and skill and also with communication skills. There are 4 things which you have to imbibe. We know that 4 L's: live, love, learn, and live. We all live for survival with food and shelter, clothing. That's all any human being will do it. Then we like to be loved by the society, neighbors, family members. That is also again a human requirement for survival. The next step is we try to learn. That is very, very important. And that is what is after education also, after passing the degrees also, we'll have that learning process. That is what we call in a medical term CME programs. It's a continuous learning, especially medicine is a continuous learning. So that will be useful for exhibiting or performing your skills and exhibiting your knowledge. Everything comes through the learning. After everything is over, then you have to leave something. for the society and for the remembrance. That is why there was a beautiful book, Die Empty. In that, the director of a big organization had a meeting with the participants of the working heads. Then he said, what is the richest place in the world? Some people said it is the Gulf oil fields. Some said it is South African gold mines. Some said it is Manhattan. What he said, no, it is not like that. It is a burial ground or a cemetery. Why he said like that? Because many people have so many ideas, but it is not communicated. It is not dissipated. They die with the ideas inside, so that becomes the richest place. That made the author, who was an observer in that meeting, to write that book. So always see that your knowledge is dissipated and people get benefited, and ultimately the society gets benefited. That is very, very important. When you come to the medical field, today, the expectations of the public are very high to resolve their health problems. But most important thing which we are facing today is safety and quality of the services which are rendering. This is very, very important. According to a report from 1999, in America, 1 lakh people used to die because of the medical negligence or medical errors. So that they have calculated a jumbo jet crashing every day. In India, today, around 5 lakhs people are dying because of medical errors or medical negligence. But we don't have any solution for that. There is no formal training on that. Maybe some good institutions are adopting some protocols, some SOPs, all those things. But we have a long way to go. And I think it is time in the conferences of this nature to include that. What is the patient safety and what is quality of services which are rendering? The first and foremost thing is you should see that a patient comes, let us not do more harm to the existing problem. That is one. And we should see that any harm is done, it is reported and it is discussed, and then a solution is found, and that is all the participants in that organization or the people who are working in the organization should be properly trained not to repeat those mistakes. These are some of the small steps I think we can do, and it will go in a long way. And with this, I thank the organizers for giving me this opportunity to participate and share a few ideas. Thank you very much. I wish the conference a grand success. Thank you.
Thank you, sir, for your knowledgeable words. Before we continue with the next speaker, I would like to invite all the dignitaries on the dais to please felicitate our chief guest, Shri Bharat Garu, President, Geetham University. I request Dr. B. Sriram Murthy Garu to please carry on with the felicitation. I would like to ask the dignitaries to please present a memento to Bharadwaj Garu. I would like to invite Dr. SZ-AP Rao, Chief Convener, SZ-AP-AOICON 2021, past President of ISO and past President of South Zone, to please address the gathering.
Respected President of today's function, Dr. Sriramurthy, and dear colleagues, ladies and gentlemen, as you all know, an ENT faculty has grown up to such an extent. You all know that we have special senses like vision, hearing, smell, taste. When you come to the role of ENT surgeon, dealing with the special senses, now not only smell, not only taste, not only hearing, we are also part of preserving the visual disturbance also with latest endoscopic equipments and the sinus surgeries. And of late, we had a better experience with the mucormycosis. Most of our colleagues experienced rich experience got through our senior colleagues also. In those cases, we have played a major role in preventing visual disturbances and life. So with the advent of endoscopic sinus surgeries, we could save so many people's lives in this pandemic, severely affected the mucormycosis patients. And not only this, our ENT branch has got a lot of responsibilities, like dealing with the problem of deafness. The hearing is very, very important for a normal human life and active life. Maybe people claim that vision is very, very important, but I can say hearing is arguably more important because the blind person is missing the world of things only, but whereas a deaf man misses the meaning of the life. Unless he hears, he cannot participate in the conversation. For example, today all this audience are because they are listening, they are enjoying the conferences because they not only vision, it is of the hearing. So, and apart from that, the other common problems like allergies, headache, malignancies, all under the branch of ENT. So our target of the senior colleagues' target is to train, to assist, to help the junior colleagues to uplift their knowledge for benefit of the society. Thank you very much. Thank you very much, please.
Thank you, sir. Now I humbly request Dr. Jeevan Pradeep, Superintendent of Government ENT Hospital, Andhra Medical College, President-elect Association of North Coastal Andhra ENT Surgeons, to please speak a few words.
Good afternoon, everyone. Dignitaries on the dais, my professor, Dr. C.V. Rao Garu, other colleagues, students, and the faculty sitting in the audience. A warm good afternoon to you all. After so many persons have already enlightened everything about the conference, I don't think I'm left with any words to tell more. This was an untiring effort of Dr. Surya Prakash Rao for the past 2 years. Almost once in a week, he used to discuss about the conference, how to do it, whether we are going to do with surgeries, some topic or the other regarding the conducting this conference was in his mind, and he used to ask us so many times, and at times we got so pestered also. He is killing us like this, but it is his untiring efforts. You take it for granted. Anything that he takes up, he does it with the same spirit, and that is why we are having such a wonderful conference here. A big applause to Dr. Surya Prakash Rao. Another thing I want to add, Dr. SZ-AP Rao Garu has told about the special senses. A human being, he needs
a shelter to stay, nice food to his stomach, and most of all, a very good night's sleep. So sleep apnea is one thing which is on the vogue now, and I wish all the youngsters get trained enough to let everyone sleep happily without snoring. Thank you.
Thank you, sir. Now I request Dr. S. Suryaprakash Rao, Organizing Secretary, South Zone AP-AOICON 2021 and President of Association of North Coastal Andhra ENT Surgeons to please speak a few words on this occasion.
1 minute.
I request Dr. A. Achyutrao Garu, Observer APMC, to please speak a few words.
Congratulations, all organizing committee members, especially Suryaprakash Rao sir. So all the best. And one more thing, very important thing. So thank you every ENT surgeon. You are the first in front of a difficult situation at the starting of the COVID situation. ENT surgeon is the main one who do the swabs, taking the swabs. If I call any ENT surgeon, I am busy with swabs and everything. So that's why we are saving our total Indian or not Indian, every human population lives we are saved. Thank you very much.
Thank you, sir. Now I request Dr. S. Suryaprakash Rao Garu to please speak a few words.
Good afternoon to this staggering gathering here today at the 16th annual conference of South Zone and 39th annual conference of Andhra Pradesh chapter of Association of Otolaryngologists of India. Respected dignitaries on the dais, our chief guest for the event, respected president who left because he is busy with some other job, Mr. M.C. Bharat Garu, and the secretary also, he left because he is having another job, Mr. Bharadwaj Garu. Our mentor, our guide from the student period is our superintendent, principal, and DME, and also is the NTR Health University Vice Chancellor and Pro Vice Chancellor of the Geetham Institute of Medical Sciences, Dr. C.V. Rao Garu, President of South Zone and AP-AOI chapter, Dr. B. Sriramurthy, and the Secretary of AP-AOI, Dr. Subba Rayudu, our organizing chairman, my friend of the conference is P. Krishna Kishore, Chief Convener of the conference, Dr. S.K. Apparao, the President-elect of our North Coastal Andhra Association of ENT and the present Superintendent of the Government ENT Hospital, Dr. Jeevan Pradeep, and our APMC, the Andhra Pradesh Medical Council Observer, Dr. A. Achyutrao Garu, and all my esteemed colleagues and friends, and my dear students and postgraduates and the guests. I thank you all for gracing the stage for the inaugural function of our conference. The 16th annual conference was initially scheduled to be held in the year of 2020, as you all know. Owing to the course of the COVID pandemic, it went indefinitely postponed. In the current year 2020, when the pandemic situation seemed slightly under the control, we set out to oversee this conference in the month of October entirely virtually, actually. During the course of which, seeing the eagerness of our young and dynamic ENT surgeons with the suggestions of our most senior and brilliant ENT fraternity, decision was made to convert the conference into hybrid pattern on the 15th September of this year, that is about 3 weeks back from today. This hybrid pattern of conference, though entirely new to us, I can proudly say that we managed to accomplish quite a substantial feat in such a short span. With the extended cooperation of the ENT surgeons of North Coastal Andhra AP-AOI chapter, we are delighted to inform you all that of the 5 states coming under the South Zone, namely Telangana, Tamil Nadu, Karnataka, Kerala, and Andhra Pradesh, we have received the participation of about 650 delegates for this conference. Next page. Of which 180 plus delegates are attending physically, because we have a limitation. We have to limit for 180 delegates. We received an array of submissions, 100 abstracts for postgraduate poster presentation, 75 for postgraduate case series presentations, 79 for postgraduate case report presentations, about 25 abstracts for the consultant paper presentations, and 4 entries for the consultant video presentations. I thank each and every one of them for their enthusiastic participation. As these presentations are from both physically and virtually attending delegates in this 16th annual South Zone Conference, in a manner never done before, with the permission of the AOI chapter and South Zone, 2 gold medals will be presented in each category of PG presentation, that is physical and virtual. In both physical and virtual, everybody get 1 gold medal and 1 silver medal, and 1 gold medal, 1 silver medal, to encourage, because the number of participants are very high. I would like to extend our gratitude and thank Geetham University, headed by Mr. Sri Bharat Garu and Pro Vice Chancellor, Geetham Institute of Medical Sciences, Dr. C.V. Rao Garu, for wholeheartedly accepting our request to conduct the 16th annual South Zone Conference here at the spectacular auditorium within the premises of the Geetham Medical College. Thank you, sir. C.V. Rao, sir. I also thank the hospitality and technical team of Geetham Medical College for the spick and span venue and the smooth running of the program. I reached out my thank you to Mr. Ranjit Kadam of the Sun Pharma for providing us with the top-notch audio visual team, headed by Mr. Dinesh from Bombay and Pawan in this area. I thank my colleagues and dear friends, ENT consultant of North Coastal Andhra, ENT surgeons of the government ENT hospital. Even though I am the government ENT hospital, I retired in the last November. At that time, we planned everything. And Geetham Institute of the Medical Sciences and the Gayatri Vidya Parishad Institute of the Medical Sciences, tirelessly putting in their hard work, time, efforts into the planning of this conference, without whom conducting such a new pattern of conference would not have been possible. They deserve all the applause. I thank all the members of the AP Executive Committee and South Zone Committee senior advisors and presidents and secretaries of AOI, all states under South Zone, for extending their support and best wishes. I especially thank Dr. S.K. Apparao, who has always stood by my side, guiding me along the way more like a twin brother than a colleague. I also thank Dr. P.J. Sudhakar, Yogandhar, and Srikar, their team, and the other team, Dr. Jeevan Pradeep, Dr. Raghunath Babu, and Leela Prasad, Nageswara, and the government hospital team. And particularly, I thank our team from the Gayatri, which is headed by Dr. M.E. Apparao Garu. I thank M.E. Apparao Garu, Dr. D.R. K.L.N. Raju, and Niharika, and Srinivas Nursing, and Leela Soumya, who worked all the days, even though I asked them to come up, give some information at the 11 or 12 o'clock also, without any hesitation, they used to do that. Thank you very much. Next. I would like to thank especially to the Sarojini and also the Susruta. They used to do the all computer and also the planning of the presentations at their places, and they together contributed a lot of efforts for the success of this conference. Thank you. And my wife, Dr. Padmavati, now the head of the Department of Gynecology, even though I used to work at 12 o'clock, but she used to continue in the wake-up stage. And of course, you know what is my position. I thank especially from here to Dr. Padmavati and my daughters. I would also like to apprise that the North Coastal Committee has requested the relocation in rotation of head office of the AP-AOI to Visakhapatnam, to which the AP executive and the general body has given their AP executive has given their consent happily to put forward and relocate the office to take place once in every years, all the 3 zones. 6 years, once in 6 years. We are looking forward to conducting a national conference here at Visakhapatnam and hope to receive the same amount of warmth and participation from all of them, those who have given cooperation in this occasion. Here at our 3-day conference, we are thrilled to inform you the participation of very good number of pharmaceutical and medical equipment companies in stalls. I would like to thank each one of them for being so responsive and taking an active part in our conference. They have brought together an extravaganza of medical equipment, instruments, and advanced medical molecules all at one place for us. I request delegates to utilize this opportunity. Last but not the least, I thank the media personnel here with us today for their active coverage of our conference. I thank each and every one of you once again for your the part you played with us well in the conference of either physically or virtually in making this conference a grand success. I hope every one of us leave this venue each day and return with newfound enthusiasm. Like the words of Doris Lessing, that is what learning is. You suddenly understand something you have understand all your lives, but in a new way. Let us learn and relearn. Hope all of you thoroughly enjoyed the 3-day scientific spread of our conference. I will see you once on the other end. Thank you all once again. Actually, this paper was written, if I miss anybody, I should not hurt anybody. At the last, I wanted to excuse me if any person I have forgotten. I wish all you enjoy here. Thank you very much. And here now, the presentation of the first results have come in the physical here. we want to present the medals here on the stage.
I would like to now call Dr. Tanveer to announce the winners for the case report and series among the PG delegates who attended in person today.
Good afternoon, everyone. In the genre for case series, the first prize or the gold medal goes to Dr. M. Nilima for her topic being partial uncinectomy versus total uncinectomy in cases of chronic rhinosinusitis. I request Dr. C.V. Rao Garu, the Pro Vice Chancellor of Geetham's Institute of Medical Sciences and Research Foundation, to present the award to the gold medalist. Dr. M. Nilima. From Andhra Medical College. Dr. M. Harshita receives second prize for retrospective evaluation of patients undergoing tracheostomy in tertiary care hospital. Dr. M. Harshita. In the genre for case reports, I request the first prize goes to Dr. Kriti Apurva from Andhra Medical College. On behalf of Dr. Jyoti Swaroop, sir, who is the upcoming South Zone President of AOI, I request Dr. Kailash Pujari Garu to present the medal. Second prize goes to Dr. L.K. Nitya from Andhra Medical College for her topic, a case report of nasopharyngeal carcinoma, rare presentation.
I thank all the dignitaries and the delegates for joining us for the inaugural function. Now it is time for lunch. Thank you, one and all. Let us all wait for the national anthem. जन गण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंधु गुजरात मराठा द्राविड़ उत्कल गंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जाहे तव शुभ आशीष माहे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे। We'll break for lunch now. We'll break for lunch now. We'll convene again at 2 p.m. I request all the delegates to be back by 2 p.m. for the next session. Thank you, one and all. Garu on challenges in cochlear implantation. The chairpersons for this session are Dr. Krishna Kishore Garu and Dr. Leela Prasad Garu. I would like to call upon Dr. MVSS Baparao Garu to introduce Dr. Mohan Kameshwaran Garu to us.
Good afternoon, everyone. I'm very happy and excited. Mike. I'm very happy and excited to introduce my Guru, Professor Padma Shri Dr. Mohan Kameshwaran Garu, for this August audience. Professor Kameshwaran Garu, Mohan Kameshwaran Garu, is graduated from Madras Medical College in 1978 and did his DLO and MS from the same institute. He has been a recipient of the prestigious Padma Shri Award from the then late Abdul Kalam Garu in the year 2006. He has also been a recipient of the prestigious award from the Medical Council of India, Dr. B.C. Roy Award for the year 2008, from the then President Pranab Mukherjee in 2016. He was also awarded the prestigious Indo-Australian Award for his meritorious service by the Indo-Australian Association. He also received award for excellence of service in appreciation of contribution to pioneering cochlear implant program in Sri Lanka by the President of Sri Lanka in 2006. He is the only Indian to be elected as a member of the governing body, Asia Pacific Cochlear Implant Board, in the year 2007. He was the president of Asia Pacific Symposium on Cochlear Implants and its related science. He was conferred Honorary Fellow of Indian Academy of Otolaryngology, Head and Neck Surgery in August 2016. In the same year, he received Lifetime Achievement Award at the 10th SAC ENT conference conducted at Dhaka, Bangladesh, and Lifetime Achievement Award from the Tamil Nadu MGR Medical University. He is one of the pioneers of cochlear implant surgery. He has mentored and was responsible for starting 32 centers in India, cochlear implant centers, and over 7 centers abroad. He is the first surgeon in South and Southeast Asia to have performed the auditory brainstem implant and the first pediatric brainstem implant in Asia in the year 2009. He is a fellow of Royal College of Surgeons, Edinburgh. He is also the founder president of Cochlear Implant Group of India. He has over 140 publications in major national and international journals. He is the only Indian to have been invited to give guest oration at the 12th British Academy Conference in Otolaryngology, UK in the year 2006. In short, he is an embodiment of a dynamic surgeon, a brilliant academician, a great leader, a good teacher, and an emulation and inspiration for everyone to follow. I welcome Dr. Mohan Kameshwaran Garu to start his lecture. Thank you, sir.
Thank you, Baparao. Dr. Krishna Kishore, President, moderators, organizing team, and distinguished audience. First of all, I'll bring greetings to you all. And let me tell you that I really miss being there in physical form. I would have loved to have been there, but times are different and we accept the inevitable. Having said that, I must congratulate the organizing committee for putting together such a wonderful program in this very difficult time. I mean, the scientific program is an absolute masterpiece, and it's really heartwarming to see such eminent speakers coming together in this scientific forum. I've been asked to talk about the challenges and solutions in cochlear implantation.
Now, in the 90s, when we started cochlear implant surgery, life was so much simpler because it was very clear cut for us. We would only take straightforward cases. We did not take any patients with abnormal cochlear anatomy, nor would we take any patient who was syndromic. So it was congenital profound hearing loss or postlingual hearing loss in people who had essentially normal anatomy. And in that kind of situation, it was an extremely simple, predictable surgical procedures with predictable outcomes. But situations have been changing in the last 20 years. Things have changed so much that we are now increasingly doing difficult years, particularly with a lot of malformations. So when this happens, obviously the challenges for the surgeon also goes up, and also challenge for the entire team, not only the surgeon, but for the audiologists and the habilitationists as well. So this is what I shall be highlighting over the next few minutes. Of course, preoperative imaging has also improved, and that has greatly helped in planning the surgery in these difficult years. And it has also helped us to some extent, predict the potential outcomes in these patients. So preoperative counseling has also become more meaningful in these kind of situations. Now, the congenital anomalies of the inner ear. If you take the congenitally deaf children and you image all of them, it will be fair to say that about approximately 10% of these children would have some kind of radiological anomaly. And what are the problems that we can anticipate? You could anticipate a partial or complete electrode insertion in these people. You could expect CSF gusher in these patients. And you can also have difficulty in identifying the anatomy, particularly in patients who have absent round window. The congenital inner ear anomalies in these patients, you can expect aberrant facial nerve in about 16% of malformed inner ears, decreased spiral ganglion cell. Sorry, I think there's a lot of disturbance. Can we ask? There's a lot of disturbance coming from. Can the moderator please ask the
స్టాచ్యూస్ మెడిసిన్ స్టాచ్యూస్ రేపు తగ్గిపోతుంది ఆబ్వియస్లీ తగ్గిపోతుంది 2-3 days లో 1.5 ఇప్పుడే ఉన్నాయంటే రేపు 1.2 తగ్గిపోతుంది రేపు పొద్దున 1 lakh బిల్ అయిపోతుంది 90 అవర్స్
fine, that's much better, thank you. So if you have a congenital inner ear anomaly, then you can expect that in about 15 to 16% of them, you can expect an aberrant facial nerve. The more concern to us is patients who may present with decreased spiral ganglion cell count, and this particularly happens in these kind of mutations. The DFNB 59P mutation is notorious for that. In these patients, in these children, if you go and do a cochlear implant, your outcome is going to be poor. And the reason is that the spiral ganglion cell population is very, very measly in this crowd. In certain anomalies like the IP3, for example, you can have an inadvertent penetration of the internal canal by electrodes. And this can lead to vigorous facial twitching in these patients. Similarly, anomalies in the round window can lead to difficulty in accessing the scala vestibulae. And in certain syndromic children, as we shall see, there may be difficulties and challenges in habilitation. In Mondini deformity, or IP2, for example, the cochlea, which is one of the most common abnormalities that we will face, the cochlea will have 1.5 turns instead of the normal 2.5 or 2 3/4 turns. But the key is that the basal turn is always well developed. Very often, there's an associated dilated vestibular aqueduct, which can predispose to a CSF leak and even have an increased risk of meningitis. It's very important in these IP2 patients to ensure that you have a normal cochlear nerve and that it is connected to the cochlea. The reason I'm saying that is you might have a normal nerve in the CP angle, a cochlear nerve may be identified, but when you actually look at the cochlear aperture, which is the base of the modulus, you may find that it is closed. The nerve is not connected to the modulus. So this can happen in IP2. So it's very important that we have to ensure that the IP2 patients have a connected cochlear nerve and the cochlear aperture is open. So here you can see what I'm talking about. This is an IP2 and this is an open aperture. You can see that the cochlear nerve is coming and connecting into the aperture. When you have a closed aperture, you will find a bone which is going right across there and closing the aperture. Now this is an intraoperative picture, and you can see the gusher which is coming out of the cochleostomy. Now, when you're anticipating a leak like this, it's much better to go for a cochleostomy than the round window insertion. And the reason is that when you have a bony opening, it is easier to plug than when you have an opening which has got partial soft tissue as part of its wall. So do a cochleostomy, even if you can identify the round window. And once you've done that, you can plug it nicely. The important thing, of course, is before you get out of the OT, you have to make sure that there is absolutely no leak, that you have a bone dry field. And my preference is usually to plug it with soft tissue. And then once the leak settles down, then you have to use a bit of tissue glue to seal it off. Another challenge, of course, is an ossified cochlea. And this happens in two situations, usually in children who have had meningitis, as post-meningitic ossification. Or it may also happen in adults as a sequelae of advancing autosclerosis, particularly when the cochlea is involved. The post-meningitic ossification is usually more dense, and it's also a bigger challenge because it can happen at a very rapid rate. And therefore, when you have diagnosed a child with meningitis and has developed profound hearing loss, there is absolutely no time to waste. Even if the child is below the age that you normally would prefer to operate on, you still don't wait. You have to go ahead and do it at the earliest before the ossification sets in. The most common site of ossification is the scala tympani in the basal turn. But then it can progress gradually, and then the scala vestibuli also is involved at a later stage, and it goes onwards into the second turn, and eventually the whole cochlea may be densely ossified. So what are the treatment options? You may either do a drill out of the basal turn, or you may have what is known as a double array electrode, where you can put part of the electrodes into the basal turn and part of it into the second turn. Now, this is a typical double array electrode. You can see the two arrays here, and that's the ground electrode. And here you can see the ossification. This side is completely ossified, and this side you can see a partial ossification. So this is a typical double array. Now I'm doing a basal turn first, and you can see it's the second turn is usually done below the process cochleariformis in front of the oval window. So here you're having two electrodes going in, one into the basal turn, you can see one here, and one going into the second turn. And the hope is that you have the maximum number of electrodes inserted into a situation like this. I must say that this has become much less popular now with the kind of electrodes which we have nowadays, with compressed electrodes and so on. The need for this is going down more and more. Now, this is a typical basal turn drill out. And you can see that I'm drilling the basal turn, and I'm drilling the basal turn. It's densely ossified. There's absolutely no lumen at all, and I've been at it, slowly opening it, removing the bone, and so on. And finally, I've created a kind of a basal turn. the word is created, because I don't think it was actually there because I've been drilling it. But then I am now using a test electrode to see how far I can go. And the idea is that you need at least about 60% of the electrodes to go in. But I find that my drill out is not enough. So now what's the next step? To go into the second turn. So I am now removing the incus and the incus bridge, cutting the SZ-AP superstructure, which is what I'm doing now, and then start drilling in front of the oval window immediately below the process cochlear reformis. And I'm very, very gently drilling there, and I've now made a opening there, and into which I'm now inserting the test electrode. And to my relief, the electrode goes in comfortably. Now I can either have an antegrade insertion or a retrograde insertion. Of course, an antegrade insertion would be better, but you can see now an antegrade insertion is going in very, very slowly, and I have got the full length of the electrode in. So now I have the second turn cochleostomy. I'm now introducing the actual electrode into it, and it is going in quite comfortably, and the full length of the electrode has been inserted. So this is a second turn cochleostomy, and in a situation where the basal turn is totally ossified. Now, the other challenge nowadays is the age of the children. We are now doing in younger and younger children. When we started in the 90s, the youngest age in which we implanted was 2 years. And, that is a much easier proposition. But today we realize that the earlier we do, the better the chances of taking advantage of the plasticity of the child. So therefore, we are trying to do it in very young children. In fact, now in MERF, the age that we keep is roughly around 10 months, but we would not hesitate to even go later. So basically, you want even earlier. I mean, so we have a situation where we have even done in 6 months in a post-meningitic child. So basically, very young children are being taken up for surgery, sometimes for bilateral simultaneous cochlear implantation. So what are the challenges here? When you're taking up a very young child, one, of course, the mastoid is smaller. There may be incomplete pneumatization. There may be very thin skull bone when you're creating a bed for the receiver stimulator. And there's also a lot of diploic bone which will bleed. The other thing, of course, challenge is the anesthetic challenge, because in a young child, the reflexes, normal hemodynamic reflexes are very poorly developed. So you have to be very, very careful. The anesthetist has to be a trained pediatric anesthetist, and you may not get much warning. For example, the blood loss is a very important consideration in these children. Remember that the blood volume is roughly about 80 ml per kg. So if you're operating on let's say a 6 or 7 kilogram baby, the blood volume is only about 500 ml. So in that situation, even if you lost 50 ml of blood, it represents a 10% loss, which is a very, very significant volume loss, needing transfusion. So in these situations, you have to be very cautious about the blood loss. Unfortunately, you won't get much warning in the terms of reflexes like tachycardia and so on. So anesthetist has to be very wary and very watchful in these very young children. So pediatric bilateral simultaneous cochlear implantation has come into vogue. It's very popular. We do it as well here, but it needs a very good anesthetic team, and particularly well-trained pediatric anesthetic team. The next challenge that we see very commonly is a large vestibular aqueduct. And you can see this here. You can see a very large aqueduct both here and there, both starting in. And in this situation, of course, you can expect a perilymph leak. We already saw that. Now, there are some warnings. Here, I have dislocated the incutoseptal joint, and you can see the pulsating stapes. So a pulsatile stapes should warn you that you're going to get a leak. Now, I am prepared for a leak. So as I told you already, I'm making a cochleostomy, and then you can see the fluid coming out. Once it comes out, allow it to flow out. So don't get panicky. Just give it some time. Let the fluid go down, go out. The anesthesiologist may give some mannitol to lower the pressure a bit. And then once the fluid leak is trickled down to a small trickle, then you can use your implant just like you do in any other situation. Seal it off nicely with a bit of soft tissue all around it, so that the leak completely stops. So as I told you already, you must have a bone dry field before you get out of the theater. And we often use tissue glue in this situation. Another warning that you may get is a round window pulsation. Look at that round window pulsating. So this is another warning that tells you that this patient is going to have a leak. An anomalous facial nerve happens in about 15 to 16% of these children. So you have to be very, very careful. Of course, a facial nerve monitor, if you have, is very important. It really helps you to avoid catastrophe. This is one example of a patient in whom there was an abnormal facial nerve. Now you can see that I have, thinned out doing a post-temporatomy. I've even removed the incus bridge because it's very poor visibility. And look at that facial nerve. That's the facial nerve. The facial canal is here, but the nerve is going directly from the geniculate ganglion to the stylomastoid foramen on the promontory in front of the round window. So this is a direct course of the facial nerve, it's an abnormal facial nerve. So I was curious, there's also a facial canal. So I said, let's open the facial canal and see, is the nerve bifid? Is there parts of the fiber going through it? So here I am opening the canal, and once I opened the canal, it was very obvious that the canal was empty. There was just fibrous tissue there. You can see that I'm just opening the canal. There's no nerve fibers, just fibrous tissue. So even though there was a facial canal, which you might see in the CT scan, the nerve was not going through the canal. The nerve was going directly. So be wary of, when you have a congenital anomaly like a congenital hearing loss, be wary of other congenital anomalies. Right. Next is a common cavity deformity. Now here is a child who's got a common cavity. The whole thing is one form, that the cochlea and the vestibule is formed. So here you can open anywhere in the cavity. So I'm now opening in, I don't have to go into the round window area. I'm just opening into the lateral semicircular canal. So you can see the cavity being opened gradually. And using a pick, you just open the cavity. But the trick is not opening it. This is one of the easiest things you can do. But insertion has to be in a certain way. Normally we are used to inserting the electrode tip first, but this is one situation where you want the tip to go last. And the reason is that in a cavity like this, the neural elements, there's no modulus. The neural elements are along the outer wall. So you want your electrode to drape on the outer wall. If it does not touch a part of the outer wall, you will get very high impedances and you won't get an AR. So you can see how very, very carefully you're doing that. And usually we keep a bit of soft tissue and use the soft tissue to push it. So the soft tissue will fill the cavity and push the electrode to the side. So you can now see me doing that. Now I'm keeping a bit of soft tissue there and use the soft tissue to push the electrode towards the wall of the cavity. And this will make sure that the actual, and this must be full banded electrodes, obviously. And these electrodes have to be in contact with the outer wall of the cavity. So once you've done that, then of course your job is done. You can get check X-rays post-operatively or a CT scan post-operatively if you so desire. Now, look at this situation. This is the intraoperative impedance. And you can see that electrodes 5, 6, 7, in fact, the mid electrodes are not in contact with the cavity, right? The other basal turn and the apical turn electrodes are in contact. But the situation changes at switch on. And you can see that all electrodes have now become in contact because the electrode also adjusts inside. And we had excellent, responses from this child subsequently. And this shows the electrodes in the common cavity, CT scan. Now, there are many situations where you may see, patients who come with bilateral mastectomies who had, for let's say, cholesteatoma years ago, canal wall down mastectomies, and they've had progressive hearing loss. They've used hearing aids, and then later on developed profound hearing loss where hearing aids are not helpful. So, how do we deal with this situation? These are, remember, patients who have had chronic otitis media, cholesteatoma, but have had surgeries and have done well, but have now got profound hearing loss. The important thing is the ear must be safe for implantation. That means there must be no residual or recurrent infection. because the potential the implant is a potential route of spread for middle ear sepsis intracranially. And the cochlea must be sealed at the point of entry of the electrodes to prevent any spread of infection. A permanent blind sac closure of the external canal is preferred, along with obliteration of the eustachian tube and the mastoid cavity to create a closed and sterile cavity. And this will reduce the risk of infection associated with inserting a cochlear implant. So here is another video. You can see I've lifted the external canal, and that's the cavity canal being lifted, and blind sac closure being done. Two-layered closure. A bit of muscle flap is kept underneath for support. And then, of course, it's already a canal wall down mastectomy. All the epithelium is removed, and then, you do a cochleostomy and do the insertion. Usually, a muscle padding is rotated from the temporalis and kept over the electrode. Now, this is another interesting situation where you have a patient who has had chronic Meniere's disease, and in fact has progressed to bilateral Meniere's now. Now, one side he has got a profound hearing loss. The other side is having a hearing aid, but the hearing is going down in that side also. So, in this situation, you can combine a labyrinthectomy with a cochlear implant. It's also possible that by the labyrinthectomy you can cut down on the episodes of vertigo, provided that's the side which is causative. So here is a situation like that. This is an unedited video, a partially edited video, in fact, because there was also another problem in this patient. And this patient had a very high jugular bulb, which is covering the round window. So, in fact, this is a problem of identifying the round window, in fact, an insertion, because the whole round window was covered by the jugular bulb, high jugular bulb. So let's see the situation now. So I'm doing a posterior tympanotomy now. So far, so good. But you can see the very high jugular bulb coming up here, the anterior sigmoid sinus, and the jugular bulb is here. Just there. See, immediately started bleeding. It's covering the round window. Whole thing is jugular bulb. So what do we do now? Because there's nothing to panic. It's a very low pressure system, and it will stop immediately. So keep a little bit of gel foam and a bit of gauze, and that should take care of this. Exactly what I'm doing now. So I'm keeping a bit of gel foam there. Put a little pressure on it, and it'll stop. And meanwhile, I'm now coming in for a canal wall down procedure, because the space is very, very restricted, and I want to do a labyrinthectomy also in this patient. So I'm removing the canal wall, deepithelializing completely, doing a blind sac closure, removing all the skin from the external meatus, and now we then proceed for the labyrinthectomy. Again, the same jugular bulb. I deliberately put this up because you need to see how these things are managed. Usually, this is not at all a problem. It will just stop with a little bit of pressure, a gel foam and a bit of pressure, and that's all you need to do. You don't have to worry about a jugular bulb bleed. That's a blind sac now. Right. So now let's go for the labyrinthectomy. That's what you can see now. The lateral canal being opened up. So that's the lateral canal. And then the posterior canal here, at right angles to it. That's the posterior canal. Yeah. You remember that each canal is at right angle to every other canal. And of course, the superior canal will be here. The ampulla of the superior canal is just in front of the ampulla of the lateral canal. So superior canal is going to be here. That's the superior canal being opened up now. In fact, I'm just outlining the superior canal. So this, between the three canals, this is the solid angle, and you can see the bleeding from the subarcuate artery, which is coming from there, which goes just below the arch of the superior canal through the solid angle. Now, once we do a complete labyrinthectomy, normally when I'm doing a surgery for an intractable meniscus, I would then go in and open internal meatus and do a vestibular neuronectomy. But here we don't do that because of the risk to the cochlear nerve, of concussion to the cochlear nerve. So therefore we stop with labyrinthectomy. We don't open into the internal canal. So now I'm doing a cochleostomy now, and then we insert the cochlear implant. So in this patient, he's had two procedures. He's had a labyrinthectomy and also had a cochlear implant. So they do very well indeed. In fact, their hearing is preserved or restored. And labyrinthectomy also takes care of or helps in management of the vertigo. Can they still get episodes? They will. They may get occasionally if their sodium level goes up, but that's not it's not as frequent as it was before the procedure. Interestingly, even though they've got a cochlear implant, if they get an acute attack of vertigo, during those attacks of vertigo, even in spite of the cochlear implant, they may have a temporary, threshold shift in the hearing, even in spite of being an electronic hearing. Is very interesting phenomenon. Maybe represents a transient increase in the impedance of the cochlear implant. But these patients will tell you that even though I have hearing, I feel partially blocked when I'm getting these attacks of vertigo. The other challenge that you may face is vascular structures in the middle. Here is an aberrant internal carotid artery, which you can see here on the promontory, and you can see the pulsation on the promontory. Now, this is not the only vascular structure which you may see. Occasionally, you may also see the persistent septal artery, and that also may be a real nuisance because it goes submucosally all the way to the round window. And when you're going and doing a cochleostomy, you may injure it. So therefore, you have to predict it preoperatively. And the way you predict it preoperatively is that when you do a skull base scan, you will see in the skull base that the foramen spinosum, through which the middle meningeal artery goes, is absent. And that should give you a clue about the problem. Electroacoustic stimulation is another emerging field where you are trying to restore hearing in a patient who's got partial hearing. Now, let us look at this audiogram. This is a typical candidate. He has got considerably good hearing in the lower frequencies, but in the mid and high frequencies, particularly from 1000 hertz, there's a tremendous drop in threshold. So this patient will hear only in the selective frequency. If you give a hearing aid, he'll not be happy because in the frequencies where he's got hearing, he will hear too loud. And in the frequencies where he has got no hearing, he will not hear at all. So, in other words, his problem only gets exaggerated. So, these patients are great candidates for what we call electroacoustic hearing. It's a combination of electrical and acoustic hearing. In other words, a hybrid hearing. You need electrical hearing in those frequencies where the hearing loss is profound or severe to profound, and you need acoustic hearing or his own hearing in the frequencies which are low. The advantage, of course, is that because you preserved some hearing in the low frequencies, these patients can have a greater appreciation of music and hearing in noise. So these patients do not benefit traditionally from a normal hearing aid. But there are certain specific challenges. So you want to put a piece of metal into the cochlea and hope to preserve hearing, there have to be certain tricks. So what are these tricks? It has to be a soft surgery where you want to open into the cochlea and insert an electrode, which is a designed electrode, a specially designed electrode, which is atraumatic electrode. And this has to be inserted in such a way that you don't damage the very fine ultrastructure of the cochlea, which is really very, remember, it's is seen through an electron microscope. There's that fine, those structures. So we always prefer a round window approach rather than a cochleostomy. And you have to, be very careful that you don't suck the perilymph out and very minimal insertion, traumatic insertion. So you can see the surgery again, the video. I think we will be going pretty fast from now on. Time is running out. We used about half an hour of time. This is a round window. You can see the post-implantomy. You can see the round window membrane quite clearly. Now, in this situation, that's a round window membrane there. So I want to use a special electrode, but here I am taking a bit of fascia to form a cuff of tissue around the electrode and make a very, very gentle, first of course, I'm piecing out the fibrous tissue around it and exposing the round window membrane. You want to do a round window myringotomy. And it's just like in a regular myringotomy. This is also in the antero-inferior quadrant of the round window membrane. And you can see I have formed a cuff of tissue around the electrode and then make a gentle myringotomy there and introduce the electrode. It must be a very small opening in the round window membrane. The electrode is inserted very slowly, millimeter by millimeter, giving a lot of space. In fact, you need to take at least about 2 to 2.5 minutes for the entire process of insertion. You can't ram it in. Allowing, every bit goes in, the hydrostatic pressure inside the cochlea goes up. And you have to allow for fluid to come out, egress, so as to balance the increase in hydrostatic pressure. So this is done very slowly till the entire electrode is inserted. And once that is done, the cuff of tissue is used to seal off the myringotomy in the round window that you made. Of course, before all this, the patient is kept on very high doses of intravenous steroids. And there are some surgeons who like to do the entire insertion underwater, under steroid solution. So that's also another option that you may do. I don't do it. I usually give intravenous methylprednisolone before I do the insertion. The anesthetist gives about half an hour before. So these are, procedures which you do to preserve the hearing in the patient so that you can make use of it in the low frequency. This patient, is a particularly important. This is a lady from US who was working as a music teacher. So for her, music appreciation was very important. So this was done, and I'm glad to say she maintained it. Another new challenge which has come up because we didn't know this condition existed before was auditory neuropathy spectrum disorder. And here is a very peculiar condition where a patient may hear but will not understand, will not have speech discrimination. The discrimination is very, very poor. Now, this is diagnosed by a triad where the pure tone threshold is maybe normal. It may be normal or it may be variable. The reflexes, however, are absent. And if you do electrophysiology, the autoacoustic emission and cochlear microphonics are normal. But the ABR is very poorly deformed so that you hardly get a auditory brainstem response because this is a dyssynchrony. It's an auditory dyssynchrony. So because the brainstem responses are entirely based on synchrony of the response. So here it is, you do not get an ABR. And speech discrimination is predictably very, very poor. So usually, there are there's two forms. One is known as the proximal form, and the other is a distal form. The distal form is the one which is seen in the towards the end, that is near the end organ, near the cochlea, and the proximal form is more in the central. Majority are distal form, and these are the good ones. They do well. The proximal form do not do well with cochlear implants. So cochlear implants work very well in these patients who have problems mainly in the distal type. Now, who are they? They are, how do we make them out? Of course, one way of doing it is by doing what is known as a transtympanic EABR. But genetics is the answer, really, because you can always make out the poor performers from the good performers by looking at their genetic mutations. Two of them are notorious. The DFNB59 is really bad news. So they don't do well. And the most common, of course, is OTOF. And this is very common in our Indian population as well. So, we've been looking at genetic studies from our center, and OTOF, if you have, you can boldly go ahead and counsel the patient for cochlear implantation, and they do extremely well. They have good outcomes. So, because these are patients who have pre or post synaptic site problems, but they have good spiral ganglion population. So in other words, genetics is a new frontier, which is now coming in to give us assistance in predicting the good from the bad cases for cochlear implantation. What about multi-handicapped patients? Patients who have several issues, syndromic issues, children who have multiple problems. Well, some of them do very well, some of them don't do very well. But even if those not doing very well, even if they have multiple handicaps, you at least are reducing the burden of one handicap in these children. And very often the benefit that you get is far more than what you'd expect. Of course, they're not going to be performing like other normal children, but they need counseling for this to be well in advance. So the golden horse syndrome is the first one. It's an oculovertebral dysplasia, where they have epibulbar dermoids, auricular pits and appendages, micrognathia, and vertebral anomalies. They have external ear anomalies, middle ear anomaly, like small cavity abs, ossicles, and the other big problem for us, the implant surgeons, is they may not have any of the windows, neither the oval window nor the round window. So it's very difficult to localize the site where you're going to be entering the basal turn of the cochlea. So these are the children. This is a small little video where this is one situation where I've done an anterior tympanotomy as well. Apart from post tympanotomy, because there's nothing, no windows, nothing, no, even the promontory is flat out. So you really don't know where to go. So you have to go to the hypotympanum, and from the hypotympanum come up and drill to locate the basal turn of the cochlea. And then, of course, once you've done that, you introduce your electrode through the post tympanotomy, reinforce the tympanic membrane with a bit of cartilage or the extra fascia, and then reposition it. So this is golden horse. The other syndrome that we see in the Indian subcontinent is the branchio-otorenal syndrome, where you have branchial cysts, you may have fistula, you have ear malformations like this, renal anomalies. And in these children, you have usually an IP2 or a Martini deformity with a dilated vestibule and semicircular canal and normal vestibular cochlear bundle. The main problem in the genetic study is there's an inversion of chromosome 8 and EYA1 gene mutation. Of course, here you can see the situation is the reverse of it. Here you have a huge additus, and through the moment you open the antrum, you can see the entire middle ear through it. So this is a easy insertion, right? Now the other major challenge that you face is the JLN syndrome or the Jervell-Lang-Nielsen syndrome, where you have a long QT, or what is known as a long corrected QT. QTC is very high. These children have cardiac conduction defects and also have, of course, profound hearing loss bilaterally, and they need cochlear implants. But these are high risk candidates because they can have Torsades de Pointes type of ventricular arrhythmias and syncope and even death on the table based on certain medicines that you give them. All the inhalational anesthetics are forbidden in these children. So you can't give them, sevoflurane, enflurane. None of them can tolerate it. You can induce even cardiac arrhythmias in these patients. So how do we deal with them? Sometimes they need temporary pacemaker pre-implantation. Pre-operative beta blocker therapy may be life-saving in these patients. And during surgery, because we avoid adrenaline, electrocautery also is not recommended. If at all you have to use a bipolar cautery. And you have to have standby defibrillators, antiarrhythmic drugs. IV magnesium and ultra short acting beta blocker like esmolol may be life-saving in this situation. And usually these children are kept on beta blocker therapy preoperatively and well into the postoperative period and kept under the follow-up of a cardiologist. A tragic syndrome is Usher's syndrome, which leads to progressive blindness along with profound hearing loss. And there's an association of retinitis pigmentosa. So there's particular types, there are many subtypes in this. One of the subtypes, there's an accelerated form where the children rapidly lose their vision and become blind. And these are children who need immediate intervention and to establish hearing. So before they lose their vision. The reason is most of our techniques of habilitation in after cochlear implantation use the vision. And if in a child who's got a double handicap, like visual and auditory, habilitation becomes a tremendous, tremendous challenge in these children. Now, this is a video of a young girl, Afrina. She had an implant when she was less than 1. So, so this is habilitation when she was about 1 year old. And you know, you can see that she is already picking up very well. Now, this is the same girl about 5 years later. She is now almost completely blind, but she is able to carry on with her father sitting there, even though her vision is very tubular. You know, she just has very small field of vision. But look at her conversing, talking to her father. The cochlear implant for her is a lifesaver. It's actually allowed her to get back into a normal stream of education, and this is important. So this next challenge that we face is revision cochlear implants. Many reasons why. There could be a device failure, there may be biofilm. But what is true is that every implant that you do is going to need revision. You know, that's a fundamental fact of life. The only question is, which is going to last longer, the implant or the patient? Now, what do I mean? You know, if you're going to do an implant in an elderly person, maybe the person will, you know, die before the implant goes out. So if I'm doing in a 70-year-old, chances are that, you know, it'll work throughout his life. But if I'm going to do an implant in a 1-year-old, there's a very high chance that I'm going to do revision not once, but maybe twice or even thrice. In other words, this child will probably go through 2 or 3 implants in a lifetime. And for that, you need a system whereby even if the surgeon is dead and gone, you know, you're going to have the patient is going to come back to the institution and be able to have the next procedure. So the second implant has to go into the capsule of the first implant. So it must be thinner than the first implant. That will be preferable, thinner or at least the same size, not bigger than the first implant. So when you choose a first implant, choose a big implant. And if it is a device failure, you can do a one-stage revision. Whereas if it's a biofilm, of course, you have to remove it, allow it to heal, and then do it 3 months later or so on. So I'll skip this video because I think we are running out of time. Another problem that we faced sometimes is magnet migration, where the magnet gets displaced. You can see this is one situation. Many years after the actual implant. There's no real reason why. You don't know why it is happening, but it may happen. There are quite a few cases reported in literature, and it's come out of the pocket and it is lying loose. You know, so you can see that. But it's not a very difficult problem. You know, you identify that, you take it and put it back into the same pocket. It'll stay put unless it's damaged. You know, you don't have to change the implant. The other big issue is cholesteatoma. You know, after you've done an implant, years later, you know, child comes with cholesteatoma. This is inevitably iatrogenic. You know, it means that we have somehow, you know, caused microfractures into the annulus, and this has led to a retraction pocket and implant. This is in my own patient. I had done an implantation in 2003, but 11 years later, he was doing very well. 11 years later, he comes with left autalgia, excellent hearing with the implant even now, and automicroscopy showed a cholesteatoma. So you can see that now, you know, it's excellent hearing, but cholesteatoma. So what do? We obviously have to treat the cholesteatoma. So I'm just opening up the following the electrode, opening up into the cavity. Now, obviously, this electrode cannot be used, you know, so you have to have a standby electrode with you in your hand. And the real question is, am I doing it one stage or two stage? It depends really on the extent of the cholesteatoma. If it's a very limited cholesteatoma and you can completely excise it, 100% certainty, then you can go ahead to the same sitting and do it. But if it's an extensive cholestoma like this, you have to stage it. You have to do the cholestoma removal in the first stage, and then second stage, go back a few months later, at least 6 months later, and then go back with a new implant and do it. So this is exactly what we did in this patient. And the second stage, you can make sure that when you open up that there's no residual cholestoma before you put the implant in. Finally, a word about genetic testing. I think this is the new frontier, which all of us have to be aware. It's a great help if you have the support of a genetics team, because it helps you to predict the difficult cases, overcome these challenges. And there are many situations. For example, in prelingual children, GJB2 mutation is the most common. And this is something which is good, because if they have a GJB2 mutation, they do extremely well with cochlear implantation. Unlike some of the other mutations like SLC26A4, they don't do very well. So this is the situation. In postlingual deafness, mitochondrial mutation 1555A-G is another mutation which does very well. Generally, CDH23 mutation is the good candidate for EAS. So, if you're going to have a EAS patient, check for genetic study, and if they have a CDH23 mutation, which is very common in them, they do very well with hearing preservation. And as we already said, DFNB1 children will do very well in CI, so because of preservation of the spiral ganglion population. So to summarize, I think it's a safe surgery generally, and it's uneventful. But you have challenging situations which you have to be prepared for, both prior to and during the surgery. Meticulous preoperative evaluation will help you to avert the vast majority of these complications and put you on a very firm footing in dealing with these multiple challenges. Thank you very much indeed.
Thank you, sir, for your excellent and elaborative lecture. I request Professor Krishnakishore, sir, to say a few words.
Sir, Professor Mohan Kamensaran, sir, it's very wonderful and excellent information you have given us to deal with all the challenging and difficult situations in CA surgery. It's always a great delight for us to listen to you, sir, your lectures. And I would like just to know how will be the outcomes in common cavity situations, sir, outcomes?
Very variable, Kishore, because
Yes.
in general, if you want to make a simple statement, the results are not great. But having said that, we'll all have individual patients, some of whom do very well. I think the real the deciding fact is the ganglion cell population, which is very variable in these people. And I think the genetic studies is what will give us a clue about in the future about which are the ones which are going to do well. So as of now, the policy in our center is we counsel them, tell them that the results are variable. They can see patients who have already had surgery, some doing well, some not doing well, and then decide about it. And if you do the surgery, and they do well, fine. Some of them have not done very well, then they have the option of a brainstem implant. But in general, we do a cochlear implant straight away and then wait and see how the outcomes are. Genetic studies, I believe, will be the future, solution to answering which of them are going to be doing well.
Thank you very much, sir, once again for your wonderful lecture, beautiful videos, and everything, sir. Thank you.
Thank you,
Thank you,
sir.
Kishore. Thank you.
I request Dr. Rahman Garu from Vijayawada to come onto the dais to present the mementos to our chairpersons, Dr. Krishna Kishore Garu and Dr. Leela Prasad Garu.
Let me say a quick hello to Leela Prasad also.
Thank you, sir. Let's move on to our next lecture by Dr. H. Vijayendra on management of facial nerve lesions in middle ear surgery. The chairpersons for this session are Dr. B. Nageshwar Rao, sir, Designated Professor, ENT Hospital, Visakhapatnam, and Dr. Fadiduddin, Senior Consultant, Vijayanagaram. I would like to call upon Dr. G. Yugandhar, Associate Professor, Geetham Medical College, to introduce Dr. H. Vijayendra to us.
Good evening, everyone. Professor Dr. Vijayendra Honurappa, presently the Director, Vijaya ENT Care Hospital, Bangalore. He was past President of Indian Society of Otology, and he is Honorary Visiting Professor, JN Medical College, Belgaum, University of Illinois Hospital and Health Sciences, Chicago, USA, and Mekelle University, Ethiopia. He was awarded by Dr. B.C. Roy Award by IMA Bangalore branch in the year 2008. And he visited 29 countries for guest oration lectures and live surgical demonstrations. And various surgical techniques are named after him. Some of them, like Dr. Vijayendra's technique, transcanal facial nerve decompression, and sutureless grafting, which were published in various international journals and which were popular all over the world. Presently, the Vijaya ENT Care Hospital is a modern, fully equipped state-of-art ENT hospital in Bengaluru. It is affiliated to KLE University Belgaum, and it is also affiliated with Mekelle University, Ethiopia. Dr. Vijayendra sir conducted 3 single faculty international live surgical workshops in the year 2017, 18, and 2019, with about 800 delegates attended each time all over the globe. With this small introduction, I request Dr. Vijayendra sir to start his talk. Thank you.
Good afternoon, respected chairpersons, my dear friends, colleagues, ladies and gentlemen. It's a great pleasure and honor to be here to present today's, to participate in this South Zone and AP conference, for which I immensely thank the organizers for giving me this opportunity, in particular, Dr. Surya Prakash Rao, for inviting me for this guest lecture. The topic of the lecture is the management of facial nerve in middle ear surgery. During our middle ear surgery, we do come across facial nerve in so many incidences. So, to be a good otologist, one has to master the anatomy of the temple bone, also the anatomy of the facial nerve. If you are confident in the anatomy of the facial nerve, you can tackle all the situations whichever you come across, and accordingly you can plan your surgery. So now I'm going to show how the facial nerve can be tackled from the internal auditory meatus up to the stylomastoid foramen or beyond stylomastoid foramen, even in the parotid region. Different situations I'm going to show one by one. So let us start with the internal meatus situation. This is a congenital cholecystoma case where you can see it was the facial nerve around the internal meatus. This is a normal tympanic membrane. This patient's our otoscopy shows that, and CT scan shows the extensive supralabyrinthine cholecystoma eroding the superior and the lateral semicircular canal. Now you can see here the normal tympanic membrane. This is a characteristic feature of congenital cholecystoma. The tympanic membrane is absolutely normal. This was a CT finding, and the patient presented to me with a facial nerve palsy. So that is the clue it gave. On clinical examination, I saw a posterior bulge was there, and when you did a CT scan, it was a congenital cholecystoma supralabyrinthine with the facial nerve palsy. So now you can see that when I'm pressing that, the tympanic membrane is moving, and now I started dissecting the cholecystoma. Now this is the beginning of the vertical segment. In this situation, the whole cholecystoma has completely exposed the whole facial nerve. Now you see, now I'm going towards the internal meatus here. That is a tegment plate. This is a supralabyrinthine area. Now this is a labyrinthine segment of the facial nerve where I'm dissecting the cholecystoma matrix. This is nicely, you can see the labyrinthine segment, and that is the meatal foramen down there. And this is a greater suprachiasmatic nerve. This is the horizontal segment of the facial nerve. I'm dissecting the cholecystoma medial to the facial nerve near the geniculate ganglion. Now you see a blue lining here, that is the basal turn of the cochlea. That is the basal turn of the cochlea. Now I am dissecting the cholestoma, which is completely almost medial to the geniculate ganglion and the first genu. Now you can see very clearly that is the blue lining is the basal turn of the cochlea. Now the whole dura is exposed at multiple places. And since the semicircular canals had gone, I had to do a labyrinthectomy also in this case to get a good exposure of the supralabyrinthine area. Now I can see that the cholestoma is going towards the intraantemeatus, which we have seen very clearly in the CT scan. Now at this junction, I anticipated CSF leak because this cholestoma matrix is going deep into the intraantemeatus. So now we can see beautifully the anatomy of the fascia now here. Now I am dissecting the cholestoma over in the intraantemeatus. This is in the intraantemeatus. Now you see the anatomy, the horizontal segment of the fascia now. First genu, this is the first genu. This is the labyrinthine segment. The length of the labyrinth is about 5 to 6 millimeters. And this is called as a bottleneck or the meatal foramen area. You can see the fascia now is narrowed here. This is the narrowest portion of the fascia now in the whole course. So this is also called as a bottleneck. Beyond this is in the intraantemeatus. I am dissecting the cholestoma matrix in the intraantemeatus over the fascia now. Very nicely I got the cleavage. I am dissecting this cholestoma matrix in the intraantemeatus over the fascia now. Beautifully you can see the anatomy of the fascia. Even if you do a dissection, you cannot see like this. So nature has, the cholestoma has dissected so nicely to expose the whole fascia now. Now I am removing the whole cholestoma matrix. It was like a completely in the shape, funnel shape, in the shape of an intraantemeatus. Like a template, it is coming out. See, whole cholestoma came out. So now the CSF gush was there. It was blessing in disguise because the CSF was pushing out whatever the remnant cholestoma matrix was there. So till the last bit of the cholestoma matrix was, I removed it. And now you can see this is the superior vestibular now. That's the fascia now. Posterior superior get the superior vestibular now. Anterior superior fascia now. At times when it retracts, you see pearly white now. That's the cochlea now. So this is how the whole cholestoma was removed. And in this case, the whole fascia now from the vertical segment, horizontal segment, genu, labyrinthine segment, and intraantemeatus was completely exposed by the disease, and the disease was cleared, and the CSF leak was sealed by using a crushed periosteum, and then nicely over 2-3 layers of periosteum I kept it. And in this case, even the patient on the table, she had a good improvement. This we do under local anesthesia. This is the next case involving the fascia now. The horizontal segment of the fascia now was involved. So removing the fascia now, this cholestoma in this particular case, where the cholestoma matrix has completely 360 degrees engulfing the horizontal segment of the fascia now. There was no bone and also there was no perineurium. Epineurium was not there. Only the perineurium was exposed completely, and it should be very, very delicate in this situation, and it should take your own time. Never hurry up. And even if you damage a few fibers, patient will have a facial palsy. Of course, this patient had a grade 3 facial palsy because of the compression of the horizontal segment of the fascia now. You can see here how the cholestoma matrix is almost 360 degrees. It is engulfing the horizontal segment of the fascia now, where completely there is no bone, and also there is no epineurium. Only perineurium is completely exposed. This is very dangerous when you are elevating the matrix. You should not damage the perineurium, which will cause damage, permanent damage. So now I am lifting the now 360 degrees to clear the disease. So take your own time, and one can easily remove that. But what I mean to say is, clearing the disease in the horizontal segment is very, very difficult because the sheath is very thin. And after clearing the disease, I kept a pemphigus fascia, and primary osculoplasty was done in this case. This is how this is managed. And what I mean to say is the clearance of the disease in the horizontal segment is very difficult compared to the vertical segment because the sheath is very, very thin here. And these are pre-operative photos, and post-operatively, immediately after 1 month, the patient had a complete recovery because there was no any damage to the nerve. This is involved the fascia in the vertical segment. So removal of the cholestoma matrix on the vertical segment is easier because the sheath is very, very thick compared to the horizontal segment, what you saw there. Compared to the horizontal segment, the labyrinthine segment, there is no sheath at all. So you should be very, very careful, because there is no sheath, then damage to the nerve will be very common. So you should be very careful. And whereas the clearance of the cholesteatoma matrix of the vertical segment is easier because the sheath is very thick. Now you can see the whole vertical segment is exposed here, and the cholesteatoma matrix is engulfing over the vertical segment. And also in this particular case, there was a fistula of the lateral semicircular canal wall there. You can see that fistula under this matrix of the cholesteatoma. So now you just watch how easily you can completely shave off this cholesteatoma matrix with a press the side knife or flag knife. Because the sheath is very thick, you can easily peel out the cholesteatoma matrix. Once if you get the cleavage, see I'm getting the cleavage of the matrix. Here you can play with the vertical segment. The same thing, you could not do it in the horizontal segment because the sheath was very, very thin. And here, of course, the epineurium is intact. Invariably, the vertical segment, whenever the disease is there, the epineurium will be intact because it is very thick and it will be intact. Now, in this situation, you can go medial to the fascia now. You can even lift the fascia now. Don't worry, nothing will happen. You can lift the fascia now. And this is how the disease was clear. This is the next case, this keratosis obturans, it was involving the vertical segment of the fascia nerve. Friends, this keratosis obturans, see this is the end product. This keratosis obturans is involving the vertical segment. This keratosis obturans is more aggressive than cholesteatoma, and in almost all cases, many cases, the vertical segment will be involved because the bony canal, in the external canal itself, the bone will be eroded, and then that will cause exposure of the fascia nerve. So here, whenever you are dealing the keratosis obturans cases in the external canal, always you should anticipate there may be exposed vertical segment of the fascia nerve. Here you can see this, there is a vertical segment, that is first I saw it, I thought this is the vertical segment, but actually it's the chorda tympani nerve. So now I'm lifting the chorda tympani nerve because the keratosis matrix, it has displaced the chorda lateral anteriorly. So now a little posteriorly. Now you can see the chorda tympani now. After lifting the chorda tympani, I'm seeing the vertical segment of the fascia now. So friends, in these cases of keratosis obturans, always you should take a CT scan and you should know the status of the vertical segment of the fascia now. If it is exposed, while taking skin incision, you should be very, very careful. When you're taking skin incision, if you're not aware that the fascia nerve is exposed, there are all the possibilities that you may cut the fascia nerve. So that is the message here. Now I am easily removing the matrix over the vertical segment of the fascia now. This was very clearly in the external canal only you can see that. So this is very commonly we see in the extensive external keratosis obturans, where the canal will be completely irregular and will be eroded by the keratin material, and the vertical segment also will be exposed. In many cases I have seen that, so one should be very careful. That is the chorda tympani. Now I completely remove the disease, that is the stylomastoid foramen area. Very nicely you can see the stylomastoid foramen area, and the disease over the vertical segment of the fascia was completely removed, and then I kept a piece of fascia, and then primary reconstruction was done depending upon the pathology of the ossicles. And also I kept, this is another case of keratosis obturans involving the vertical segment of the fascia now. And also here, see this is the endoscopic picture where through the external canal, you can see the vertical segment of the fascia nerve is so nicely seen in the canal itself. And also in this case, the keratosis has completely eroded the tympanic plate, and the jugular bulb was also exposed in this case. So you can very nicely see in the endoscopic picture, OPD, the horizontal, the vertical segment and the horizontal segment was completely exposed here. That is the handle of the Marius. The horizontal segment will come like this, and that is the vertical segment. And this is the case. And also when you see the CT scan, you can see the jugular bulb was completely exposed. The cortical bone of the jugular bulb was not totally descent, and also the fascia nerve was completely exposed in this case, vertical patient. Now again, the same way, you have to be very careful. Now I'm gently elevating the matrix over the vertical segment. Here I see the vertical segment. Look at the irregularity of the canal. The canal is so irregular because of the keratosis obturans has completely eroded the bone in the external canal. So that is the reason why the fascia nerve is exposed here. And that is the vertical segment of the fascia nerve. So take your own time. And now I am completely elevating the matrix all around the fascia nerve. And further, I have to do further decompression to get a good exposure of the fascia nerve to clear the disease. As I told earlier, clearance of the cholestoma disease or the vertical segment will be easier because the fascia nerve sheath will be very thick here. Also, I am trying to expose the nerve more than 180 degrees to make sure that there is no any squamous epithelium left around the facial nerve. Even at times, if you have a doubt, you can lift the nerve from the facial canal, nothing will happen. Now I got a very good cleavage medial to the facial nerve, and now I dissected that. Now you can see that the nerve is completely 360 degrees. I elevated it, and the matrix I am removing it all around. So this is how this case, the cholestoma was completely removed 360 degrees. Look at the end picture. As you saw that in the OPD picture, this endoscopic picture, the tympanic plate was completely eroded. This was the endoscopic picture. What we saw preoperatively was showing the malleus here, and the horizontal segment and the vertical segment was seen in the endoscopic picture itself. And here the tympanic plate was eroded, and we saw the shadow of the jugular bulb. So this is how the jugular bulb was, or tympanic plate was completely eroded, jugular bulb was exposed, and this is the vertical segment. And this is how one can manage without any problem. And preoperatively you have to assess, and CT scan is also very, very important. This is a case of congenital the grade 4-6 facial nerve palsy. This is a very rare case. This is an 11-month-old child. She came with a facial nerve palsy. See, total grade 6 facial palsy she had. And when he did CT scan, it showed a congenital cholesteatoma. This is a youngest child where I have done a facial nerve grafting for this case. In the literature also, nowhere in the world it has been done. And now this is a CT scan is showing a cholesteatoma in the second genu area. Then also here the facial nerve was exposed here. So then I decided to do the general anesthesia. This is an 11-month-old child. When I meant elevating the tympanomeatrial flaps, I could see the cholestoma matrix from the second genu down up to the vertical segment is involved. So you can see the congenital cholestoma, the tympanic membrane was normal here, absolutely it was normal, and it is a congenital cholesteatoma. And a characteristic feature of congenital cholesteatoma is usually it will be a big sac, and the middle mucosa will be normal. In most of the cases of congenital, the first bone to be eroded will be stapes. Unlike the CSOM cases, incus is normal here, you can see that. But the stapes was partially eroded. So you can see the cholestoma matrix here. And now I decided to do a canal roll down procedure because I had to do a grafting in this case to get a good proximal and distal segment. There's no other go, we had to do it. And now I'm elevating this now cholestoma, and you can see it is completely engulfing the fascia nerve and eroding the fascia nerve. See, now you can see the horizontal segment of the fascia nerve here, and there is no discontinuity. There's no continuity of the fascia nerve. So now I am removing the cholestoma. There is the fallopian canal. And here the stapes suprastructure was there. Fortunately, in this case, what had happened is the cholestoma was completely engulfing the stapes suprastructure here. So very meticulously I removed it, but still I was not sure because the cholestoma was completely going in between the cruras. So I decided to remove the suprastructure by using a diode laser. I burnt out the cruras, anterior and posterior crura, the low voltage. Because the cholestoma was there in between the intercrural space. So it was difficult to remove. So this is the best way. If you have a diode laser, very gently I vaporize the cruras and then remove the suprastructure. Now you can see that cholesterol matrix in between the crura has been coming out. That is a posterior crura. That is anterior crura. Stapes foot plate is intact here. So now you can see the foot plate is very, very clearly seen. The whole foot plate is nicely seen. There's a posterior crura and also movement. You see the foot plate is freely moving. And now I'm trying to get a normal distal segment of the fascia now. That is almost mid-vertical segment or beyond that. And this is a horizontal segment. Whenever you are doing grafting, you should get a good normal proximal and distal segment. So this is how I do grafting. Always when I'm doing grafting, I expose the fascia now almost 1 centimeter from the site of the lesion to get a good healthy nerve here. Now you can see the healthy nerve, that is horizontal segment. Always I slice the cutted nerve, normal nerve. So when I slice using a iris blade, this is an ophthalmic blade. So it is a slice, the cut edges should not be crushed. That is the idea. You should never use a blade here. And I take a great auricular now. Even the cut edges, the great auricular should be sliced. It should not be crushed. And always I take great auricular now. And then I approximated this. Now the diameter of the great auricular of the patient and the fascia now will be almost similar. Now I wrap up with the temporalis fascia. This is called sutureless technique. It's also called as Vijayendra sutureless technique. It is popularized all over the world. Many people are following this technique and results are excellent. In earlier I used to do suturing. Suturing will take a lot of time. And now we approximate like this and then place a temporalis fascia 360 degrees and then wrap it up. This is called sutureless technique. And this is how it has been done. And I've seen in children, and also primary osteoplasty is also done in this case. In children, the results will be very good. I have done many cases below the age of 10 years. The fascia nerve surgery, these results will be good. So now I'm going to show the post-operative picture of the same child, which was about 1 year later, and she has got a very good improvement. See, this child had a grade 6 facial palsy. Now, after 1 year, you can see the eye closure is so nice. See, smiling is also good. So this is an excellent improvement. At the end of 1 year, this child had a very good. Look at this, the eye closure is so nice. Pre-operatively, you saw that patient had a Bell's phenomena, and this is the result I got in this child. And still, I expect little more improvement. So grade 3 from grade 6 is excellent improvement. Almost grade 2 to grade 3, I can say here. So now, similarly, I had one more case of 1.5 years old child of congenital cholesteatoma, where again, almost the pathology was similar, the site was similar, and again, the grafting was done in that case. And in the history, the 9-month-old child, facial nerve grafting is the first case which I had done. And another case was 1 year, 6 months child. I can say the pathology was almost similar. So this is another child. You can see that this child also had a grade 6 facial palsy. So again, you can see the cholestoma is sitting there in the second genu area and the vertical segment is completely gone there. So again, I explored this patient under general anesthesia. See, look at this. This is a normal tympanic membrane, and under the tympanic membrane, you can see the white shadow here. This is classical of congenital cholesteatoma. No discharge, nothing, normal tympanic membrane. You can see the shadow here. That is a congenital cholesteatoma. I'll fast forward this because the same thing I have shown. So same cholesteatoma was there. And then the grafting was done in this case. And see, this facial grafting was done similar to the previous case. So this is a post-operative. See, look at the cavity so nicely. In my series, if I do a canal wall procedure, you cannot make out that I done a canal wall procedure. The cavity looks like an intact canal wall. This is the hand of the malleus. This absolutely looks like an intact canal wall procedure. And this child also had a very good post-operative improvement. And she is coming for follow-up for nearly 3 years. See, look at this child. Now she is 4 years old. Look at this, how nicely she's closing. Almost she has got a grade 2, I can say. She had grade 6 facial palsy. See, this is the scar. This is the greater auricular nerve scar is there. So this is the improvement you get in children. I have seen they get a very good improvement. This is a massive keratosis obturans. Completely, it has exposed the whole fascia now from the meatal foramen up to the stylomastoid foramen. So very extensive keratosis obturans. This has involved, eroded all the semicircular canal, posterior fossa dura, middle cranial fossa dura, and intra-antemeatus, up to intra-antemeatus, and also the jugular bulb was exposed. So this is the status of this extensive keratosis obturans. Just I am showing this how the fascia now was completely exposed. This patient also had a grade 3 facial palsy, and fascia now see that is the horizontal segment of the fascia now. I'm clearing the disease on the horizontal. This is the vertical segment. This is the second genu, and you can see this matrix was completely covered the verticals. Now I am going retrofacially also. The disease has eroded completely retrofacially also. So it was hanging like a bridge. And posteriorly, you can see the posterior fossa dura. Here the jugular bulb was also exposed in this case. So I just fast forward. This is a very extensive disease. I don't want to show the disease clearance. Mainly, I want to show the fascia now here. And this is completely posterior fossa dura. And this is the endolymphatic sac. This is endolymphatic sac area. I'm clearing the disease of the posterior fossa dura. So you can see completely the whole posterior fossa dura was exposed here. Even the sinus plate was exposed, middle cranial fossa was exposed. Now I'm clearing the disease below this is the intra-antemeatus. So you can see the whole intra-antemeatus. The matrix is going almost up to the porus, from fundus to the porus. So you can see beautifully the anatomy of the intra-antemeatus. It is like a funnel shape. And also you can see the whole posterior fossa dura, how it is exposed completely. There is no cortical bone over the posterior fossa dura and the mastoid. See, like a C-shaped hole. Now if you incise this, you will be in the CP angle. So that is the petrous, that is the porous area. So I clear the disease from the porous. And this is the lateral sinus. You can see the sigmoid sinus is completely exposed. You try to remove that matrix at the end of the procedure to play a safe role, because accidentally while doing procedure, you should not injure the sinus. That is the reason you should remove this at the end of the procedure. So I removed it now. See, this is, look at this picture, how after the complete clears the disease. Now the whole fascia now, mainly I wanted to show the fascia now. This is geniculate ganglion, horizontal segment, vertical segment, second genu, and this is the vertical segment, and this is the stylomastoid foramen. The whole fascia now is hanging like a bridge, and this is the endolymphatic sac. This is a posterior fossa dura. This is the sinus plate, and here you can see the jugular bulb. And here I did a radical blind sac closure after complete clearance of the disease. That is from the sinus. Now I'm clearing the disease from the sinus. This is the middle cranial fossa dura. Now I'm doing blind sac closure. So before doing that, cauterize the mucosa of the SZ tube orifice. Now this is the end picture. You see clearly whole disease is completely. That's a very, very important when you do a blind sac closure. You should be more than 100% sure that you have completely removed the disease. Now see, look at this. This is SZ tube orifice. This is a canal for tensor tympani. This is a promontory. This is a round window area. This is a jugular bulb. And this is a posterior fossa dura. This is also posterior fossa dura completely here. And this is endolymphatic sac. Beautifully, you can see the endolymphatic sac. This is the intra-antemeatus. This is a vestibule. Completely, I cleared the disease from the vestibule. And this is a sigmoid sinus. It is opened here. So this is how you have to completely clear the disease. You should be 100% sure that you have cleared the disease. Then only you should do blind sac closure. If you are left behind any stamina, you cannot do the blind sac closure. Then when you're doing blind sac closure, you have to block the SZ tube orifice, the cartilage, and take abdominal fat. And this is a middle cranial fossa dura here. And now I'm doing a blind sac closure that is covering the extrinsic canal. So this is how this case was managed. And this patient is regularly, she's coming. Now I'm blocking the SZ tube orifice, the cartilage. and I taken abdominal fat and completely operated the whole cavity. And then this is the next is the facial palsy, the Bell's palsy. So I got a large series of Bell's palsy. So beyond doubt, now I prove that the Bell's palsy, the vertical segment will be involved. So there is a lot of controversy. There's no controversy now. People, if you see the old literatures up to 1980, there are more than 50 literatures of the book there. Everyone mentioned that the vertical segment will be involved. After between 70 and 90, there was a controversy, and they were telling that it's a labyrinthine segment. It is, according to me, it is only the vertical segment. And you see all the literature before 60 says that vertical segment is involved. And I've done a lot of study on that. Now, beyond doubt, we do, especially when you see the unrecorded Bell's palsy. If you do as a 3D reconstruction of the fascia now, the vertical segment in all the cases, the fascia now will be widened. You compare to the opposite side, it is widened. This is a very common characteristic feature. And also we do MRI to see then there will be uptake of this fascia now will be there. And also we are done, when you do a Schumer's test, in all cases, lacrimation will be present. If lacrimation is present, the lesion should be distal to the geniculate ganglion. And also we are done a study on the facial sheath. With this, I got beyond doubt, I have proved that this vertical segment will be involved in cases of Bell's palsy, unrecorded Bell's palsy. When I do decompression is, when the patient, if you give physiotherapy, steroids and medical line of treatment, at the end of 3 weeks, if the patient is still have grade 6 to grade 5 palsy, these are the patients who we may request surgery. If they are, the patient at the end of 3 weeks, if they are closing the eyelid, they will completely recover even at the end of 3 months, 3 weeks, if still patient has grade 6, these are the patients who are not going to recover. And this is how we do decompression. There is a transmastoid vertical to the decompress the fascia now. From geniculate ganglion up to the stellomastoid foramen, I decompress. And I'll show the pathology. Now keep observing exactly the pathology will be in the vertical segment. All cases, if you see the fascia nerve sheet, the dense fibrous tissue will be there. This is a dense fibrous. See, now that is the horizontal segment here. Up to here, it is very healthy. Beyond this, if you see the fascia now, it is not healthy, and it is a dense fibrous tissue is there. And if you compare this to a normal nerve sheath, inserting the vertical segment will be easier. Whereas in cases of unrecorded Bell's palsy, where there will be a dense fibrous tissue of the epineurium, which causes strangulation of the perineurium, and that causes the reason for the unrecorded Bell's palsy, which I have proved beyond doubt, and I have done series of cases. In all the cases, I have seen the same pathology. And to be on the safer side, always you decompress fascia now, proximal and distal to the site of lesion. Here the site of lesion is very clearly, you can see this is from the beginning of the second genu down, you can see almost up to the mid-vertical or proximal distal vertical segment of the fascia now is densely fibrous tissue here. It is very unhealthy, and this is the cause for the facial palsy, unrecoverment of Bell's palsy. So these are the cases when you do decompression. See, look at the pathology once again under higher magnification. You can see the nerve is not a healthy nerve. It has dense fibrous tissue of the epineurium, which will be now, if you want to incise the sheath, see, it is so difficult to incise the sheath because it is a thick fibrous tissue. Whereas a normal vertical segment, in one single go, you can incise the sheath. Whereas it is not possible to do that. And this is one of the characteristic feature of this unrecorded Bell's palsy. And also I had taken this thick sheath and sent for biopsy, and it has proved beyond doubt this is a dense fibrous tissue. And also we had done a comparative study of this sheath with a normal sheath, and definitely this is a dense fibrous. See, now still I have not got the perineurium because so many layers of thick fibrous tissue I have to incise with a tenotome to get the cleavage of the perineurium. So now, friends, if you see this, no one should have any controversy or doubt about this. As in all over the world, nobody will show any pathology apart, even though they say the labyrinthine segment is involved, but I have not seen a pathology like this, anybody showing. So here you can see the pathology is so clearly seen, and nobody should have any doubt about this. Look at this. Now I am getting the cleavage of the perineurium. See, it is so difficult to incise. And also keep observing the moment I incise, and also see that now you can see the thickness of this epineurium. It is so dense fibrous tissue. Normally the epineurium is this thick, and here you can see it is so thick. And also I take this piece of sheath and I sent for histopathology for all the cases. Now it is not possible to incise the sheath, the teratome, where I had to use the scissors to cut that. That is the thickness of this fibrous tissue. Imagine this dense fibrous tissue, it is completely strangulating the perineum. If you don't do this, these patients will remain forever with a great facial palsy, maybe up to 4 or 5. So these are the cases when you do decompression for unrecorded Bell's palsy, that is after 21 days, if they still have grade 6 facial palsy, immediately these patients will get 100% recovery. I done series of cases, and all the cases we have got an excellent result when you do timingly facial decompression for these patients. See, look at the perineum now. It is looking very healthy now after incising. And now this is how I'm taking the sheath for the biopsy. No, sorry, I'm incising the horizontal segment of the sheath. See, horizontal segment is, the sheath is so thin, you can see the shadow of my blade there. Easily you can incise the horizontal segment of the facial nerve. Always it is better to incise the sheath when you are doing decompression, then only you'll get result. And look at the end result, the whole nerve is completely exposed. And look at the sheath, it is so thick here, even though it has gone apart, look the thickness of the facial nerve sheath. So friends, this is the pathology in case of Bell's palsy, unrecorded Bell's palsy, and this is a segment, and this is the histopathology which shows thickened nerve sheath in all the cases. And look at the result. This patient had total grade 6 facial palsy preoperatively, and see, she was totally, Bell's phenomena was there, and post-operatively, she has completely recovered. That too, there was a very fast recovery was there in this patient. Look at it, 24 hours with the bandage. See, look at this after 1 year, 15 days and 1 month, she has got a smiling face. So this is the result, friends, you get if you do a timingly facial decompression for unrecorded. This we have published in the British Journal also. This been role of facial unrecorded Bell's palsy. The same thing holds good for Ramsay syndrome also we have done. The same thing holds good for that also. And radiologic evidence of involvement of the vertical segment Bell's palsy cases is very, very important. So now you can see very clearly, you can see the widening of the facial nerve compared to the opposite side. And also MRI with the gadolinium contrast shows enhancement in the same segment. You can see that this is also we are doing nowadays. So to prove that there will be a vertical segment will be involved in cases of these things. Coming to iatrogenic facial palsy, this is Vijendra's innovative sutureless grafting technique, which I have shown already. So this is iatrogenic facial palsy. I get a lot of iatrogenic facial palsy referred from all over India. Almost on an average, we do 1 to 2 cases every month. So now this is a case, the previous surgeon, instead of opening the mastite here, he has opened here. This they are done by me. So show the antrum, and the surgeon has opened here and damaged the vertical segment. So friends, always when you are doing mastectomy, juniors, this is spina fenlei. You should stay superior to the spina fenlei, never come inferior to the spina fenlei. And if you try drilling here, you will not get the antrum. You keep going in this direction and damage the second genu of the facial. A very common site of lesion will be second genu. And at least in my series, 50% of the cases that I have seen, even they have damaged the lateral subsecrena. So friends, that's why I always stay between the root of the zygoma and the superior to the spina fenlei, and don't come inferiorly. So this is the pathology here. So, but always it is better to do canal wall down procedure to get a good exposure to do grafting. Now I am doing a canal wall down procedure, and the victim of I got a very vast experience. So now with my experience, always I very liberally expose the nerve, normal nerve, proximal and distal to the site of the lesion. Now this is the neuroma has formed here at the site of the lesion. Now I'm excising that. And send it for histopathology. And most important thing is when you're doing grafting, see now you have to expose the normal nerve and cut the normal. Don't cut near the site of this neuroma. So go away and expose the normal nerve. And then I use this sharp, this disposable ophthalmic knife. It's very, very sharp. In one cut, you can slice the nerve. If you slice the nerve fibers will not be crushed. If you use a blade and try to cut, the nerve fibers will be crushed. If you put grafting for nerve crushed fibers, the results will not be good. All these small things makes hell of a difference. So that's why this is a disposal blade. Only once I use, once if I easily can slice it, so the cut edges of the nerve fibers will not be crushed. Look at this, how easily it cuts. And also it has got a long blade, you can hold it very easily and then slice the nerve. So once if you slice the nerve, if you still look at the cut edge of the proximal and distal segment, the cut edge also should be healthy. See, this is a very healthy one. So if this is healthy, automatically the proximal segment is healthy. So you have to do grafting to a healthy nerve, not to unhealthy nerve. That is very, very important. And in most of the cases, what I do, I try to retain the facial nerve sheath posteriorly. So if you retain the facial nerve sheath posteriorly, you get a good vascularity. Now, my technique is that I do a wrap up, take a temporalis fascia and wrap up 360 degrees. For that, I am incising the epineurium. I incise the epineurium and then I can expose the nerve 360 degrees perineurium. Similarly, you see that now I'm incising the epineurium in the distal segment is almost near the stellum acetylphenol. Look at the healthy nerve here. So like that, you should get a very healthy nerve. And see, 360 degrees, I'm lifting the nerve fibers and separating from the epineurium. So once if I lift, what I do, I keep a temporalis fascia, thin temporalis fascia below this and put a graft and approximate this and wrap up this temporalis fascia 360 degrees. This is what I call it as a sutureless technique. Similarly, you can see how I'm getting a good, healthy proximal segment and lifting it from the facial nerve sheath. So 360 degrees, you lift it up and I keep a fascia underneath that and wrap it up. See, always I take a great auricular nerve. So it is a very good nerve. The diameter of the great auricular nerve will be very nice. And one more thing here, see, I have used the scissors here to cut the nerve in the neck because I cannot use a blade. So this is a crushed edge stuff. That's why I don't want this. That's why I use a blade and slice it. Now this nerve fibers here is not crushed. So then the result should be good. If I use this, because nerve fibers will be crushed, the result should not be good. This is how take approximate size. I'll show once again how I slice it. That is very, very important thing. See now how I sliced with a blade, razor blade. See, I'm slicing with a razor blade, both the sides. So now this length should be proper. It should not be too short or too long. Now, see how nicely. Now, if you see, you don't see any display. It looks like a normal now. And this is how I wrap up with a temporalis fascia, 360 degrees. And it will be there. It will never move. And this is a very easy technique. Earlier, I used to do suturing. It takes long time. See, nicely I wrapped up. This is what called as a Vijayan's technique of sutureless technique. And primary ossiculoplasty also I had done in this case. And see, this is the result I got in this lady. So actually this is done. So 45 days after the iatrogenic palsy. So she had almost grade 6 facial palsy. And this patient still now she is coming for follow-up almost 6-7 years over. And now look at this after 120 days, after 365 days, up to 1 year, you can expect good result. And this is the result she has got. She has got excellent result and almost grade 2, I can say. People say that you don't get grade 2. Look at this, the result. Even the frontal is there, some movement is there. So we cannot make out that she has got a facial palsy at all. So this is the result you can expect. The smaller things, which all I told, crushing, all those things will be slicing. All these things are very, very important. Lastly, I'm going to show another this thing, facial schwannoma, a case from meatal foramen extending through the stellum into the neck. This facial schwannoma patients is a very slow growing tumor. Patients they present with a mild facial weakness, sometimes recurrent facial nerve palsy. Whenever you come across recurrent facial nerve palsy, always you should think of facial schwannoma. And this patient had 2 or 3 attacks of facial palsy and which had recovered. So now he had grade 5 facial palsy. And when a suspect saw that tympanic membrane was normal, and when I did a CT MRI, it was showing a facial schwannoma vertical segment involving the vertical segment from the second genu going through the stellum foramen. Look at this MRI scan. The whole vertical segment is completely inward and it has gone beyond the stellum foramen and it is in the parotid region. It was seen in the neck. See, this is the tumor in the parotid region. It was like a dumbbell-shaped tumor. It was coming from the vertical segment to the stellum foramen and extending in the parotid. This is how this patient has MRI presented. So again, this is the same CT scan MRI you can see. Now you see, now whenever I want to do this, I have to access the tumor. So we have to do canal wall down procedure so that a good exposure will get. Now you can see this is a facial nephronoma here, which was seen very clearly in the CT scan. And you see, look at the middle ear is very healthy, stapes is very healthy. Incus, I removed it. Of course, when I want to do this canal down, see, I'm lifting. See, look at the tumor, how it is like a dumbbell shaped. It is there in the vertical segment. Now I'm going almost up to the stylomastoid foramen area. That is the stylomastoid foramen area. Now you can see the pathology. So nicely you can see that whole the fascia now, how it was bulged out. Now you have to get a normal now. So I'm going, but in this case, there is induration, infiltration of the tumor mass almost up to the geniculate ganglion. From the geniculate ganglion, I dissected the nerve. I'm reflecting the nerve from the geniculate ganglion. That is the stapedius muscle. Fallopian canal is very nicely seen here. And now the challenge was, it was going through the stylomastoid foramen into the neck. So now I did a neck dissection. See, now we can see that the tumor was coming here and it was sitting in the over the parotid area. So this is how it was coming out. And then I cut the nerve here. This is the before the branching of the fascia now. And now in this case, this is the last case. Another 1 minute, I'll be finishing it. Yeah. Now you can see that I'm passing the instrument on the neck. See, that is from the stylomastoid foramen area. From the neck, I am passing the instrument, and grafting was done in this case. And of course, there's a good improvement was seen. So with this, I conclude my lecture. I thank you very much for the organizers for giving me this opportunity where I shared different pathologies, the fascia nerve which we come across, and this is how one can manage the fascia nerve on about pathologies in middle ear. Thank you very much. Thank you for your patient listening. Thank you.
Thank you so much, sir, for such a wonderful lecture. I now request Dr. J. Srinath, President-elect AP-AOI, onto the desk to present the mementos to our chairpersons, Dr. B. Nageshwar Rao and Dr. Fariduddin.
Sir, Dr. Vijayendran Garu, thank you very much, sir, for showing this facial bridge technique. Again, this sutureless, Dr. Vijayendra sutureless facial nerve grafting technique.
Thank you,
the
sir.
Nice way you have used your razor blade instead of your scissors to prevent the injury to the nerve endings, cut end of the graft. Thank you very much, sir.
Thank you.
Thank you very much.
Dr. J. Srinath Garu, President-elect AP-AOI, onto the dais to present the mementos to the chairpersons. I request Dr. Y. Subbarayadu, Secretary AP-AOI, onto the desk to give mementos to the chairpersons. Thank you, sir. A kind request to all the physical delegates. Dr. T. Krishna Kishore sir's delegate bag has gotten interchanged with another physical delegate by mistake. We kindly request you to please check your contents of the bag for a white spiral notebook, and if found, please report to the podium. Now we move on to the next Dr. B. Harnath oration by Dr. Sirish B. Gunn on silendoscopy, a frontier between the known and the unknown. I request the chairpersons for this session, Dr. Kailash Pujari, Head of Department Manipal Medical College, and Dr. B. Singari Prabhakar, Chairman of Singari ENT Hospitals, Vijayawada, to occupy their seats onto the dais. I now request Dr. P. Ramesh Chandra, Assistant Professor of Government ENT Hospital, Visakhapatnam, to introduce Dr. Sirish P. Gunn to us.
Thank you. Let me introduce to you the Dr. Sirish Balachandran Gunn. Dr. Sirish Balachandran Gunn has done MBBS and MS ENT from Bairamji Jiji Boy Medical College from Pune. He has done DNB ENT from Delhi in 1996. And he is in private surgical practice since 1997. And he is a consultant ENT surgeon in multiple hospitals in Nashik and Pune. And he has been a guest faculty, operative surgeon, and a judge in a number of CME programs and number of surgical workshops held at Mumbai, Pune, Aurangabad, Nashik, Kolhapur, Ahmedabad, Raipur, Kolkata, Mysore, and also in number of international platforms like Geneva, Dubai, Alexandria, and Philadelphia. And it's very interesting to know that he has done a paper publication in the first International Silendoscopy Conference, Geneva, titled To Assess the Diagnostic and Interventional Potential of Silendoscopy in Recurrent Parotitis. And he has authored 2 chapters in the first handbook in the World on Silendoscopy, published in August 25 at the European Silendoscopy Training Center. And he has a vast experience in the field of otology, endoscopic sinus surgery, and silendoscopy. And he's one of the pioneers in India in this field. He has held a number of posts also. He's the Secretary Association of AOI in Nashik, then a President AOI, Nashik chapter. And he is a founder member of Silendoscopy Group of India. And it is very interesting to know that he has a vast interest in social work activities also, in multiple social work activities like a shared parenting programs, and Vanavasi Kalyan Ashram, and a number of social activities. And it's interesting to note that he is a sports person. He is a good badminton player. He's a state level player. He has won a number of awards. He's interested in trekking. He has done a number of trekking programs. And a very interesting thing is he is interested in flying also. Okay, and he's in the process of getting a private pilot license. And he has done a number of trekking programs. Very interesting CV, sir. Thank you.
I request Dr. Shirish Khan to give his oration on silendoscopy, a frontier between the known and the unknown.
Good afternoon, everyone. Am I audible?
Yes.
Okay. Is my presentation on the screen right now? Hello? Hello? Hello?
Yeah, it is seen. Please go ahead.
Okay. Thank you. Thank you, the organizers of this wonderful conference. It is an academic feast, and with deep humility, I accept to give this oration in the name of Dr. B. Harnath. He is an exceptional teacher. That is what I got to know, and I hope he would. I would do justice to this oration. Silendoscopy is a frontier. It's a new science between the known and the unknown, because The question, I would have loved to be in Vizag, a city which has stalwarts like C.V. Raman and Sarvepalli Radhakrishna Rao. The museum is something which I would be so much interested in looking at. But probably there's a next time when I will be in Vizag in person. This is my alma mater, BJMC Pune, and this is where I have learned all my graduation and post-graduation studies. The question that is normally asked is, why silendoscopy? I mean, we can just remove the submandibular gland. I remember talking to a senior gastroenterologist, and he said that ease of surgery should never be an indication for surgery. So just because I can remove a gland, I should not be removing it. So this question pops up time and again when I'm talking about silendoscopy. And my answer to this is
to explore strange new worlds, to seek out new life and new civilizations, to boldly go where no man has gone before.
So, I mean, it's logical, isn't it? If there is an obstruction, then removing the obstruction is what you should be doing and not removing the entire gland. Now, we know the anatomy, I will not dwell on it, but this is the known fact. We also know through the xylographies some of the anatomy of the ductal system, but again, it's just an indirect evidence. So what exactly is silendoscopy? Silendoscopy is using a miniature scope through the natural opening of the duct to enter into the duct system and explore it completely and find out whatever is the reason that is causing the obstruction and treat it also ultimately. So as you can see, this green is the guide wire and you can see multiple tributaries there. So when I saw this for the first time, I was thrilled because for me, this existed in theory. But for me to see it first time with my own eyes was a life-changing moment. And as you can see, this is a beautiful picture. You can get a very clear picture of what the anatomy is, what the pathology is, and you can relieve the patient of his symptoms. And that is one of the most gratifying things that we can ever get. So if you look at the history, the idea started somewhere around 1985 of trying to put in a fiber optic fiber into the duct. By 1990, further modifications were done. By 1995, the first scopes were, built. And since 2000, the field has exploded. We have more than 500 silendoscopy surgeons all over the world. So this is a fantastic thing. A lot of work has been done by Professor Francis Marshall from Geneva. And with this, I also got interested and I said, let's take up a new field. Now, how do we go about it? There are basically two types of scopes. This is a modular scope, 1 millimeter in diameter for the adults and 0.75 millimeters for the pediatric patients. This is a modular scope which has a sheath onto it, and you can see an instrument channel. A balloon has been passed, and this side port is for irrigation. I'll come to why we need to irrigate. The other type of scope is the all-in-one scope. As you can see, everything is machine tooled into one. So you have the instrument channel, the irrigation channel, and the optics. This is where the camera sits. If you look at the distal end of the scope, you will see this is the instrument channel, this is the irrigation channel, and these are the optics. Now, basically the papilla, as you all know, is a very small structure, very pinpoint. So you have to dilate it to be able to enter into the duct. So there are various types of salivary probes that we use. These are there on display. Then we use a lot of baskets. You can see a variety of baskets, variety of handles to operate those baskets. We use tents. Fortunately, these tents are made in Bangalore and they work very well. And this is the general trolley setup for the surgery. And this is the schematic OR setup. I sit and operate on the right-hand side of the patient. My assistant is also on the same side because both of us have to be able to see the video trolley. My assistant seeing the video trolley is important because he will have to do certain things without me telling him, and he can do it only if he's observing what's happening on the screen. This is actual procedure happening, and you can see my assistant, his eyes are glued to the TV screen, which is opposite on the opposite side. So what are the indications? I mean, simple, there is only one indication: obstruction to salivary flow. That's all that is the indication. So some people might think that, oh, it's one single indication. But let's look at it this way. If you look at all salivary gland disorders, 80% are obstructive, if you consider both the submandibular and the parotid. So a huge chunk of salivary gland disorders can be tackled by salivary gland endoscopy. Professor P.P. Singh, he did a study, and he found out there is one stone and one stricture per 20,000 population every year. So in India, it amounts to 120,000 cases per year, or 130,000 by now. Nashik district, where I live, has a population of 6.1 million, so approximately 600 new cases every year. So this is the volume load, case load that we face, and I believe we should be looking at silendoscopy as one of the very lucrative branches. Symptoms and signs, easy, as you can see, recurrent swelling of the salivary glands, generally associated with food intake. There will be pain, there can be pus or foul smell, pus discharge into the oral cavity. Signs are hypertrophied gland, a nodule surface, especially of the parotid, sometimes a palpable stone, and especially in the parotid, a duct that is tender indicates that there is a pathology. You can palpate the duct in a clenched jaw situation across the anterior border of the masseter. Now, what are the types of obstructions? So we'll get a ductal obstruction, which is like the lumen being obstructed by something, like in a traffic jam. So they could be siloliths, or they could be foreign bodies, and foreign bodies could be again animate or inanimate. You can also have obstruction due to ductal narrowing. That is a stricture formation, as you can see here. Now, ductal obstructions, because of siloliths, you will see a lot of different size and shapes of stones. You will see animate, inanimate, foreign bodies. I'll be showing you videos of that. And the surprising thing is ductal narrowing. It is quite common and presents as a juvenile recurrent parotitis, young children with recurrent parotid swellings. Adult recurrent parotitis, more so common in the female gender. We can see sialadenitis, sialadenosis, Sjogren syndrome, radiation-induced sialadenitis, and as radioiodine-induced sialadenitis, as radioiodine treatment has gone up for treatment of thyroid cancers, we see a lot of radioiodine-induced sialadenitis. What are the relative contraindications? And why do I say relative contraindications? Is because, as we see in all fields, contraindications which exist today need not necessarily be so tomorrow. So acute sialadenitis is a relative contraindication. Very rarely in acute sialadenitis, not responding to conservative line of management, we do an interventional silendoscopy and remove the obstruction and relieve the patient of the infection and the symptoms thereof. The other limitations, which can be large siloliths, for which we will do combined approach, I will be talking about it. Intraglandular siloliths. This again is a question which quite a few people have, but there is nothing called as intraglandular siloliths. The siloliths are in the intraglandular part of the duct, which means basically you can approach them through the duct using a silendoscope. And very tight strictures which we cannot dilate, then we can do a combined approach for the strictures too. Investigations are basic. I mean, an X-ray for the stones. Ultrasound is the chief investigation that I would ever order. And if necessary, then an MR silography and a CT if required. But conventional silography is something which I do not agree upon, because for the fact that for a radiologist to get into the papilla is difficult. If there is a scarring of the papilla, then the chance of a silendoscopy is lost. So how do I deal with a patient who comes to my clinic? I mean, the patient is symptomatic. He lands up in my clinic. I will do an ultrasound, which tells me whether there is a stone or there is no stone. If there is no stone, it means either the stone is less than 3 millimeters, because some ultrasounds do not detect stones smaller than 3 millimeters, or there could be a stricture, or there could be a missed stone because the sonologist has not followed the duct right up to the papilla. So at this stage, what I will do is I'll do a diagnostic as well as a therapeutic style endoscopy. So if I have a stone, I remove the stone, end of the story. If there is a stricture, I dilate the stricture and put in a stent, and that is the end of the story. But there are certain cases which do not follow this course of action. There is a discrepancy between the imaging and the actual style endoscopy. So if there is a discrepancy, then what I do is I do I suspect a stone, then there is a CT, and if there is a stricture, then I do an MR xylography. Ultimately, this will have to undergo style endoscopy to relieve of whatever condition is there. The most important thing is saliva is a friend, so we avoid perioperative atropine or glycopyrrolate. Most of the times, I would rather give a LIMC 15 minutes before surgery to increase the flow of saliva, because that helps me identify the papilla. Especially for the submandibular style endoscopy, which can be done under local anesthesia of the inferior alveolar or the lingual nerve block. And this is quite commonly given by dentists. So we can learn from them. And generally, when I use general anesthesia, which is more common than local anesthesia, then I use a North Pole intubation through the nasal cavity. What exactly is the procedure? I mean, the first thing is you have to identify the papilla. So how do you go about it? I put all my patients under the microscope when I have to identify the papilla. So we all know the parotid papilla is in the cheek vestibule opposite the second molar. The submandibular papilla is just adjacent to the frenulum of the tongue. So we have to look carefully, and we have to increase our experience of looking for this anatomy so that we get used to the variabilities and we don't miss out on finding a papilla. You can do an external massage of the gland and see egress of saliva from the papilla, and that can give you the clue. Sometimes the opposite side papilla is easily identified, and generally it will be similar on the side that we are interested in. Very rarely we need to inject submucosally saline so that the papilla stands up like a saucer. Papilla dilatation, look at this. This is the dilator going in. This is the conical dilator going in. One after the other, larger dilators going in. And you can see the papilla enlarging in size. This is the largest, number 5 diameter, and that's the scope which is going in. So that was for the submandibular. This is for the parotid. You can see the parotid papilla. You can see the angle at which the dilator goes in. It is not parallel, it is not perpendicular, it is at about 45 degrees to the surface of the mucosa. And progressively larger diameters. This has to be a very delicate technique because you cannot force a lot of bleeding, and then if you miss out onto the papilla, then your entire surgery is jeopardized. So once we have the scope into the papilla, what we do is we do a diagnostic style endoscopy. As you can see, we go in, we see multiple tributaries, we can see carinas, and I'm going to, move these videos a little faster because we are already running out of time. And as you can see, we can explore using the guide wire, we can explore the different ducts. We can explore ducts up to the size of the scope, not ducts smaller than the size of the scope. So as you can see, we have gone into this duct, explored, do we have any findings over there? And accordingly, we treat. This again is a diagnostic style endoscopy. You can see a tributary here. And you can now see a salivary gland stone. So once we have seen that, then we have options of removing that stone. You can see multiple stones in this scopy. But before we do this, one concept has to be cleared, that we have to have irrigation. And why? Because look at this pipe. As soon as the fireman opens up the wall, this pipe it enlarges and then it has a cavity. Otherwise, it is a potential space. The tube is collapsed. Similarly for the salivary gland ducts. Now, this is just to explain it to you. After ranula excision along with the sublingual gland, you can see the duct, the scope has gone in, and you will see as I irrigate, you will see the duct enlarging. And then it gives you better vision. Now, this is how it looks endoscopically. Once the moment my assistant irrigates, the duct expands. And I can have a better view. It collapses. So again, I will ask him to irrigate. And most of the times now I don't need to ask him because he's seeing the picture on the screen and he irrigates accordingly. Now, if we find a stricture, what do we do? See, this is the scope going inside the duct. Here we find a stricture, sudden narrowing of the lumen. So we pass a guide wire. We allow the guide wire to go in. The guide wire is 0.5 millimeters in diameter. And once the guide wire goes in, we follow it with the scope. And then we can see we have entered into a larger cavity, larger duct, where we see a tributary. So that's the proximal system, which appears to be normal. And then we withdraw the scope, and as you can see, now the diameter has enlarged to quite a larger size. Now, why does stricture dilatation work? I mean, we all know Poiseuille's law, where it says the flow is directly proportional to the fourth power of radius. So it's not a linear progression. What happens is, as the diameter increases, as the radius increases, the flow jumps up quite well. For example, in this table, as you can see, if the radius is 1 millimeter, the flow, every other constant variable being maintained at a same parameter, the flow will be 1 x ml per second. If we increase the radius by 2.25, the flow jumps to double. If we increase by half a millimeter, the flow becomes 5 times. And if we increase the radius to twice what it was, the flow will jump to 16 times, which basically means the resistance is reduced. And that's why it works quite well. As you can see, this is the dilated portion of the duct. As we are withdrawing, we can see a large bore lumen. Now we come to the stone removal. This is a video which is, how you go about it. It's a conceptual video. You have the scope. You see the stone inside the duct. Then you pass in the basket through the instrument channel. The basket is in a closed state. It goes beyond the stone. Then you deploy the basket. You withdraw the basket, slowly closing it over the stone. Once the stone is trapped, you withdraw the entire assembly, the basket and the scope, out through the papilla, because there's no way that a stone can be extracted through the instrument channel. The scope, the largest channel size that we have is 1.7 millimeters. And 1.7 millimeters is too small for a stone to come out. So this is what it actually looks like. You can see this is the basket in a closed state. You see a stone. That's the basket being deployed. And then the stone being trapped. And the entire assembly being withdrawn out. There are other baskets also. As I said, you can see this is the basket. It is being deployed. It takes a little bit of coordination between your assistant and yourself, because you have to maintain the picture at the same time. He or you operates the basket and he is also irrigating. So 3 processes going on simultaneously. Once we have the stone trapped in the basket, then we, as I said, we draw it out of the gland. We can also use a forceps, but mind you, a forceps is much thicker than a basket. You can see these jaws of the forceps here opening. And then we are trying to catch the stone. It's a bit like the video games our children play. Probably they will be better at doing these things. And then it's like a forceps is going to catch the stone and we get it out. But remember, all of this is happening through a scope which is not more than 2 millimeters in its entire diameter. Probably the reason why we don't use forceps to remove foreign bodies from the nose, because it tends to slip down. The same thing happening here. But finally, I managed to catch it and then we get it out. We can obviously use a laser. So this is a laser. We are fragmenting the stone. You can see a fragment coming out. Once the fragment comes out, we deliver it using a forceps or a basket. And sometimes it's a small fragment that is removed. Then it allows the stone to come out through the narrowed part of the duct. So sometimes even a small fragment can help change the equation in our favor, and then you don't need further laserization. But sometimes you need a lot of time to laserize the stone. And you can see the stone has been broken because of the laser. A lot of heat is generated, so irrigation is a friend here again. Extracorporeal shortwave lithotripsy, I would not dwell too much on it because it's nearly not available anywhere in the world except Germany, and only one place in Germany. The machine, they have stopped making it, so not too much. And what do we do? At the end of it, we generally would stent. So this is a stent going in through onto the guide wire. The guide wire which was placed at the end of the scopy into the duct under vision, and the stent is now railroaded over it. This is the left parotid. You can see the guide wire going in through the papilla. Now the stent will follow. And you can see holes on this distal end of the stent where we can suture. This is for the submandibular. Again, the same procedure. The guide wire was in place. You can see the tongue frenulum, the tongue here, and the stent going in, and then it's suturing. But what do we do for large stones which cannot come out through baskets? So also there are situations where you may have a stone which is distal and a proximal stone, or it could be this way around. It could be a stricture which could be distal or proximal to the pathology that is seen on imaging. So what do we do? So we have an algorithm for that. If the silolith is less than 4 millimeters, generally we will be able to do it silendoscopically purely. If it is 4 to 8 millimeters, some of them might come out through silendoscopic, pure silendoscopy. Some will have to undergo a combined approach, and greater than 8 millimeters, there is no hope that we can do it purely silendoscopically. So with silendoscopy, we catch hold of the stone, drag it forward, and then do an internal combine. So what exactly is it? It's called silodocoplasty. As you can see, we diagnose the distal pathology. Distal is something that is close to the papilla. This is the distal end, the hilum is the proximal end. So if we see a stone, we catch the stone in the basket, get it out. After that, we again pass the scope and see this stone, which was proximal to it. And again, we may remove it. If there was a stricture, we would dilate a stricture and put in a stent. If we have to remove this stone using a ductal incision, Then we pass in a stent and we close the duct over the stent. So what we have done is we have removed the obstruction or the obstructions, and we have maintained the natural outflow tract of the duct. That gives me time to have a very easy sleep once I've done this. Now let's look what it looks like. This is a stone being diagnosed. It has been a large stone. It is trapped in the basket. Now it cannot come out through the papilla, large stone. So we have now taken an incision on the floor of the mouth. We are delivering the stone through the floor of the mouth, passing in the scope, checking that everything is fine. This is the cut end where we had incised, and you can see the stent inside. This is being sutured, so that's the stent and the suture. So the normal outflow path is established. We can also do for the parotid an internal combined approach. How do we go about it? This is from
It is 14,
live surgery.
right? And so the duct is obviously smaller on the rest of its portion than the
That
stone.
is Francis Marshall.
Right.
So we are
Did you
communicating
plan to
about the plan
fragment,
for surgery.
or did you plan if you get the impossibility to retrieve it with a basket? Did you plan a combined approach? What's your plan?
Yeah,
Plan
my
A,
line
plan
of
B, plan C.
Right. Plan A would be try to trap it in a basket and get it more proximally, rather more distally, and then do an internal combined approach.
Okay.
I do not have a laser, so I cannot fragment it. The only thing which I can fragment it with is a handheld burr that is provided, but that requires a larger instrument channel.
Okay.
So I don't know if I will be able to put that kind of a sheath through this boy's duct.
Okay. And
So
the
my
last
plan
question is
right.
Yeah, last question is how many centimeters?
So when we do an external combined approach, you can see this was the swelling. We went into the scope. You can see the scope light here. So we now know where the stone is. And then we did a small stab incision. And these stab incisions, if taken on the facial crease lines, then they heal extremely well. And we can remove the stone and the patients are happy. We can also have a mini facelift or a mini parotidectomy incision and then remove the stone from here. So that is also done. But generally, I prefer doing a stab incision on the face. The scar is not something that I need to worry about. I need to assure the patient that there will not be an ugly scar, because the incision is somewhere about a centimeter or so at the most. Because with the silent endoscope, we have pinpointed where the stone is. Now, if you look at submandibular stones, this is data from a few months ago. Purely endoscopic, I could remove 54 of the 114, and then a combined approach was 60. If you look at parotid stones, purely endoscopic were 26, external combined were 8, and internal combined were 4. For post-operative care, that's we, at the end of the procedure, I instill intra-op into the duct local antibiotic plus steroid, especially if it is stricture, analgesics, antibiotics, ice fermentation. We avoid sour foods till the time that heals. The combined approach, and head up 30 degrees immediately post-op is all the post-operative care that is required. Probably she is speaking in Marathi. But you can look at the smile that she is having. That is the post-op smile. So that is a wonderful thing to get as a feedback. Now, there has always been this issue of people saying that if there is a stone, the gland is non-functional. And I have said that every gland that has been removed, I mean, the submandibular gland is removed at the drop of a hat, but the same doesn't hold true for the parotid. And I've said once the gland has been removed and is lying in a petri dish, we can never prove whether it was functional or non-functional. So let's look at this. This case, pre-operative, you can see that is 10th of November. You can see a stone with the post-shadowing effect, and you can see the echo texture of the gland. 25th November, post-operative, 14 days, and you can see the echo texture of the gland has changed, and this is where the stone was. Now, look at the post-op picture of both glands, right and left. Do you find any difference between the echo texture? No, which basically means once the stone was removed, the gland reverted back to normal. The right and left cannot be distinguished. So it basically means just because it is an obstructed gland, it does not mean it is non-functioning. Actually, most of the times the swelling shows us that the gland is functioning. So just do not remove a functioning organ that easily. What complications do we face? I mean, if there is bleeding, generally we have to be very gentle with our instrumentation, wait for a while, and flushing with saline generally helps. You can see a lot of vasculature. Infection can happen because of lack of sterilization, generally treated with antibiotics. TM joint sprain happens, especially in submandibular cases, but we give bite blocks and analgesics will help. Swelling due to irrigation, that can happen because if the assistant is not aware enough and you are not aware that the assistant is pumping in saline like he's a firefighter, then the parotid gland especially swells up. In the parotid, it will cause pain, but we are more concerned about the submandibular because it can give rise to respiratory obstruction post extubation. So generally, we have to train assistants, and ice fermentation and head up is something that we would do. Now, one of the most important things as a silent endoscopist we have to know is, have we perforated and gone outside the duct? Now look at this picture. Remember, this picture will tell you that we are not in the lumen. You have seen a lot of videos. The lumen looks different. If you see something like this, we are definitely not in the lumen. I'm going to show you a video of the perforation that I had caused. Everything looks like a lumen, but you will have floating strands. If you have a floating blood vessel, definitely you are outside the lumen, because the tissue around the submandibular duct is soft. Anything you poke into will create a passage. So we have to be very aware. You have to know how to diagnose. So once we have this picture in mind, we should not be doing anything. We have to stop. We give conservative treatment, and then we can do a rescopy after 1 week. The other complications which can happen is post-op strictures. So we have to be very careful, avoid mucosal damage. This can happen very commonly with lasers. We have to avoid conventional silography, as I said, because it can cause stricture to the papilla. And once we have dilated, then we stent and we give steroids. Degloving is something, it's like intussusception. The duct, because you force in your scope without proper dilatation, the duct intussuscepts in, it degloves. As you can see in this picture, this is the guide wire outside. This is the cuff of the mucosa of the duct. So avoid excessive force, and recannulation and stenting can be done, and it has been successful. But if not, then you have to excise the gland. And gland removal is the last complication. We can use combined approaches, and I would generally avoid doing a gland excision for an obstructive disorder. And instrument breaking inside, we have to properly select cases for the instruments that we are using. Rather, we have to select the instruments for the cases that we are using. And combined approach or gland excision is what is required. Neural damage can happen because we have the facial nerve close to the duct in the parotid, the upper and lower buccal branches, and the lingual nerve in the submandibular duct region. So meticulous dissection is what can be done. If you damage the lingual, well, you really cannot do anything to it. But so don't do it. And my experience, I would say the number of the sex distribution is nearly the same. This keeps on changing over a period of 6 months, a little here and little there. So no significant difference. Age range from 3 years to 81 years, most of them in the adult age group. Symptom durations from 8 days to 38 years. I mean, this patient did not want a scar on his face, so he waited 38 years for his salivary gland stone to be removed. Stent duration, sometimes the stent can come out in 1 day because we really cannot splint the mouth. Follow-up can be from 1 day to 8 years. It depends upon what kind of case. Now, if we look at the submandibular, we see a lot of stones, obviously, and very few strictures. The exact opposite is in the parotid. Very few stones and a lot of strictures. And this follows the book picture that we see, the 80-20 rule in the salivary glands. Now, if you see the total number of cases are nearly 450. I could not cannulate in 10 patients. Siloliths were like 220, strictures were somewhere 210. I did not find anything in 15 cases, so these are still left. Why were the patients facing obstructive symptoms? And there were other cases which are about 6. But remember, the most important thing is of all these cases of the submandibular 220, I had to excise only one submandibular gland. So that I think is a significant, and that is a message I think we should all carry home. As mentioned in my introduction, I have chapters in a book, the first hands-on book on silent endoscopy. This is a wonderful book for anybody wanting to learn the technique of silent endoscopy. And we have courses happening periodically at the Minimal Access Surgical Training Center, Mumbai. So you can log on to their website and they will keep you informed. And I believe that this scopy should not be done without training because the scope is very delicate. We have had doctors who have taken a demo scope and then broken it on the first attempt. That is pretty discouraging. So take a good training, be more confident and get into the field. This field is vast, it's beautiful, and it's rewarding. Now, parotid megaduct, look at the cases, other cases that we can do. A huge swelling, and this is the immediate post-op. So you can see I'm into the duct. Again, the stricture, the guide wire going in. And then the scope follows the guide wire and enters into a cavity. It is all a muck-filled cavity. You can see it's a large cavity. The rest of the video is emptying the paratocele. And this is the cavity of the paratocele. So if you see, this is 0.5 millimeters, this is 3 centimeters. And such a huge cavity, you put in a stent, but these patients will require repeated dilations at least twice or thrice till the time that the paratocele settles. Interesting case. Submandibular gland was excised for the stone. The patient still remained symptomatic. We did an ultrasound. There was a stone seen. So we went in with a silendoscope in the duct remnant which was there. And as you can see the stone, we removed it. This is the blind pouch of the duct. And you can see the duct is not as viable as the other videos because this now has no function left, but it can still give rise to symptoms of infection and it mimics obstruction. A patient with tongue tie fibrosis done 1 year ago was advised, he developed obstruction of the submandibular salivary gland and he was advised gland excision. He landed up, you can see this is the tongue frenulum, right papilla, left papilla not very clearly seen. This is easily gone into this. When I went in, I could not get the proper lumen. So I dissected the floor of the mouth, found out the duct, that was the papilla, incised onto the duct here, went in, confirmed that this is the lumen, this is the duct, passed a guide wire, passed a stent, sutured a neopapilla around the stent. This was the size of the neopapilla. And that was one more gland saved, a functioning organ saved. Now, foreign body, quite a lot of stones turn out to be foreign bodies. So as you can see, when we go in, if I see a mucus plug this thick, it is a telltale sign of a stone behind. So for better visibility, I removed the mucus plug using a forceps. Once it was removed, I could see an odd shaped stone. You could see, I mean, this is not how normally a stone would look like. And then we passed a basket, trapped that stone, looked like a double barrel kind of thing. And we got it out. And this is what it was. So you can see a vegetative foreign body, the stem and the concretions over the body of it. So this was what was inside. Now, this was an interesting case reported as a soft stone. My sonologist said it is not as radio dense as a regular stone. The post shadowing effect is not there. We went in, nevertheless, I could see a small forehead body there, something, the main forehead body over here. And when I put in the basket, the basket is the brown colored one. I trapped the forehead body in the basket. As I was taking it out, I could see a broken wire inside. And I was wondering what was happening. And I will show you that broken wire. And I was using a 3-wire basket and I could see the forehead body trapped. And yet there was a broken wire outside. Can you see 4 wires now? 1, 2, 3, 4. While my basket had only 3 wires. What was happening? But the fact that the stone was coming out, I was happy, more than happy. And here you see the broken wire. Here you see the broken wire coming out. I removed it. And guess what it was? It was an insect. So this is the only documented case of an insect causing recurrent parotitis all over the world, as far as I know. So fascinating things happen. Radioiodine, as I said, a lot of radioiodine treatment for thyroids is being done, and we miss the fact that the radioiodine also concentrates on the salivary gland. It causes a lot of damage to the salivary gland. You can see this is the mucosa, petechiae, doesn't look healthy. It looks like, I mean, nearly a cadaveric mucosa. This patient also coincidentally had a stone, so we removed the stone. And there are a lot of patients who have strictures and dry mouth after radiation. These can be helped with this thing, with silent endoscopy. Now, this is also an interesting case. 3 stones seen, large stones in the parotid. I couldn't find anything in the ducts. As I said, ducts were normal. So one of the stones was palpable. So I did an internal combined and I removed one after the other 3 stones. And they turned out to be calcified phlebolytes. Now, remember one thing, if I went back to the radiology journals and found out that if there is a radiolucent center on an X-ray or CT scan, then they don't treat it as a ureteric calculus, they treat it as a phlebolith. And coming back, I realized that all 3 had a radiolucent center. So this would have, if I would have had known it, this would have given me an idea that this was not a silolith causing the problem, it was a phlebolith issue. Now, and the list goes on. We can treat facial trauma leading to duct transection. We can do post-superficial parotidectomy, silocele treatment. Fistulas can be treated. Symptomatic relief in dry mouth disorders by irrigation. Now, this is like a post-facial trauma parotid fistula. He had a cut because of a shrapnel and he was sutured outside. He ended up with facial palsy and a fistula and a silocele. So I went in, found out the duct, cannulated rather, stented the duct, did the facial nerve was trapped in the sutures. So I removed those sutures and he has had a better post-op relief.
I operated him on 26th November, primary suturing somewhere outside.
And there is no fistula post-op.
Okay.
And he's much better. So this wouldn't have been possible if there was no silent endoscopy.
कपाळावर आठ्या कर.
This temporal branch was totally cut off.
तुला काही त्रास आहे का आता सध्या?
By the injury or probably by the primary surgeon who sutured it. And the list still continues further. I mean, look at this patient. She underwent cheek liposuction and ended up post-op day 1 with a parotocele. So fortunately, she landed up with me. We had an MR silogram. We could make out that there's a huge parotocele. I went in, dilated the papilla. Once the dilatation is complete, I passed the scope, went into the paratocele, emptied the paratocele of the turbid contents. As you can see here, I'm aspirating the turbid contents. Now my goal was to reach the proximal duct system, which we found after a lot of effort. We passed a guide wire into the proximal duct system. And over the guide wire, as you can see, this is the normal proximal duct system into the parotid. So this is the proximal duct system. Now I will be withdrawing myself and coming into the area of the paratocele. This is the paratocele. This entire thing is the paratocele. So this is where I had gone proximal to the paratocele. And this is close to the papilla, the stricture which we had dilated initially while going in. And over this we passed in a stent. And sutured it in place. This is pre-op, this is post-op. And great result. It has been more than 8 months now, no further complaints. And the patient is really happy, no scar, and the functioning organ has been preserved. So using silendoscopy techniques, we are causing a paradigm shift from gland excision to no excision, from worrisome scars to no scars and more smiles. So this is very important, I believe. And finally, I would like to say that it is a nearly non-invasive procedure which helps in preserving an organ. It also preserves the function of the organ. It diagnoses as well as treats all salivary gland disorders, is definitely cosmetically advantageous and has very low morbidity. My gratitudes to Professor Kirtani, who has helped me all along, Professor Francis Marshall, from whom I have learned all of this, my parents and my children, my wife, my OT staff, without whom it would not have been possible to go on this journey, and a lot of other activities that I keep on doing, as was mentioned in my introduction, cycling, high altitude mountaineering. And this probably epitomizes what I believe in. It says, Shramena Sarvam Sadhyam. This was seen somewhere in Ladakh, in a godforsaken, lonely place along a roadside. I don't know who did it, but hats off to this person, because we were dead tired when we were approaching this. Another 20 kilometers to go, high up in the mountains, the air is rare. And suddenly this inspired us to finish off the remaining 20 kilometers like it was a cakewalk. So that is what happens in every field in life. So that will happen in silendoscopy, that will happen in any field that you choose to go. I would leave you with this. Thank you.
Yeah, Dr. Shirish Khan is a really excellent lecture and very educative. And you made everything known to us now from unknown. And surgeons feel of seeing blood many a times, but you send a message to everyone without blood also we can feel very happy with the results.
Yes.
Yeah.
A very valid point, sir.
Thank you, Dr. Shirish. It's very elaborative and informative talk that you've given to us. Thank you very much. The video is also very good, and even the range of cases that you showed us. Thank you.
It was a pleasure and it was an honor to be here amongst the august audience. Thank you very much. Thank you, the organizers, for giving me this honor.
Now, I request Dr. M.V. Apparao, HOD of ENT, Gayatri Medical College, Visakhapatnam, to hand over the mementos to our chairpersons, Dr. Kailash Pujari, Head of the Department of Manipal Medical College, and Dr. Singari Prabhakar, Chairman of Singari ENT Hospital, Vijayawada.
Thank you.
Thank you, sir. Next, we have a guest lecture by Dr. E.C. Vinay Kumar on bilateral cochlear implantation. The chairpersons for this session are Dr. G. Harikrishna, Professor, Government ENT Hospital, Visakhapatnam, and Dr. Devraj K., Associate Professor of ENT, Kasturiba Medical College, Manipal. Dr. E.C. Vinay Kumar is a renowned ENT surgeon with over 38 years of work experience. He did his DLO and MS in ENT and is now the head and senior consultant of ENT and head and neck surgery. He worked as an ENT surgeon at MLL Hospital, Madanapalli, Hyderabad in 1982, ENT Clinic Tarnaka, Hyderabad till 1988. He was a visiting consultant at SCR Headquarters Hospital, Hyderabad between 1995 to 2001. At present, he is a senior consultant and head of the Department of ENT and Head and Neck Surgery and coordinator of Apollo Cochlear Implant Clinic, Apollo Hospitals, Hyderabad. He is an expert member of Arogyasri Cochlear Implant Program. He is in the founder member and secretary of Society to Aid the Hearing Impaired. He is on the advisory board of Sri Vidya Center for Special Children. It is a pleasure to have such eminent personality with us to give a lecture on bilateral cochlear implantation.
Yeah, something like that. Yeah. Definitely maintain the price. Yeah, with the elaborative. Me. Yeah, 15 minutes. 30 minutes.
నేను చెప్పలేను బస్ రిజల్ట్గా చెప్పాలంటే సాఫ్ట్వేర్ ఎంప్లాయీ ప్రిపేర్ చేసి రావాలి ఎక్స్పీరియన్స్ ఆఫ్ మై 5 cases అని చెప్పి 7 cases అని చెప్పి లెక్క దిగో లేదు మనోజ్ గారు వేరే స్టార్ట్ చేశారు ఆయన కాకపోతే మనోజ్ గారు స్టార్ట్ చేశారు మనోజ్ గారు ఎవరు मनोज कर ठीक है इनको ये या राइट other one from Karnataka Prahlad sir has come here. I think some implant issue is going on in Chhattisgarh. He doesn't operate in India. He operates in Kenya and Africa and all places. Controversial. I talked to him around 20 minutes regarding why he is not getting the implant here. He commented something on some implant issues. There is nothing like whispers. Whisper here. Our also should be doing. Remaining other things we should not concentrate, especially in this implant. Like all other things, okay, whatever we can do, things are in our control. But these are not in our control. I realized it only when I wanted to enter into it.
There are so many other additional factors.
2010, like that, I also used to be so reluctant and commenting on something nonsense and all this software implant surgery. But 2 or 3 cases I have got it done by myself outside. And somehow some factors has to be changed. Like our commissions are said you should do it by end of the 9 months or 8 months of the baby or 10 months. By before 1 year you do it and you dedicate at least 6-7 years to make the mother as a therapist. That's the only ideal way to get the child back to normalcy or near normalcy. I found out that. So what I understood is it is the lacking of system development to that system. There's a big thing which I think we may not be able to have a good control on that. So what we can do is we are designed to do surgery. We will do the surgery. Remaining other things, government will look after, other people will look after. For software implant program, that rehabilitation issue is not so permanent because of funds availability is not there. Or if the funds did not sanction, what can we do? Yeah. The thing is that we have been lecturing and slaughtering and what is that say? Penetrating their brains of parents and children, parents especially, in such a way that you are the boss for this kind of surgery. The moment the surgery is over, they think that so that is the reason why things are not in our hands in India. Our system is like that. We cannot do anything. And that's what I learned is focusing on our thing, what we can do, what we are supposed to do. Sir, it will be audible to you. Hello.
Hello, good evening.
Hello, sir.
Hello, I'm ready.
Dr. M.P. Manoj was born on 4th April 1962. He did his medicine at Madras University, Chengalpattu Medical College, DLO at Madras Medical College, and MS ENT at Calicut Medical College. He worked as a lecturer and assistant professor of ENT in Trichur and Calicut Medical Colleges from 1990 to 1998. He resigned and started ENT and Head and Neck Surgery Institute with colleagues, forming the first ever attempt in Kerala to start a comprehensive ENT audiology habilitationalist institute in 1998. His team joined MIMS Calicut in 2001 and started Kerala's first cochlear implant program in 2002. Trained at Bionic Ear Research Institute, Melbourne, Australia, Causey Clinic, Béziers, France, Würzburg University ENT Hospital in Germany, and Kidwai Memorial Cancer Hospital, Bangalore, trained in CL endoscopy, laser surgery, and microvascular surgery. He started his own center, Messiark ENT Institute, in 2006, and at present is one of the best equipped ENT hospitals in this part of the world, having high-end equipment including all varieties of lasers, operating microscopes, nerve monitors, HD cameras, and ENT navigation systems, and state-of-art audiology labs and modular operation theaters. He performs a large number of pediatric cochlear implants, over 1,000 now, with a very high proportion of children less than 2 years old, including India's largest bilateral cochlear implant program. He performed India's first bone bridge surgery. Special interest in lateral skull-base surgery, including acoustic neuromas, glomus tumors, and petrous apex lesions, middle ear surgery, stapes surgery, head and neck cancer surgery, CL endoscopy, and dizziness disorders. He devised the structure of Shruti Tarangam Kerala Government Free Pediatric Cochlear Implant Program, arguably India's finest government program. He is a member of Hearing Group, an elite group of 28 centers worldwide engaged in research into otology and otoneurology. He was invited as a speaker, operating faculty in many centers worldwide, and numerous publications in national and international journals. It is our pleasure to have Dr. M.P. Manoj with us for his lecture on building surgical repertoire and handling difficult situations, changing lives. What a good cochlear implant program should aim to achieve.
Hello. Thank you so much. Am I audible?
Yes, sir. You are audible, sir. Good morning, sir.
Good morning.
Good evening, sir.
So I apologize, first of all, for slightly late entry because I was a bit held up. I actually knew about this talk only a few days back, even though I told Aparav. Thanks so much for Aparav and for the South Zone AOI and the Telangana AOI for giving me this opportunity. See, there was, I think Dr. Mohan talked about the challenging situations. And in my topic, there is a slight change. Actually, it is on changing lives. Okay, now the difficult situation part, I think Mohan has already covered. Am I right?
Yes, sir.
Yes. So I am going to talk about what a good cochlear implant program should aim to achieve. Now, first of all, thanks to my team, without who I don't think I'll be giving this talk at all. These include my audiologists, surgeons, habilitationists, and people without whom no cochlear implant program is complete. Now, what do good cochlear implants program have? First of all, a good cochlear implant program should be able to improve outcomes of their patients. They should minimize the adverse events. They should build a hierarchy. I'm sure we know everybody here who gave a talk on cochlear implants would have given this about how to build a hierarchy, how to make sure that you have people below you to take over your program, because your children will be alive and using their implant much long after you're dead and gone. And to build a hierarchy, you need to have a robust team working in tandem. It's not only about having a surgeons, it's about having habilitationists, audiologists, child psychologists, social workers, and etc. Now, what do we call good outcomes? See, when you talk about good outcomes, you should have age-appropriate speech. For example, somebody, when you implant somebody very young, when the child grows up to be 5 years, you should speak like a 5-year-old. And over a period of time, they should have continuous improvement. It's not like hearing improves up till a certain level and it stops, because child is not only going to be a young kid, it's going to be going to school, going to college, going to have an occupation. And over the period of time, he should be able to improve like other children do. They should also have lesser dependence on visual communication. See, some of the things that we as surgeons faced is when we have these children who come to us late, they come to us very commonly now after COVID because they are not able to understand speech because of the mask that you wear. And they should also have spontaneous reactionary speech. The good speech is not just about reciting a poem or saying something. It's about, when you speak to them, they speak back to you in a reactionary manner. They are able to do that all the time, 24/7. It is also about preventing deterioration. Now you can see how these children speak, and they are all very young children who have been implanted extremely young bilaterally.
All hearing is on third mark. May I tell you something? I can hear everything through the cochlear implant. Identify hearing loss before 3 months of age. Every child can speak every day. I'm 9 years old. I am studying in 4th standard in New Gulfington School. Today I'm going to recite a poem by Ruskin Bond. The poem's name.
Okay, now we shall not go into details, but you see how these children speak. They speak exactly like normal children of their ages do. When they are 6 years old or 9 years old, they're able to speak confidently using all the nuances of speech. Now, what are the factors that improve outcomes? See, we have learned about so many things that improve outcomes. We talk about different implants, higher-end implants, but actually there are only a few things that actually improve results. One is the age of implantation. People like me who have been operating for 20 years know that when you implant early, you get results like that. We also know that over a period of time, when you preserve residual hearing, people say that what is the point in preserving residual hearing in children? But if you preserve residual hearing, they're able to use much more of that auditory environment. And to preserve residual hearing, you need to have atraumatic surgery. Bilateral cochlear implantation is always better than unilateral cochlear implantation. See, we have gone through so many years of implantation, and we have gone through different generations of implants. But till today, I cannot say whether X implant is better than Y implant. But we know that bilateral cochlear implantation is definitely better than one, because in the human ear, normal human ear, both ears work together to give sound awareness. When you do one cochlear implant, and we know that no cochlear implant is as good as normal hearing, you need to have two to give the right result. Also, about choosing the right side, we need to know which side is the ideal thing. I shall come to this later. Now, we know that a good speech characteristic is about when you should have auditory system that can regulate parameters like intensity, extension, and frequency. And when you have a hearing impaired individual, they have an unpleasant quality of voice. They strain during speaking. They have high frequency. They have altered breathing pattern, and they have an utterance with excessive variation. This is something that people with bad speech have, and this is directly related to bad hearing. Now, what happens when you implant a child? They tend to have better auditory perception. They have incidental appropriation of oral language, and they have more speech intelligibility and vocal production, which we have already seen before. Now, when you have a hearing impaired individual, see, most people with hearing impaired, they speak in a very high pitched voice. They say, what do you want? Like that. And frequency control is affected when auditory functions are impaired. They tend to have poor laryngeal control. They tend to elevate their larynx when they're speaking. They put in more effort into speaking, and they're not able to control the tension of the vocal cord and subglottic pressure, because most of our hearing is because of, speech is because of auditory feedback. And when that is lost, you tend to do all this. You can see how this child is speaking. Unfortunately, this is in Malayalam, but you can see what is happening. Mother's asking child his name.
അമ്മയുടെ പേര് അച്ഛന്റെ പേരെന്താ?
See, now what is happening is this child is saying something which is totally unintelligible. And that is simply because the child is not able to hear what he is supposed to be hearing. And this day of cochlear implantation, after 25, 30 years after implants have come to India, such a child should never be seen. Now, there have been a lot of papers on this. What do we need for adequate speech reproduction? You need to have audiometric threshold in the normal range for cochlear implant users. If they don't have it, they will definitely not have good speech. You also have a lot of papers which say that what are the characteristics of a child with cochlear implant speech? They should have daily use. They should have long years of CI experience. They should be placed in a good educational system. They should have a good oral mode of communication. And they all say that children who use 2 languages tend to have better education and speech progression than somebody who uses 1 language. So, typically people who are using 1 language, when children are using hearing aids, when people with hearing handicap are using hearing aids, young children, they were told that if you use the hearing aid and if you give therapy, you should give it only in 1 language. And this is completely different from what happens in cochlear implants. You need to have bilingual or maybe trilingual approach. And they also say that the higher the income of the parent, there is a stronger performance, which is one of the reasons why government-funded programs tend to do badly. But this is something that we can always correct. Now you can see what happened to a child when they implanted both ears together at 8 months.
Hi, dears. I'm Marie. Today I'm going to sing a song. Watermelon, watermelon, pineapple, pineapple, chiku, chiku, chiku.
Now, see, this child is studying in a school in Dubai. You can see that there is a slight English-tinged accent. The teacher is an English teacher, which is why he says watermelon rather than watermelon like what Indians speak. Now, this is what happens when you implant them extremely young. Now, look at this bilateral implantee. He makes his own videos.
Hi, I'm Jivan from grade 7. Most of you might know how does the hearing work. Well, in the world, there are people who can't hear. So, to subside the disability of hearing, people use hearing aids or cochlear implants. And I am one of them. What is a cochlear implant? How does it work? A cochlear implant is a small electronic device that electrically stimulates the cochlear nerve. Do you know? The implant has external and internal parts. The external part sits behind the ear. It picks up the sound with the microphone. It then processes the sound and transmits it to the internal part of the implant. The internal part is placed under the skin behind the ear during an outpatient surgery. A thin wire and a small electrode lead to the cochlea, which is part of the inner ear. The wire sends signal to the cochlear nerve, which sends sound information to the brain to produce a hearing sensation. Although normal hearing is not restored with appropriate therapy and practice, the improved hearing experience can mean an increased awareness of sound in the environment, as well as better communication through listening. A cochlear implant may help someone with hearing loss to restore or to improve the ability to hear and understand speech. A cochlear implant is different than a hearing aid. A hearing aid makes the sound louder, but not significantly to improve the speech understanding. When a person struggles to understand speech, even with appropriately fitted hearing aids, a cochlear implant should be considered. When the device is tuned appropriately and the recipient is committed rehabilitation therapy, the cochlear implant can significantly increase the hearing in adults. Cochlear implants in infants and toddlers may help them to listen and learn to speak. The cochlear implant is a lifelong commitment.
Now, you can see how Jeevan made his own video. So the patients in the video, he himself. He had the first implant and then a second implant much later. And he made this video himself. We can see how good his speech is. But if a child has got meningitis, the child is older age of implantation, if they have a poorer aided audiogram, And the lower family income, and if they use sign language, they tend to be negatively associated with quality of speech. They won't be able to speak like the children here. Now, what can the surgeon do to improve his outcome? We know that surgeons should understand that they should prevent auditory deprivation. How do you do it? You will have to implant extremely early. Now, see, look at this child. This girl was actually brought to us when she was 3 or 4 and actually had a lot of residual hearing. We told them to have implantation, but they did not. But instead went for therapy instead, and you can see what her speech is.
Speeches of Pokemons, and it's just my life. And I feel like public now.
How long since you had your implant? How many years now?
The next 4 or 5.
She can actually hear very well, but look at how poor her speech is. And this is her many years later. She is now working in Apple in California.
Hi, my name is Aishwarya. I received a cochlear implant at the age of 10 in Cochlear ENT.
Now, she was implanted only at 10, but even though she had significant residual hearing, she did not become a good speaker simply because we could not implant her young. Her parents were not willing. Now, this is what happens when you implant them late. And this is something we always want to prevent. See, there was a time when people thought that when you do implants, all the residual hearing will go. And that is very wrong. We shall come back to that later. Now, this girl, we implanted the second year much later. She was the one, she sent me a letter saying that she is improving much with the second implant, which happened 16 years later. You will see what happened to her. Look at her. She had residual hearing. She was same as Aishwarya. In fact, they were friends. She was implanted the worst year at 4 years. She had a lot of residual hearing. And then she was implanted the other year, 16 years later. Look at this.
Hi, I'm Rosby, and this video is about my experience of using bilateral cochlear implantation. I did my first implant on my right side when I was 4 years old, and my second implant on my left side when I was 18 years old. And to say this experience, it was really fabulous. It's just that when I was using one side alone, I wasn't realizing what I was missing out. It's like when I did my second implantation, I had like a completion of hearing, and I could manage with both ears if any unpredicted situation, like for example, if you're in a meeting or if you're on a call with someone, suddenly one side goes off, I can manage with the other side. And even when situations like, I suppose when I'm driving, I really love driving, and I had when we were sitting on the right side and driving, and at that time when I was using one side hearing, it was really difficult for me to travel with another person on my left side. It was like I really hated traveling with someone on my left side. I would prefer solo drive, but now when I did my second implantation, it's like I could easily mingle with people. I could easily understand what they were saying on my.
By the way, this girl is now working in a software company in Hyderabad. She's there in Telangana now. Now, see, this is the difference between when you implant early and when you implant late. These two children were actually friends. They were together. They are of the same age, Aishwarya and Roseby. And you can see how much better Roseby's speech is. But if you look at it very critically, even her speech has got errors. It is not like the very young children that we implanted, but still, this is much, much better. At 4 years, she is better only because she had a lot of residual hearing. Normally, if you implant somebody at 4 years, she will never have a speech like this. Now, what do we have to do? See, for us to understand what we have to do, this is for a general opinion. So you should do a autoacoustic emission test, and if they refer or pass, you should explain the methods of surveillance. And if they refer, you have to retest after 1 month. And if they still refer, go for detailed audiological testing. Now, what I want to tell you is that even if people pass OAA-ABR, they should be explained surveillance, because just because they passed doesn't mean that they have normal hearing. Now, these are the tests that are done for hearing. You can do an autoacoustic emission or auditory ABR. The difference between that, this is more expensive, but the autoacoustic emission has got a lot of disadvantages. They need to have a noise-free environment. They will miss auditory neuropathy because OA will be passed, and vaccine midlear fluid will affect results, whereas an ABR is less dependent on auditory environment and will not miss auditory neuropathy dysynchrony, ANSD. So it is ideal to do an automated ABR, but unfortunately, most places have only an OAE. So what do you do? So when somebody fails a newborn screen, you have to roll out a midlear effusion immediately. If the mid-layer effusion is not there, you do a hearing test battery, which includes an OE, tone burst, ABR, and ASSR. If there is a profound hearing loss, you have to immediately image to rule out anomaly, give a hearing aid trial, and there is no benefit, go for a cochlear implant. The time between a failed newborn screen and doing a cochlear implant should be ideally between 4 to 5 months. So which means that when the child is about 6 or 7 months of age, we should take a decision whether implantation has to be done or not. It cannot go on for ages and years and years. But however, if there is serviceable hearing, you give a hearing aid and there is benefit, you have to do an aided audiogram. And if there is no benefit, you have to go for a cochlear implant. But if there is benefit, you have to go for hearing aid and therapy. This is what you do for a children who failed a newborn screen. But however, if there is meningitis, you have to immediately do an MR cochlea. And if there is no meningitis, you need to do a detailed hearing evaluation. These are the risk factors for neonatal hearing loss. See, if there is a significant risk factor for hearing loss, you can do a hearing test battery. They could be profound, they could be severe, they could be mild, or they could be normal. If they are profound, they have to immediately go for imaging, and there is anomaly, severe anomaly, you have to go for auditory brainstem. I'm sure Mohan would have talked about that. There is no anomaly cochlear implant. Severe hearing losses may benefit with hearing aid where they go for hearing aids. No benefit to go for cochlear implant. Mild hearing losses, they have to be observed, retested at regular intervals, and if there is concern, you have to go for a hearing aid. Most people with mild hearing loss may not need a hearing aid at all. If there is meningitis, what do you do? When you get neonatal meningitis, you do hearing testing at 2 weeks. If it is normal, you retest after 1 month, and it's still normal, you don't have to do anything at all. So any meningitis patient should have testing 2 weeks after meningitis and 1 month after. If both the tests are normal, it's very unlikely that the child is going to have meningitis. But however, if it is abnormal, you have to go for MRI, and if there is ossification, you have to go for early CI. We have done CIs at 6 months of age with a meningitis ossification. If there is no ossification, you have to repeat MRI every month. And if there is still no improvement, you have to do early CI, because in meningitis, there is something that happens to the brain that if you implant late, there will be no benefit. But if it is, if you repeat MRI every month and there is no ossification, if the hearing aid can be given, they should be given hearing aid. They don't have to go for cochlear implants if there is aidable hearing. See, this is what happens when you delay implantation meningitis. You look at this cochlea, left side is normal, right side is ossified. There is absolutely nothing that you can do with this cochlea, which is why we say that every time there is meningitis, early MRI, earliest sign of ossification, go ahead and do an implant. Don't wait for the child to become older. What do you do with a child more than 1 year with hearing loss? Do an audiogram. If there is residual hearing, you find out if the aided scores are within the speech banana. If it is yes, hearing aid. And if there is no benefit, you have to implant the Verser ear. I mean, we are talking about profound hearing loss. However, if there is no residual hearing, do imaging and always implant the better ear, which is the reason why we implanted the Verser ear of Roseby. She was having residual hearing, and because the aided scores were not within the speech banana, we implanted the Verser ear first, and much later the better ear. But if there is no residual hearing, you always implant the better ear first. People always ask me, which is the side that we choose? This is back to my old slide, where this is how you decide on which side to implant. Residual hearing, worse ear. No residual hearing, better ear. So this is the selection criteria for residual hearing. As when you have a pure tone thresholds which are normal to mild to moderate hearing loss in the low frequencies, decreasing to a profound hearing loss in the higher frequencies. Typically what we call a ski slope audiogram, and a speed discrimination score of less than 60. These are the type of people that we go for cochlear implant. Now, the additional patient, see, suppose you have somebody with a residual hearing, you need to show that they don't have progression, they should have no autoimmune disease, they should have no malformation of cochlea, and no airborne gap, and no external ear contraindication to using amplification devices. These are the children with the residual hearing you take up for cochlear implantation. Cochlear implantation criteria in young children with residual hearing is much different from those people, adults with residual hearing. See, these are look at this. These are people who we implant. See, the young girl with low frequency hearing, but absolutely no high frequency hearing. These are children that we give a 5-month hearing aid use and then decide that they don't improve because these children all hear a lot of sounds, but because there is no high frequency input, they tend to become worse and they have to go for cochlear implantation. See, look at this. This is what we do. So do cochlear implants in both ears, or if there is no choice, then we go for the right ear. So this is the aided scores. See, look at that. This aided score is always below the speech banana. The speech banana is like that. You need to have high frequency in the region of 10 to 20. If the aided scores don't reach there, these children have to go for cochlear implant. These are the children who actually get into the hands of people who give hearing aids, and they say that some benefit, and later on they kind of plateau. So when you have such a child, what do you do is that when you implant, you have to do implants in a very different way. See, you have actually found out the cochlea, and then you start putting in the electrode gently, one electrode at a time. You take about 1.5 to 2 minutes to insert the implant. Some people say 3 minutes. We take about 2 minutes. You have to see each and every electrode one by one going into the cochlea. Because if you do a very rapid insertion in the wrong place, all residual hearing will be lost. So this is what you do when you have somebody with residual hearing. You can see how slowly, very, very slowly, the electrode is going into the cochlea. I actually counted this nearly 2 minutes. You can say here, 155, 203, and now the last ring is going into the cochlea. So it took about 2 minutes and 10 seconds for the whole electrode to go inside. Now, when you do this, you get very low current levels when you do testing, and that shows that actually a lot of cochlear hassles are left behind. And we also have a hearing preservation calculation. We find that preoperative and postoperative audiograms are generally equal, which shows that a lot of residual hearing is preserved. I shall skip that. This is in Malayalam, which is not very good. Now, this child who was implanted in 2007 has got fantastic speech because there is a lot of residual hearing. See, this is the aided audiogram without the hearing aid. This is the aid with the hearing aid. This is the aided audiogram with the cochlear implant. So when you implant these children, even though they are 7 years old, you still will get fabulous results because they all have a lot of residual hearing. We started doing residual hearing surgery maybe 14, 15 years back. See, look at this child. She's got a lot of residual hearing, but not given a cochlear implant. See, I am asking her name, but she is not actually answering me. She is looking at the mother to get a visual cue. And that is what you have when you, this one, when you have such a lot of hearing and you're given a hearing aid, the hearing aid does not bring the sounds to the auditory spectrum. The child will actually depend a lot on visual cues. This is something that we don't have to have. And if you do an implant for these children very early, they tend to do extremely well. So what should a cochlear implant have? They should have a proven track record of safety and reliability. They should have all the approvals. They should conform to the recommendation of the national agency. They should have highest quality of clinical and technical support and should meet national purchase requirements. See, we have a lot of implants. We have the nucleus, we have the advanced bionics metal. You're all familiar with this. AOICON Neuro is the only implant in the last 20 years to get FDA approval for adults. This is the old Neuralink implant. So it takes so much time to get approval for implant. It's not easy. But and when you have an FDA approval process, it shows that it has been very good and how well it has worked, what are the adverse effects, and it is safe and effective. And once US FDA approval is given, it makes sure that your implant is safe and can be used without fear in a patient. And this is how the new CE regulation is. See, earlier, some implants used to get FDA, but not get CE. But now it is changed. CE has changed. They have got something called MDR, which is called Medical Device Regulations, a very complex process to which you can get approval. It's actually become more difficult than FDA approval to get an MDR approval. So you have a technology assessment. There are a lot of papers to be given and how safe they are. But there are new implants like this, which say a lot of fancy things, but don't have any approval. You have to stay clear of implants like this. Now, when you have a surgical skill to do an implant, what kind of people should do surgery? You should be able to do surgery in difficult situations. You should be able to do things like this, a large posterior temporal artery to remove a paraganglioma. You can see that if you have the skill to do this, you most definitely will have a skill to do a cochlear implant. So an otologic surgeon should have his skills to be top level before attempting to do cochlear implants. It's a wrong thing to say that I did an implant, but I can't do some kinds of ear surgery. That is not right. Only a surgeon with good otological repertoire should be able to do a cochlear implant, because not all cochlear implants are easy. Now, what should ideal team have? They should have adequate experience in advanced otologic surgery. They should have junior surgeons who can be included into the program, at least 2 skilled audiologists, at least 4 habilitations. So 1 surgeon, 2 audiologists, 4 habilitations. That is the team that you should have to do a cochlear implant program. You should also have anesthesiologists who are skilled to give anesthesia in very young children, child psychologists, radiologists who can do imaging and interpret them properly, and a social worker. It is important for a team to have all this. But frankly, not many teams have all this. But at least if you don't have a psychologist or radiologist, you can easily associate with somebody who's got that. But the important thing is that you should work as a team. See, because sometimes when you implant people like this, this is a patient with a blind sac cavity for an extensive cholesteatoma. So when you go back inside again, you have to find out the areas and then find out the cochlea and then cover it off with the bone chips and put an implant. So when such a patient comes with cholesteatoma and profound hearing loss, you should have a skill to do a subtotal petrosectomy. This is what I meant by increasing your surgical skills to do advanced surgery, including cochlear implants. It is not just about finding out the easiest patients to implant. Now, not all implants work all the time. Sometimes you may have to remove an implant. See, look at this. Sometimes ceramic implants fracture, and you may have to go back in again, take it out, and use a second implant. So this is an old implant removed now, and then the new implant insert. So a surgeon must be sure that his patient continues to use an implant for a long period of time, which means that you may have a patient of yours who is coming to your hospital much after you have finished surgery, which is why we always say that you should have enough people below you who reach your skill level or sometimes even above that to make sure that your patients do not suffer 10, 20, 30, 40 years later. Now, we know that if you don't implant, they can have delayed speech and language skills. They can feel bad about themselves, have trouble making friends. And we know that if you implant early, they can actually go back to your normal levels of skills. See, this is the age of intervention. If you intervene early, they reach the normal growth percentage. Even if you have mild to moderate loss, they begin to fall behind in grades. There's severe hearing loss. They struggle after 9th and 10th standard, and they will need support from parents in the school to keep up with normal children. This is something we don't want. See, look at this. This child was brought to us at 1 year with profound hearing loss, went somewhere, and has come to us now at 4 years for cochlear implantation because somebody told them hearing aids will be beneficial. We don't want to see that. We want every small child to have a cochlear implant as early as possible, because if you implant around 12 months of age, they tend to become like normally hearing children. So when you implant children with the age of 2 years or younger, they will have normal communication. They will be understood by strangers. They can go to a normal school. They will become an auditory communicator. Look at this girl. She makes motivational videos. Here she's talking about COVID.
Namaskaram, everybody. Today I'm going to talk about COVID-19. The virus that causes COVID-19 enters people's bodies. When it is on their hand, touches their mouth, nose,
Now, see, this is what we talk about normal speech. See, even adults, this is a man who was a crossover.
I'm Varghese from Kerala.
You will know this man because
I have this hearing loss
he is actually
from
part of the
my
Alukas
school
family.
days, and I was taken.
We the Alukas jewelry that is you see often in Hyderabad and all that. He's the owner of Alukas jewelry. He was very young when I implanted him. He runs a huge business empire, but was profoundly deaf at one time. And look at him, so confident after implantation.
Doctors in those days and asked me to wear hearing aids, which I was not using, or it was not very helpful to me in those days. And my hearing loss was going down as I'm getting old. Then I got married. I came into business, and it was tough for me to manage both the family life and business life and all that. Later on, when I was in 2008, I came to know about this cochlear implantation through the internet and all that. So I decided to do it, and in 2008, I did my implantation.
So you can find out how confident his speech is. He is able to run an empire. And this is another girl who we implanted very early. And look at how confident her speech is.
Hi guys, I'm Malavika. I'm from class 11, science stream. I'm now currently in Kollam. I got the implant at the age of 1.5 years old, like 1 to 2. That time I got the implant. It benefits.
Now, Malavika incidentally also plays the guitar. She was playing the guitar. So people who think that implant users cannot play music, they're very wrong, because they also tend to learn music. Now, what are the research in the future, to come to my last few slides? Because we have only two important predictors. We know that earlier is better, and we know that residual hearing is good. And all the research is happening is around these areas, because nothing has proven to be such an important predictor as age of implantation and residual hearing. So to optimize results, we need to implant early. We need to choose wisely. We need to build your skill set, form a team, look at your bad results, and look at long-term goals. We should not think about what is happening to my patient next month or next week. We should be looking at our children and telling them that 15, 20 years later, they will be achieving what you and I probably cannot achieve. And look at this girl. She's become a doctor now.
Hello, everyone. I'm Tiswana. I'm 21 years old. I was diagnosed with hearing loss.
Now, this girl, she's now doing her MBBS fourth year, and she wants to become an ENT surgeon. And I do not know if you remember this lady. She is the health minister of Kerala, was very famous during the Nipah time, Srimati teacher. And Srimati teacher, when she got medicine, directly called her and blessed her. And this is what happens when you do implantation. I'm sure she will one day become an ENT surgeon. So thank you so much. I hope I have not exceeded my time so much. And once again, thanks Aparao, and thanks South Zone team for giving me this opportunity, for giving a talk on what outcomes are and what a good cochlear implant program should do. Thank you.
Thank you, sir, for such a wonderful overview of how to improve the outcomes in cochlear implant. Apart from sharing the pulse from your vast experience and concise literature review, I think the cherry on the cake was the videos from your patients and their testimony. And definitely, I'm sure all the participants have got inspired by the presentation you just gave us. Thank you.
Thank you. Thank you so much.
Thank you very much, sir, for your wonderful speech regarding earliest possible to implant, and that will be the best way to get a good speech development in children. Thank you very much, sir, for this your video speech, sir. Thank you.
Thank you so much.
Now I request Dr. DRKLN Raju, Associate Professor, Gayatri Medical College, Visakhapatnam, to hand over the mementos to the chairpersons of this session, Dr. G. Harikrishna, Professor, Government ENT Hospital, Visakhapatnam, and Dr. Devraj K., Associate Professor of ENT, Kasturiba Medical College, Manipal. Thank you, sir. Now we have a guest lecture by Dr. Baya Srinivasa Rao on tips to beginners for a successful cochlear implant program. The chairpersons of this session are Dr. P.B. Kameshwar Rao, Chairman, Sindhura ENT Hospital, Srikakulam, and Dr. S. Ramesh, Associate Professor, AIMS, Mangalagiri. Dr. Baya Srinivasa Rao is one of the best ENT doctors. He completed his MBBS degree from Andhra Medical College in 1980 and got his MS ENT degree from Postgraduate Institute of Medical Education and Research, Chandigarh in 1985. Dr. Baya Srinivasa Rao has 35 years of experience and wide professional knowledge in all aspects of ENT surgeries and treatments, mainly in cochlear implant treatments. He was trained in cochlear implant surgery at Memorial Hermann Hospital, Houston, USA. He was the first surgeon to start cochlear implant surgery in combined state of AP in the coastal belt and Rayalaseema. He received extensive training in implant surgeries from Sydney, Poland, and Zurich. He has attended many national and international conferences all over the world. It is a pleasure to have Dr. Baya Srinivasa Rao Garu for the guest lecture on tips for beginners for a successful cochlear implant program.
Hello. Hello, good evening, everybody. Am I audible?
We can hear you, sir.
Yeah, please. Good evening, everybody. Thanks to the organizers for giving me this opportunity to talk about tips to the beginners in cochlear implant surgery. That is today's my lecture. One thing everybody should know is cochlear implant has lifetime maintenance. It is not a single day business. It has a lifetime implant maintenance. You should educate the parents of the implantees that you should be ready to provide minimum of 25,000 rupees every year. That is a recurring expenditure to maintain the implant forever. So if we are doing implant at the earliest stage, in his lifetime, he may require a second implant because only the internal implant warranty is 10 years, but he may require a second implant after some time. So parents should be ready to spend minimum of 25,000 every year. And also educate patients and parents to give preoperative speech therapy that is very imminent, and also fitting of the hearing aid is most important. So advise parents to use the hearing aid in an unoperated ear also. Though he is implanted one side, there is every chance the child may go for implantation in another ear in future. Also educate the parents that audiovariable therapy post-operative does not end in 1 or 2 years. It may take more than 2 years. It all depends upon the child's capacity and mother's sincerity. So very important thing before surgery is, this is all I'm telling only for the beginners, not the implantees, the implant surgeons who are doing surgery. So those who are interested to start the program and the beginners, this is very important. So advise complete immunization till date, and especially child is advised to take immunization like pneumococcus and also H influenza a few weeks before surgery. So they are the common pathogens in the middle ear. So child is going to get repeated ear infections. These are the common pathogens. But in very few cases, there may be tegmen absent, tegmen tympanate, tegmen mastoid may be absent. If you give good immunization, there will not be any problem in the implantees. Also very important, preoperatively, you check, you examine all implant surgeons, not the assistants, examine the ears first, see for any wax. So give wax dissolvents remove the wax and look for tympanic membrane, whether it is normal or not. If there is any perforation, don't go, repair it. And if there is a fluid in the middle ear, give a conservative treatment and wait. If there is no response, put a grommet. And till ear is dry, don't do cochlear implant. Once ear becomes dry, go for cochlear implantation. Another common feature we across is because we are doing in government programs, all children below 5 years. Even in central government program, we are doing below 5 years. So these children, most of the children will have adenoid enlargement. That is a lymphoid aggregates in the nasopharynx. If they block of lymphoid aggregates more than 50 to 60%, they will have mouth breathing. So once, if you don't remove the adenoid, if you do a cochlear implant, the child will be listening to the breath sounds instead of the speech. So there may be delay in speech. If you don't do adenoidectomy, they get confused with the normal sounds and the breath sounds. Always do, because so if you are doing an implant in 2-year-old child, so adenoid, if it is more, I think you try to do coblation technique because it is a bloodless technique and the child will not lose any blood. Also, we see in most of the patients, there is seborrheic dermatitis. We admit the children one day before surgery and we ask them to shave the head. So once you see, we shave off the hair, now you see the children like this, that you see a few of the cases, seborrheic dermatitis, scalp infections. So advise all the children preoperatively to go for ketoconazole shampoo at least for 3 days. Also advise to go for good antibiotic prior to the surgery and also antihistaminic before surgery. That will solve all the problems. There will not be any delay preoperatively. Radial is very important, very, very important for selecting patients. So for beginners. So radiology, you take HRCT temporal bone, MRI. So HRCT temporal bone, what you look for is to look for pneumatization of the mastoid. So most of the children we are doing below 2 years or below 5 years, there may be hypopneumatization. Be careful while opening the mastoids in hypopneumatized patients. There may be a small cavity, mastoid cavity. Also look for high riding jugular bulb. If there is, I will show you that picture later. Also look for any aqueduct of the cochlea, vestibular aqueduct, endolymphatic sacs. They are the patients, they may develop perilimb pressure during surgery. So you should be careful. You should select those patients. You should see preoperatively. You should assess preoperatively, be ready for treatment of the CS pressure during surgery. And in CT scan also, you have to see any anomaly of the cochlea and also rotation of the cochlea. So most of our children in our Andhra Pradesh in coastal belt, we are seeing a rotation of the cochlea. Previously, we were not concentrating on the rotation of the cochlea because we are doing cochleostomy procedures. Once we do a post-implant, you see the promontory, you are making a cochleostomy. Nowadays, we are following the round window approach. So once the round window approach is seen, so we are now facing a rotation problem. We are seeing more rotation problems, probably some anatomical abnormality in the skulls of our coastal belt. That's what we have noticed. And in CT scan also, you look for any ossification. Especially this is very common. So post-meningitis children, post-encephalitis children may have ossification. Initially, there will be membranous ossification followed by ossification, bony ossification. CT scan, you can find bony ossification. Sometimes, if there is no bony ossification, so you don't think that post-meningitis child, there is no ossification, then look for MRI. And MRI shows clearly there is a membranous ossification. So membranous ossification is there if it is in initial stage. What I advise in all post-meningitis, post-encephalitis children is, even if they don't have money, go for a dummy electrode, open the mastoid cavity, open the cochlea, and keep a dummy electrode, and wait for your financial status, then go for cochlear implantation. So if there is a membranous ossification, mostly it starts in the basal turn near the round window. So then you can select where to open the cochlea. Suppose if it is near to the round window, so you can make a cochleostomy just over the promontory, distal to that ossification. Also, MRI, what findings you see is, see the nerves, whether the nerve is present or not. So you can see here the 4 nerves. This is facial nerve, and cochlear nerve, superior vestibular nerve and inferior vestibular nerve. So if the nerve is okay, go ahead because you'll have good prognosis. If the nerve is thin or hypoplastic, you have to explain to the parents that the results may not be very good. So if there is nerve is absent, it is a straight case for brainstem implant. And I already told you about this ossification. Look for membrane ossification. Also see the length of the cochlear tube so that you can select the electrode which you want before surgery. See, this is a mundane, some of the common cases, anomalies, we face in regular practices. Very common thing is Mondini deformity. So in the Mondini deformity, you have membranous labyrinth and bony labyrinth is developed only for 1.5 ton. So the rest is there is a partition deficiency of there will not be any development of osseous spiral lamina. So there is a partition or defect will be there. So there will be 1.5 ton. In those cases, you have to select a short electrode. And also be ready. You may face other anomalies. Something like perilimb gush you may encounter. I was talking about high reading jugular bulb. You can see here right side there is a high reading jugular bulb. In these cases, and be prepared that jugular bulb may be high in the mesotympanum, in the hypotympanum. It may reach up to mesotympanum. So you get mentally prepared for implantation in these cases. In this case, you have a high reading jugular bulb right side and left side there is no high reading jugular bulb. In this case, I select left ear if it is a unilateral implantee. I was talking about ossified cochlea. So you can see in the right side, clear ossification, left side normal cochlea. This is a basal turn and the first turn. So most of the cases, post meningitis cases, they develop ossification. So before that, you can see the membrane ossification by MRI. So another thing you can see, there is a common cavity. You can see right ear and left ear. But there is no development of membranous labyrinth. You have a common cavity. There is ossified, bony labyrinth is there, but membranous labyrinth is absent. So this is a common cavity. You can see a bony labyrinth. There is no partition. There is no separate vestibule, saccule, semicircular canals, and cochlea. Michael deformity. So in this case, you can see there is no development of the membranous labyrinth and the bony labyrinth. Totally, it is absent. This is a straight case for cochlear, brainstem implant. Cochlear aqueduct. See, this is a duct which is present between the scala tympani of the cochlea near to the round window, that it connects to the subarachnoid space or the petrous bone, subarachnoid space. Usually it obliterates by birth. If it is present, keep ready and be prepared for perilymph gush during cochlear implantation. Once you open the round window membrane or the cochleostomy you make, you will see the gush. See, in this case, I'm showing a case where you have a perilymph gusher. So CT scan showed there is a perilymph gusher. We are mentally prepared. We told our anesthetist to be prepared, and we asked them to reduce intracerebral pressure. We have elevated this one. In this perilymph gusher, don't be panicking. And wait till the gush comes down. Now the electrode is put into the round window, and the only treatment is tight package around the cochleostomy or the round window, around the electrode with connective tissue. If necessary, you can use tissue glue. Here you can see this is tightly packed around the round window. Now the gel foam is packed around the electrode. Now the posterior implant is being packed with muslin later. So almost there is no CSF leak. In these cases, advise the patients post-operatively Diamox at least for few days to reduce intracerebral pressure. We had a case where we operated. We tried to manage perilymph gush during surgery. We tried a connective tissue. Initial days when we started the program. So the external dressing was becoming wet, and we waited 5-6 days. There was no response. Then we had to do lumbar puncture. We had drawn about 50 to 100 cc of cerebrospinal fluid. Then it stopped. So don't hesitate taking lumbar puncture and remove and see that perilum pressure should not be there. For any successful cochlear implant program, strict aseptic precautions is a must, imminent. So you do very good aseptic precautions. If you have a laminar theater, use it. Otherwise, good aseptic precautions you maintain in the theater to have a good cochlear implantation and not to have any complications post-operatively. So I want to talk about the two techniques. See, most of our surgeons in India, we follow posterior tympanotomy, post-auricular approach. And second is a varia technique. Few of the surgeons, they are doing varia technique. The incision here is the posterior oral approach, posterior tympanotomy technique. The incision should be long enough to have an adequate exposure. That is, length is not the criteria. It should be long enough to have a good exposure. And also, the incision should be, at least incision site should be 15 millimeters behind the implant, so that the BTA processor will not overlap of the implant. And also, once you keep implant anterior inferior end of the implant and BTA processor, there should be a gap of 10 millimeters. You can very well see here, the incision is anterior, post-oral incision. There is double breasting of incision. So incision, skin and subcutaneous tissue is post-oral anterior, and this is a muscular periasteral flap incision, which is posterior. These incisions are not overlapping each other. So that you have a very good protection over the implant. Even one incision goes off, other incision protects your implant. This is a varia incision. Varia incision is nothing but an extended endoral incision. You have endoral incision here, and there is an inverted C incision that is connected to endoral incision or the squamous temporal bone. So for flap elevation, always better to use cold steel technique. So if necessary, if you want to use, cautery, preferable thing is bipolar. So to have reduced tissue necrosis. So we always prefer cold steel or bipolar technique. And thickness of the flap is very, very important. So the flap thickness should be between 5 to 6 millimeters. What is the reason? So the reason is it should be ideal to protect your implant, and it should be ideal to prevent flap breakdown. Suppose if it is 4 millimeters, 3 millimeters, there is every chance that flap may break down. If it is very thick, there will be signal transmission, problem will be there. So ideal thing is 5 to 6 millimeters necessary for very good magnetic hold, and it is very ideal for optimal signal transmission. So nowadays, we are using the BTA processors. So for best to, for all these processors, for latest processors, the thickness should be 5 to 6 millimeters. During surgery, you may encounter emissary vein bleed, apart from regular bleed. So it doesn't stop. So don't be panicking. What you do is try to do with a bipolar, try to control it. If it is not controlled, then go with a diamond burr. Try to reduce the bleed with the diamond burr. If it doesn't subside, go for a soft tissue. Even if there is no response with the soft tissue tuck, you do a bone wax and come out. So that is the only way to come out of this emissary vein bleed, and keep ready at least some blood. So children, even losing more than 10% of the blood, they will have a problem. So nowadays, surgeons are not doing implant bed, and they are not fixing, because the senior surgeons, they are making a small periasteral flap, they're pushing the implant in the pocket. So for beginners, I advise always to use a good implant bed and a good bed for a good tunnel, not for a electrode array to exit. So the implant bed should not be shallow. Try to do minimum 2 to 3 millimeters, unless the dura is very superficial. So try to make 2 to 3 millimeters implant bed, and the margin of the bed should be right angles, so that implant doesn't get slipped out of this pocket. So, and You can see here tie holes. Initially, we were using securing implant is very, very important for beginners. So initially we were using tie holes with Prolene. Prolene has some problems. In the long term, we observed some Prolene because of the sharp edges. It may produce some problem, granulomas, all those things. We found softer sutures are much better. Nowadays, we are using Vicryl. For any posterior tympanotomy technique for a beginner, three silent important features is don't be very hurry. So it is always to have a good optics. Select a good microscope. Don't get compromised with my good optics. And also be slow. Don't be very, fast. Make slow drilling, and irrigation is important. Irrigation is very important to prevent any facial paresis or paralysis. So it is always better to have a good optics and slow. Don't be very fast and do good irrigation. It will solve your purpose. And you can see here the posterior tympanotomy boundaries, all of you know. So this is apex is at the short process of the incus. The anterior boundary is the cardia tympana, posterior boundary is the facial nerve. So finally, what I want to tell is be slow, don't be hasty, and try to do with diamond burr and very good irrigation. This is after doing a posterior tympanotomy, you can see the round window opening. So approaches. So electrode insertion through the cochleosmia or trans-round window. So till 1 decade back, most of our surgeons across the globe, they were doing cochleosmia. For the last 1 decade, most of the surgeons are preferring to. So you can see here the cochleosmia. Cochleosmia is being made anterior inferior to the round window membrane. So here you can see the trans-round window approach. So most of the surgeons recently, they are preferring round window. Why? Because so round window, you are 100% sure that you are in the scala tympani. So you are not 100% sure that here in cochleosmia, you are in scala tympani. You may be 95, 99%, 1% chance you may be in scala vestibuli. So this is you are 100% sure in round window approach, you are in the scala tympani. So in future, you are not disturbing the anatomy of the cochlea, bony cochlea. So in future, there may be very good implant, maybe there. So where you are not interfering with the anatomy, since the normal anatomy is preserved, you can always go for a higher end implant, which can be discovered in future. Coming to the varia, this is suprameatal well that is being done. Here the underl incision is given. So the skin is posterior base and periastial flap is anterior base. See, tympanomeatal flap is elevated. Here the varia bar is being used. So varia tunnel. So a very important thing is, similarly, just like posterior tympanotomy, you should have very good irrigation in this, and there should be to and fro movement of the handpiece. And always use irrigate. And also point of entry should be around 10 to 11 o'clock. Point of exit should be at 9 o'clock to have a good transcanal tunnel. So varia techniques, what is varia technique? It's nothing but a non-mastectomy technique where endarl incision is used for cochleostomy and transcanal tunnel is done parallel to the posterior canal wall, where the electrode passes through the transcanal tunnel into the middle ear. So you can see this varia. This is a specially designed drill with a guard. It should be very steady guard. Suppose if it is not a steady guard, there is a chance of splaying while you are making a tunnel. So that may hit facial nerve. So the drill bit which it is used is 1.4 millimeters. So you are making a tunnel of 1.4 millimeters, and the distance between the posterior canal wall, that is guard, and the tunnel is around 2 millimeters. So if you calculate 1.4 millimeters tunnel And between the guard and this, around 0.6 millimeters posterior canal wall is there. So you should be very careful while doing varia to maintain the integrity of the posterior canal wall. If it is very thin, if it is destroyed, you have to reconstruct with the cartilage. Otherwise, there is a very chance electrode may migrate. So advantages of posterior implant means. So this is just for academic purpose. The surgeons who like posterior implant means they do all the cases, all complicated cases, all anatomical abnormal cases, rotated cochleas in posterior implant may also. So for theoretical purpose, I tell you about this. Advantages is it is very easy in the normal cochlea with cellular mastoid. So in narrow external canal, see, in varia technique, if there is a narrow external canal, it is very difficult to raise tympanomeatal flap. So it is good in narrow external canals. And in varia techniques, there is a very chance for the beginners while elevating the tympanomeatal flap, you have perforations. So it doesn't happen in posterior tympanotomy. So it may be a little difficult in hypocellular mastoid and the small facial recess. Varia technique is a wide angle, wide axis. So you are elevating posterior meatal flap. So just like stapedectomy, you can see everything. So it is easy for the surgeons who do varia technique. This it is very good for any ossifications and rotated cochleas and abnormal cochleas. And cons are any poor irrigation while making a tunnel in the posterior canal wall, transcanal tunnel can cause heat and give a facial paresis. And for the beginners, elevating tympanomeatal flap, even for the stapedectomy or those, they may get a perforations. If there is a perforation, repair there itself with a facial graft. And transrondon insertion, what I feel in varia technique is a little bit difficult. So when you are making a parallel transcanal tunnel parallel to the posterior canal wall, the electrode through the transcanal tunnel directly enters over the level of promontory. So the round window is behind that promontory. So you have to make a turn of the tip of the electrode to posterior aspect to go through the trans round window. So it will be a little bit difficult. So what I found is varia technique cochleasm is better than round window approach. And if the transcanal depth is less, what I said is if it is less than 5 millimeters, there is every chance there is possibility of canal descent. You have to reconstruct, and there is a chance of migration of electrode if you don't reconstruct the posterior canal wall. This is a post-op X-ray. You can see the electrodes going to the basal turn and first turn. This is CIREST, so nucleus electrode that was going to the first basal turn and part of the first turn, second turn. So facial nerve, once it gets exposed in the limited facial recess, don't be panicky. So there is a facial nerve, don't injure it much. Unless you injure the fibers, nothing happens. Even if the facial sheath is a little bit damaged, don't bother. So you do a very good irrigation. Only precaution you should take is while you're making a cochleostomy or round window opening, when the facial nerve is exposed, try not to rest the drill bit over the facial race. It does not lie over it. So there will not be any pressure over it. So there will not be any problem unless, and try to pack muscle between the electrode and the facial nerve. There should not be any direct communication between the nerve and the electrode. So otherwise there will be a stimulation of the nerve. The issues which you see post-operative nowadays we are seeing is a few cases I just want to tell you. See, after surgery, so we give external processor with magnet. By default, the company send number 2, number 3 magnets. So if you are doing a surgery for a child below 1 year, around 2 years, if you use a 2 magnet, there is every chance there may be ulceration. Don't be panicking. What you do is remove the external processor, apply topical antibiotic cream, and also a course of antibiotics. Wait till this ulcer heals off. Then switch over to the lower magnet. If you are using 2 magnet, you go for 1 or 0.5 magnet and try to use a soft pad between the magnet, between the processor and or the scalp. If you use a soft pad, so it will subside. And what we observed, we are doing all BPL patients because in our extended patients, the care of the scalp after surgery is not good. The parents are not taking good care of the scalp. So they are not giving regular head baths and shampoo baths. So those patients, if they scratch, they are going to get furuncles, follicles. Once the follicles or furuncles are there, treat it. So if you don't treat, definitely it is going to produce local cellulitis, abscess formation. It can spread over the implant. So this is one patient from your Walter area where we did surgery. After 6 months, this patient came with a follicle. Then we gave antibiotic, he went home. He did not use the medicines. Later, he came with an abscess. Ultimately, we had to remove the implant. So it is very important for the parents to tell about the maintenance of the scalp even after surgery. Coming to the complications, see, we classify them into minor and major complications. Minor complications are the complications which occur immediately after surgery. Usually they subside on their own in few days or in 1 or 2 weeks. So I said also the magnet problem. Suppose if you are keeping a lower magnet, doesn't happen. Super infections usually doesn't happen. If you give a good prophylactic antibiotics preoperatively and perioperatively, postoperatively for 1 week, it doesn't happen. So perforations, if there is a perforation during surgery, you immediately treat. So in adult CA patients, what we see is a tinnitus and vestibular. If there is a tinnitus preoperatively in adult CA patients, it may aggravate postoperatively first few days. Slowly it subsides. Once the patient starts wearing the cochlear implant, it has a masking effect and tinnitus problem will be solved. Coming to the adult CA patients, in 30% of the adult CA patients, you have vestibular problems, vertigo, giddiness. They appear for first 1 to 5 days. Slowly they disappear over a period 2 to 3 weeks with the vestibular treatment. If there is a vestibular problem in children, they manifest as a repeated vomitings postoperatively 1 or 2 days. Usually they subside. Facial paralysis, as I said, you can always avoid by very good irrigation, not to touch the facial nerve while you are making the shaft of the drill bit. If it doesn't rest on the facial nerve, nothing will happen. If there is a neuropraxia, just give postoperative light steroids for 2 weeks. It may resolve in 2 to 3 weeks. So taste problems, very, very rare problem. So altered taste may happen in posterior tympanotomy patients. So usually they subside on their own in 2 to 3 weeks. Coming to the major complications, electrode extrusion. So it very rarely happens. So usually it appears after a few years, the electrode may slip off out of cochleostomy or the round window. And if the posterior canal wall is descent, if there is a tympanic membrane perforation, they get extruded into the external artery canal. So you open it and reconstruct the posterior canal wall, reconstruct the tympanic membrane, and place it back again. So this I will show with a diagram later. Electrode tip fold over, it is very, very rare complications. In some cases, there may be electrode tip folded will be there. It involves only very few electrodes. So it is can be avoided if you take a perioperative X-ray. Suppose if you don't take a perioperative X-ray, postoperatively see this tip fold over. If there are few electrodes are involved, just leave it, switch off those electrodes. If many electrodes are involved, again open it, remove it, and put the electrode back into the cochlea. And electrode misplacement. So it is very rare. While making on tunnel, cochleostomy, sometimes we may go into false track in a hypotympanic cells. So perioperative X-ray will avoid this problem. Device failure. What is device failure? If 50% of the electrodes does not work, we call it as a device failure. It may be due to the mechanical trauma. So implant company will not give any warranty for traumas. So if there is a device failure, if without any trauma, so we have a warranty of 10 years, they will replace the implant. So we can remove the implant, we can put it back. And so this is a nerve stimulation. This is a diagrammatic representation. It is very rare. You can see here the electrode. This is the basal turn of the cochlea and the superior aspect. This is a horizontal facial nerve and the partition, bony partition between the labyrinthine portion of the facial nerve and the superior aspect of the basal turn. If it is absent, so there will be direct stimulation of the facial nerve once you switch on. So there will be facial nerve twitchings. So treatment is only the flagging of these 2-3 electrodes. Suppose many electrodes are involved, you have to remove this electrode. Try to use a perimodular electrode. This is outer wall electrode. Sometimes this outer wall electrode, CAREST, that pressure effect that bone may resolve, it can produce facial nerve stimulations. So treatment is flagging off few electrodes. If there are many electrodes, use a perimodular electrode. Nightmare for any cochlear implant surgeon is a biofilm. So biofilm, what is biofilm? It's nothing but this is a complex bacterial colonies that are attached to extracellular polymer substances. This complex bacterial colonies, they adhere to the crevices of the implant, where they grow there. So the bacteria, the common bacteria are methicillin-resistant Staphylococcus aureus and Pseudomonas. Here, for the bacteria, the nutrition oxygen demand is very less in biofilm, and also antibiotic resistance to the resident bacteria is very high. So once there is a biofilm, so unnecessary trials, what we used to do initially, open it, debride the tissue, all infected tissue, and give antibiotics. After 1 month, 2 months, they come with the same problem. Ultimately, we have to remove the tube. So remove the implant. So biofilm is a havoc in cochlear implant post-operative complication. So it can be avoided by preoperative aseptic sterilizer techniques. Only thing we can avoid it. This is one case. So all the children are BPL patients. So there is a roadside accident. So the patient was admitted in ICU. So they came after 10 days. They were applying the antibiotic cream. So what we thought is we will just try. So we excised this surrounding tissue. We made a scalp flap out. This just wanted to take a chance. Luckily, it was positive. So we made a scalp flap and we relocated this implant bed. We kept it down and we made a scalp flap. So you can see that this scalp flap is rotated here over the implant, and this raw area is with split thickness skin graft. Only problem with this is the hair here is a normal scalp hair. There will be baldness in this. It looks very ugly. So we take a chance. Luckily, implant worked. That is only lucky to our hospital. So very rarely we'll see hydrocephalus patients where they had a VP shunts. So you can always do in VP shunts also. Only thing is keep the implant behind the shunt. There will not be any problem. Don't disturb this VP shunt. So last but not least, if there is a external pressure, so external injury, this electrode on the magnet can get slipped off the silicon pouch. So how do you identify? The patient, they say the external processor will not adhere to the implant, internal implant magnet. So instead of getting adherence, adhere to this area, it will adhere this way. So there will be reversal of this external processor. If you take an X-ray, you'll see this is a slippage of the magnet displacement. So what you do is give a small incision, put it back, the problem is solved. Once again, thank you for patiently hearing my talk. Especially, this is only for youngsters. So if you take all these precautions, you will not face much problems. Thank you.
Thank you so much, sir, for such a wonderful lecture. I request Dr. GSP Krishnamurthy, Senior ENT Consultant, onto the desk to give mementos to the chairpersons of the session, Dr. PB Kameshwar Rao, Chairman, Sindhura ENT Hospitals, Srikakulam, and Dr. S. Ramesh, Associate Professor, AIMS Mangalgiri.
Hello.
Thank you, sir. As the scientific sessions for the day have neared the end, I thank all the dignitaries for their presence in the conference, the speakers for their informative and captive lectures, and the delegates for their enthusiastic participation. Tomorrow's sessions begin at 8 a.m. with physical and virtual poster presentations by postgraduates in Hall B, third floor of the same building. Scientific sessions begin at 9 a.m. in Hall A, here where we are seated right now, and the consultant, both senior and junior consultant papers and video presentations will begin at 9:30 in Hall C. Hoping there were a multitude of takeaway points from today's enlightening scientific sessions, let us all gather here tomorrow with enhanced eagerness and the same zeal to learn and relearn. Your participation is what makes this conference a grand success. We are looking forward to the next 2 days of the 16 South Zone Conference as much as you all are. May you all have a good evening, and I once again thank all the delegates for their participation.
Recording stopped.